Good morning, everyone. So that video was made at last year's conference in Columbus, Ohio, and many of you were part of it. So thank you so much for taking the time to listen to it. We're very proud of that video. So, wow, I'm looking around the room and I'm just amazed. We keep growing and this conference continues to get bigger. I have the incredible honor of opening today for the 2023 Family and Professional SCN2A conference. My name is Leah Myers, but I'm also probably better known as Ben's mom. And most of you probably have met Ben, and if you haven't, you should get a Ben hug because he's famous for them. I am one of the founders and the executive director for the foundation. In 2013, after an almost 2-year battle with infantile spasms, my son Ben was diagnosed with a change in his SCN2A gene. My husband, Brant, and I experienced all those frantic feelings that most of you in this room are all too familiar with, that come with receiving a life-altering serious diagnosis like SCN2A. And at that time, there was very, very little known about this gene and what happens when it's changed. So on top of dealing with the grief that our son's life was now going to look very, very different than what we had dreamed, we were also impacted by the utter despair of being among the only ones. We were very alone. But that's changed. This is the foundation's 5th conference. We've come a really long way since that really lonely day in 2013. Our Facebook support group now supports over 1,200 families. We started that in 2013, right after Ben was diagnosed. And in 2015, we got our 501c3 status and we started fundraising for a cure. Since then, we've awarded over $3 million in research grants for SCN2A. We've initiated programs to support all of our families. We've collaborated with researchers and clinicians to work harder and faster towards cures. We've advocated for funding and awareness on state, federal, and international levels. And we've officially declared February 24th as International SCN2A Awareness Day. And the list of our accomplishments is far too long, and they're only letting me stay up here for 10 minutes. So I'm going to just leave you with those highlights, and Jenny is going to touch on some more. I'm really in awe as I look around this room, all of you that are here today, and I know it takes a lot of effort to be here. So thank you for coming, and thanks for taking the time to learn and grow with us. Can you stand up for me if you traveled a good distance to be here today? Okay, so pretty much almost everybody in the room. Okay, stay standing if you came by plane. Everyone else can sit down. Stay standing if you came from outside of the US. Okay, oh my goodness. Okay, so we have United Kingdom, South Korea, Canada, Ukraine, Poland, Spain. We have Australia. What am I missing here? Dubai. Any other countries that I've missed? Yeah. India. Wow, thank you so much. For those of you that are not in person this year, it's okay. We're thrilled to have you. And I'm going to have everyone turn around and wave to our virtual attendees. They're over there in the corner behind that AV table. We're really happy you're here, and we're going to take good care of you. Our final head count is 325 in-person registrants, over 100 virtual. No pressure at all. Somehow our amazing team of volunteers, board members, and staff have been able to accommodate everyone. And I hope that you feel the love that went into every single detail of this conference and you feel taken care of. And if you haven't, come see me. I will make sure that you're taken care of. So this is our 5th conference. Like I said, we had Chicago in 2016, Delaware in 2017, Seattle in 2019. Last year was Columbus, Ohio. This year, please don't miss the group picture. It's going to be right at 4:15, and it's going to be announced. We haven't decided 100% where we're going to do it, but we'd like everyone in it. So please meet us. I'm going to mention something. We're very, very honored this year to have 3 special families who are participating in the conference who have lost their SCN2A warrior. They're missing today. These brave families have decided that they're going to continue to fight alongside us for a cure. And we're so proud to advocate with them. As a way of reminding us all to be respectful and empathetic of each and every individual in here, we have included a sign of solidarity on their name tags. So just take a notice. All right. If you're not sick of seeing my email pop up in your inbox, thank you. I've been sending a lot of emails talking about the research opportunities that are available at this conference. I've never met a group of people that are so ready and willing to participate in research to move things forward. Okay, I just got the 2-minute warning. So we have a lot of room assignments. If you need help finding a room, then just go to the registration desk and we'll let you know. With this large of a meeting, we have to stay on time, which is Mary's job this morning. And we're running a really tight ship. So open your folders. You should have an agenda, which we're going to follow to the minute. If you don't have an agenda, get one at the registration table. I've also been told several of you haven't registered yet. So please go ahead out there, get your name badges, register, get all the goodies. If you're a picture taker, take pictures. There's a QR code in your folder. There's also a QR code right here. You can scan and add your pictures to it. We'd really like your help in capturing the event. You'll notice that there's index cards on your tables. Those are for you to write your questions down. Write them down as they go. So as each presenter talks, write your questions down. And at the end, after all the presenters come back up here, we're going to collect your questions and bring them up for the presenters to answer. Hold your applause. You do not need to clap for each presenter. They know that they're loved and they will be okay. So all sessions will be right here in the ballroom. The 5th floor has all of the kids' rooms. We have a playroom with a schedule of activities. We have pet therapy, music therapy, toys, coloring. Let your kids go wild in there. That's their space. They're welcome in here as well. But if they get loud in true SCN2A spirit, like my son would, just step out and let other people listen because it's hard sometimes. All meals will be here in the foyer and the poolside courtyard. So if you'd like to take a break from being indoors and get some sunlight, right on the 5th floor outside of the pool area, we've reserved that courtyard area and there will be food up there as well. So feel free to eat either place. And I'm going to take a moment to thank our sponsors. None of this would be possible without their support, and they are set up along the edges of the room and then also out here in the foyer. Take a minute to go meet them, thank them, and tell them your story because they want to learn as well. And I'm going to take this opportunity to embarrass a few people. And this also would not be possible without the help that I've had for planning this conference. Pam, do you mind standing up? Right there. Pam has planned our aquarium night. Carla, are you in here? Carla's in the back waving. Carla has planned everything. Amanda Gale's right here. Amanda has helped us with our Friday dance party dinner. Thank you all so much. Okay, let's see. And the very last thing I've got is to introduce and turn this over to my dear friend, fellow advocate, warrior mom, and the foundation's board chair. Jenny Burke has led us through an insane amount of growth in this last couple of years, and she's done it with ease and grace. We are all very lucky to have her at the wheel. Jenny?
Thanks. Good morning. Thank you, Leah, for the kind introduction. I'm always honored and humbled to be in Leah's company. None of us in this room would be here if it weren't for that amazing warrior mom who is steadily charting the course towards cure for our kids. And of course, co-founder Carla Forbes in the back, who's now our administrative manager. She keeps us afloat behind the scenes and loves to greet new families. All right, let's see if I can. Speaking of families, as you know, families is part of our name for good reason. SCN2A related disorders affect the whole family. Last year, I posted that cute pic of my kids when they were little. I was in denial that they're all grown up, but now I can't ignore it. Early June, Alex, who's over there, graduated from high school, aged out of high school at age 22. And then a few weeks later, his older brother, Sam, became a firefighter EMT. And I'm pretty sure it's because of all the times he had to answer the door for the ambulance when he was little. And I wouldn't be here without the unwavering support and love of my wonderful husband, Mike. So pat him on the back when you see him. In 2021, as most of you know, we earned a seat at the table with the Chan Zuckerberg Initiative's Rare as One project. And while they're investing $600,000 over 3 years in our foundation, they also give us access to an incredible team of advisors and trainers with expertise in science, technology, fundraising, just about everything a rare disease nonprofit needs to thrive. Receiving that grant coincided with our last round of strategic planning, which is focusing our efforts through 2025. Guided by surveys filled out by all of you, our community stakeholders, thank you. The work to reach our goals is well underway. In fact, I'm excited to announce a newly funded project to curate SCN2A variants so that they're all in one place. This is aligned with our #1 research priority, which is patient-level variant characterization, which will inform treatment and clinical trial selection. Once complete, this will allow each of you to have details on your child's variant, enabling better treatment decisions. So congrats to Rike Moller, who's in Denmark and not here today, and Dennis Lahl and their teams. I don't know if Dennis is in the room, but if you see him, please congratulate. Oh, there he is. Congratulations. And now I'd like to introduce the talented and dedicated people who are tasked with planning and supporting the future of the family's SCN2A Foundation. Board members, please stand up if you're in the room. When you see them, please introduce yourselves, tell your story, tell them about your research, tell them what you think we can do better, and thank them for caring enough to do this volunteer work in their spare time. Michelle, secretary of the foundation, is mom to Lyanna. She lives in Missouri. Catalina, mom to Mateo, originally from Colombia, lives in Georgia. Maura, mom to Ashlyn, is local to Boston. Will, dad to Emery, lives in Dubai and Florida and sometimes Canada. Emily, mom to Caroline, lives in California and sometimes South Korea. Mike, our treasurer, is not here today, is actually not a parent of an SCN2A child, but he is dedicated to helping us help them. Mary, right here, our vice president, is mom to Ethan. She lives in California. And Roger, dad to Teddy, is also local to Boston. So give him a quick round of applause. Thank you. And you guys can sit down. Another key thing that the CZI grant enabled us to do was to hire a chief scientific officer. Sean Egan, as you know, was on our board, but he became the obvious choice to lead us into the future on our science team. As dad to Harper, a PhD and a biotech pharma industry analyst, he was the triple threat. So he was a natural choice to lead us into the future. And I'm going to introduce Sean for a minute so he can talk about the team for accelerating science and clinical outcomes.
Thank you, Jenny. Yeah, it's a tongue twister, PASCO, but a great acronym. And this is phenomenal. Our first conference was in 2019. There's just so many more people. And our research roundtable yesterday that we started the conference with, which was professionals only, I think was bigger than our 2019 conference in attendance. We had 100 people in this room yesterday, and phenomenal. But it's so part of CZI gave us the capacity to hire a scientific team to keep pushing forward towards a cure. And we're really blessed and thrilled to be able to bring on 3 scientists that are helping us push towards this goal, which we all want as parents and caregivers. So starting Karen Ho over there, maybe stand up and give a wave. Christina Saninocencio, right up here. Give a wave. And Brad Bryan in the back. each and every one of them are playing a critical role in to help advance science and bring us closer to a cure for our children. But Brad is also tasked with getting our registry up online, which we'll be launching at the start of the year with NORD, which is a big initiative. And we're really excited to be pushing forward with that. I was also tasked to give a quick synopsis on what we learned yesterday. So yesterday was a think tank, and we had some of the best and brightest minds in our community, in the research world and in the industry group, all here in this room thinking about our children. How can we do it better? How can we do it faster? How can we do it smarter? And the day was long, it was intense, and it was a lot of fun. But we dove deep into preclinical models, barriers to translational research, biomarkers, benchmarking for clinical trials, eligibility criteria, N of ones, and how to convert those N of one studies to N of many, and clinical trial endpoints. And I mean, it's only been a few hours since that meeting, and already hearing that new ideas were generated, new partnerships were fostered between different groups, and we're moving faster and moving quicker. So thrilled about the day, and really appreciative to all the researchers, many of which are still in this room today. So that parents and caregivers, talk amongst your table, that there are researchers and academic groups and industry groups sprinkled in here. Tell them your story, talk about your child, and let them know that it's important that we move fast. Thank you so much.
I'll do it. I also want to give a shout out to our medical and scientific advisory board members, many of whom I think are in the room. If you guys could just stand up for a second. Thank you. So once you're here, Stephan Sanders, Eloise Austin, Al George, Heather Olson, John Millichap, Dennis Law, Caitlin Hudak back there. Thank you all for being here. We appreciate it. We couldn't do it without you. And finally, I just want to remind everyone of our mission and values and our vision for a world where we don't have any SCN2A to worry about. We don't have to be here except as friends. But I want to thank every single one of you who volunteer your time, everyone who's held a fundraiser, big or small, every donor, every sponsor, every researcher who spends nights in the lab with mice and rats, hoping their work makes a difference. Well, it does make a difference, and that's why we're here. So enjoy the conference, meet some new people, families, make sure you talk to researchers, meet a family, learn their stories. That's how we all learn and grow and reach our goal of cures and better treatments. I now have the pleasure of introducing Stephan Sanders, your moderator today. Stephan's been a friend of the foundation for many, many years, and we finally got him to join our medical and scientific advisory board, where he's already making valuable contributions. Come on up, Stephan. The only thing is I'm not sure I'm going to be able to get him a blue whale, which you have to ask him about that later. Thank you all. Enjoy.
Thank you very much. It's a great honor and privilege to be here. I'm delighted to see so many people in the room today. When Leah asked me to moderate this, I did come with one stipulation. I did want to put on a British accent for the entire time. So bear with me, we'll see how it goes. My main job today is to make sure we all get to the aquarium on time. And so I'm going to be taking cues and making sure that things clip along. I apologize to any of our speakers if I cut you off, but we want to see if the aquarium has a blue whale, which we're thinking might be a useful model for future scientific inquiry. It does seem unlikely. The format we're going to have today in these sessions is going to start off each one hearing the most important thing of why we are here, hearing about the warriors, the families, and the impact. And that will then be followed by clinicians and scientists trying to explain some of the key progress which has been made so far. At the end of that, we'll then have questions. As Leah said, they'll be written on these little bits of card in front of you. They'll come up to the front and we'll do our best to get through as many of them as possible. Please write clearly. I'm not very good at reading, I'm better on computers. So nice, clear, easy, well written. At your table and around, you will find many scientists here. We are here for the families and for the warriors, and we are eager to meet you. Please take your time to talk to us. I think it's fair to say we learn something from every single family and every single child here. And so please do take your time, especially if your question doesn't get asked. And with that, I'd like to move on to our first part, which is Carla giving our first why we are here. Carla's coming now. Can we have a big round of applause for Carla?
Hi, everyone. I'm not a speaker, so I'll be looking down. I'd rather do an interpreted dance in front of you all than speak. So here we go. So our story, Colin's story. So Colin was born on August 30th, 2011. And before that, when I was growing up, my parents really taught us and showed the importance of determination, family, and community, especially rising up to any challenge, no matter the difficulty. So it was a lovely pregnancy. I loved being pregnant. And the first 24 hours Colin was born was pure heaven. It was like the only time things were normal. So, and Brian couldn't get enough of holding Colin. He just, anytime we had a visitor or his mom would come, he was just like, I want to hold him. So on day 2, Colin was taken to the nursery just to get changed up. And the nurse noticed that one of his legs was stiffening. So she alerted the NICU to come over, and they determined he was having a seizure. So he was rushed to the 4th floor at our local hospital, and he spent the next 21 days in NICU. Every test came back normal. Each week, the NICU team had a plan in place, but in true Colin fashion, he would present with a different seizure type. So then everyone's like, okay, let's try something else. Whenever I would get to hold him in the NICU, I would tell him, let's make a deal. If I learn everything about seizures, then you can stop showing us what they are. Yeah, that took a while. After 21 days in the NICU, we were discharged with a cocktail of medications. After many ER trips and PICU stays, our local hospital was stumped because Colin wasn't following the book. He should be this shouldn't be happening. So we advocated to get transferred to Boston Children's. So after a few days with fighting with insurance and PICU, we were transferred over to Boston Children's in an ambulance. This is where we learned that Boston Children's had more of an experience with complexity and not following the book. We learned very quickly that his therapeutic levels for Dilantin didn't need to be at 9 to 11. It needed to be 19 to 21. So we changed that right away. We finally began to see the real Colin emerge. His eyes were there. He started looking at us. He started smiling, and the smile wasn't a seizure at that point. So Colin was emerging. Our local neurologist wasn't thrilled about Dilantin because we all know Dilantin is not the easiest drug to be on. Comes up and it comes down, and there's always constant checks. But anytime we tried to wean and introduce a new drug, he would start seizing again. We were tired and wanted to get off this roller coaster ride called maybe this drug will work better. So Brian and I started advocating to stop trying other drugs and just keep with Dilantin. And so glad we did. Colin grew up really smiley and happy. He would do some progressions and hit a little bit of milestones, but he was happy. The one thing he was really good at is whenever a therapist would come to our house and he didn't want to work, he had this beautiful pout and soap opera tear. And then as soon as they would leave, he was all happy. And finally, I had to show them a picture and be like, do not fall for this at all. Colin was upgraded with glasses and started making gains slowly because we learned he had cortical vision impairment. But at around 16 months, we started noticing a change in Colin. We saw more grumpy faces and blank looks. He wasn't looking at us right away. So he was regressing, and we didn't know why, because he was controlled and we haven't seen a seizure for over 12 months. So around that time, I got a call from a geneticist and said, we know what's going on. Now, this is in 2013. Colin was born in 2011. So we finally found a cause. So I'm like, okay, what is it? And then she said SCN2A. And I was like, okay. And then she said, you're not going to find another person with it. Huh? The test said there was a family. I was like, no, that can't be true. There's a family. It says right here. How can I find them? She's like, you're not going to find them. I think I did. So we were determined, and I just jumped on Twitter and started hashtagging SCN2A and just wanted to find someone. So while Colin was regressing, he needed to do a liver biopsy because his liver functions were horrible. So they thought maybe he has a mitochondrial issue. Let's do a liver biopsy. Let's see and make sure it's not the dilantin. It was the dilantin. And the dilantin was the only drug that ever worked for Colin. So we had to go down that scary route to get him off and go and try keto. So we're back in Boston, scheduled, and he has his EEG on, he's playing. And they're like, okay, no more dilantin. 48 hours later, he still has the EEG. We're ready to start that fun keto journey. And the doctor came in and said, he's not seizing. Do you feel comfortable going home with Diastat? And then you can come back once he starts seizing. We were like, sure. So we drove home and he had this big smiley face, and we just waited until the bomb would drop, but the bomb never drops. So he started making gains, still not at full potential. He's still nonverbal. He's still a manipulator to get out of therapy, let me tell you. He has language issues. He has aggression. He's entering puberty. So we started noticing things were okay, but his way. So back in 2019, on June 9th, Colin had a seizure at school. So after 7 years, Colin had this massive seizure, a tonic-clonic that he's never had before. And we don't know why it happened. And if you want to know more, ask Dr. Olson, she'll tell you more if you want. I give you permission. So he had a seizure and our world started crashing down again. So we just started that train again. So it's been 3 years. He's on Vimpat. He hasn't really seized. So we're just on that train and just riding it day by day. Now, during all of this time, the group was forming, and we were very big advocates on joining the Tiger study. Back in Seattle, we rode the airplane, went all the way over there, and then we participated in Detroit for a small little study, and we finally got to meet Leah and Ben and Brant in person, and we were like trying to notice each other's kid, like, what can they do the same? So it was amazing. And then the story took off with the foundation. So sorry, hold back a little bit. So Colin is nonverbal. He's working on his fine motor skills to use this communication device effectively. He does have cortical vision impairment, motor challenges, intellectual disabilities, sleep issues, constipation issues, and again, like I said, entering that wonderful stage of puberty. But we are okay. We take it one day at a time, determined to tell our story and doing everything we can for Colin and our SCN2A family community, because it's all about family, community, and rising up to any challenge, no matter the difficulty. Thank you.
Thank you. So we heard there a familiar refrain in the SCN2 community, in the SCN2A community. So I stumbled with the British accent there. It's quite hard if anyone's tried this. the familiar refrain we hear there of ask Dr. Olson. And so with that, I'd like to welcome Dr. Olson to the stage to talk about the evolution of the SCN2A spectrum. Thank you.
Thank you guys for having me. It's such a pleasure to be here. To bring up the slides. I've been part of this group for 6 years now, I believe, and it's been really fun to see the evolution and meet so many of the families, and I look forward to meeting more of you guys today. This is going to be a little bit of an overview of the clinical presentations of SCN2A across the spectrum. I'm not going to dive deep into data because you're going to see that in the rest of the slides today, but I'm happy to answer questions. And we do have a cohort at Boston Children's Hospital who we've been following over time are going to be doing some more genotype phenotype analysis, and we're collaborating with some of the groups here doing some of the electrophysiology. So I do serve on the medical advisory board, as you saw, and we have some collaborations, as I mentioned, especially with Al George and Ted Cummins, and my fellow Isabel Haviland. Say hi to her if you see her today. She's doing some great work and starting a project looking at genotype phenotype correlations for our cohort as well. I'm going to, like I said, talk about the broader phenotypes and touch on aspects of epilepsy, movement disorders, tone, autonomic symptoms, autism spectrum disorder, and intellectual disability in broad strokes, as well as the impacts of each of these on treatment approach as we know it today. Colin is one of my little buddies, as you just heard, so feel free to say hi to him. He's a cutie. It's not the end of the world if they have my notes. So while she works on that, I'll just talk a little bit. So we sort of divide we call it phenotypes, but that basically means a clinical presentation of how the kids present into a few different groups. And some of them are based on age of seizure onset, which has been a differentiating feature. And then there are some children who don't have seizures and have more predominant autism and intellectual disability presentation with or without seizures that may present later. And you'll hear a lot of work today about how the different clinical presentations and the genetic variants relate to how the channel is actually affected by those genetic variants. We think about gain of function, especially with early presentations, versus loss of function. That tends to be more intellectual autism disability with or without seizures. And there's a group of mixed function, which is complex, but can affect the main electrical activity is actually reduced, but there can be like leakiness to a current, persistent current, resurgent currents, and we can see some intermittent later onset, more severe epilepsy and developmental disorders in that setting as well. So these are kind of the broad groups I'll talk about: self-limited epilepsies, early on infantile developmental and epileptic encephalopathy, which is a term that indicates there's developmental and cognitive impairments that are and behavioral issues that are related both to the abnormal electrical activity as well as to the underlying disorder, in this case, the SCN2A variant. The later onset developmental and epileptic encephalopathies, DEE is the term we're going to use for that. There are movement disorders within those, and then there's a defined intermittent ataxia, which has been well defined, and that can overlap, especially with the early onset epilepsies, and in particular the milder spectrum. These are the figures. There are breakdowns from a couple of manuscripts in dividing those groups in various different ways. The one with the more aspects on the right there, the Zhang divides it by specific epilepsy syndrome. And epilepsy syndrome is essentially a description of the seizure types, the age of onset, and the EEG patterns that we see. So that's what we mean when we say an epilepsy syndrome. Whereas the Wolf paper in 2017 did the broader categories similar to what I'm describing here. And we'll break those down. Oh, no, I'm not moving, Christina. So this is just one other look at kind of the bigger picture of those subcategories, looking at it by age of onset of the seizures on the x-axis and development on the y-axis, going from normal to severe developmental delay and intellectual disability. So the early onset normal, which has a broader range, is the self-limited epilepsies, and then the more severe DEs are towards the bottom left. And then the loss of function groups tends to be more towards the right, with the intellectual disability, autism with or without epilepsy. Dr. Sanders has an updated version of this that you showed yesterday that shows a little bit more. This shows the spectrum of the gain of function towards the red side, the loss of function towards the blue side, normal in between. But there is actually this other category of the mixed effect on the channel, which can cause a developmental and epileptic encephalopathy with a little later onset after 3 months of age. So that's an important group to kind of include in here as well. So with the self-limited epilepsies, they can run in families. So I showed a pedigree there. The individuals in black are affected. They have infantile seizures, and the individuals in white are unaffected. Plus means that they carry the variant in SCN2A, and minus means they don't. If there's no plus or minus, then they weren't tested. So you can see that it's tracking in families in a dominant manner, about a 50% chance of inheriting the variant. And if you have the variant, you tend to be affected. This can be familial or it can be sporadic. A new variant can pop up and cause the spectrum of disease. The range of age of onset is pretty broad, from 2 days to 23 months. They're often very early onset, but not necessarily. Seizures are typically focal with stiffening, what we call tonic, or jerking, we call clonic activity. Focal meaning they come from one part of the brain and not a deeper focus that spreads everywhere immediately. The seizures typically resolve by 12 months with rare recurrence later in life. Developmental and cognitive outcomes are typically normal. And in some individuals, you can see a later onset movement disorder, usually after a year of life, episodic ataxia in particular. It's a balance coordination problem that can come in waves, and we'll talk a little bit more about that. This particular epilepsy syndrome is often in other genetic causes associated with something called paroxysmal dyskinesias, which is a hyperkinetic movement disorder with irregular excess movements, but we don't actually have that particularly associated with SCN2A. So this is a case example, but I actually put self-limited question because it shows you that it's not always black and white. And this one is maybe self-limited, but maybe actually has some ongoing epilepsy. Boy born at 34 weeks by twin pregnancy, no perinatal complications, a little bit preterm. Did okay until 3 months corrected gestation age, so 4.5 months, but corrected to 3 months, had onset of focal motor seizures. He's had completely normal developmental and cognitive outcomes. Seizures were controlled and he came off of medication, but starting in about 2 years, had some paroxysmal episodes, not very often, so they haven't been captured on EEG, but he intermittently will feel shaky inside, run to his parents. Can't outwardly see anything, but afterwards he has a little slurred speech and shuffling gait, not quite himself. So we suspect they may be focal seizures, but he has a 24-hour HE that was completely normal. So a little bit of an unknown. So moving on to early infantile developmental and epileptic encephalopathies, these are the seizure onset less than 3 months. They're often refractory, meaning not responding well to our medications, associated with global developmental delay, intellectual disability in the majority. EEGs range from burst suppression, which is one of the more severe neonatal EEG patterns, to a range of abnormal patterns. They are commonly associated with movement disorders. So in particular, dystonia, which is stiffening. So writer's cramp is a mild form of dystonia, but these kids can have segmental, multiple joints affected, or whole body dystonia that can be really problematic for quality of life. Chorioathetosis is another movement disorder that can be kind of a subtle wiggling distally as the chorea. The athetosis is a little more proximal truncal wiggling movement. And that also can be really affecting quality of life and can burn a lot of calories. So that can be a problematic movement disorder, and others it can be milder. And then dyskinesias are a bit more non-specific excess hyperkinetic movement. So all those can be seen in the spectrum of disorders, not usually as often the episodic ataxia. Muscle tone can be high or low, and that can be problematic. You have these kids, we often, and many of you probably follow with orthopedists and rehab doctors, physiatry for complications of tone, like impacts on the spine or the hips. It's something we suggest if there's significant tone abnormalities, as well as help with bracing and that sort of thing. Cortical visual impairment is a common problem that you're gonna hear a lot about at the conference too. And then autonomic symptoms, so temperature instability, tachycardia. This can affect the GI system. Right, McSweeney from our group is going to come talk about GI effects tomorrow. So stay tuned for her talk. Sleep can be impacted, so the autonomic system is really important. Less well described in the literature, but really important and noticed by all of you. So early infantile DEs with burst suppression, that particular EEG pattern that I mentioned, these present with epileptic spasms, which are brief stiffening and relaxing in clusters, tonic seizures or myoclonic seizures that are like lightning bolt jerk fast. They have this severe abnormal pattern that I'm going to show you on EEG. It is one of many genetic causes of this syndrome, of which there are subsets. Ohtahara syndrome, early myoclonic encephalopathy are terms that you may have heard that fall in this subset. So there's some literature suggests that sodium channel acting medications can be beneficial. Phenytoin in particular, as you just heard in Colin's story, that these kids often require high doses of phenytoin, and it has this funny chemistry that when you get to those high doses, you near the zero order metabolism, and then you can skyrocket. So you're at this very teetering balance between, I go a little higher and I get toxic, and I go a little lower and the kiddo goes into big seizures and status epilepticus. So it's a challenging balance to reach. And sometimes the other sodium channel blockers can be helpful, but not always. There are some risks for shortened lifespan, such as aspiration or status epilepticus or sudden unexpected death in epilepsy as well. This is the pattern of burst suppression that I mentioned there. Each of the letters on the left are an electrode. If your family member has had an EEG, and each channel there with the squiggly lines is one electrode comparing to a neighboring electrode. And in this pattern, you have these high bursts. There. Does this work? Yes. You have these high amplitude bursts of activity and then these periods of suppression in between. So these epilepsy syndromes, I just wanted to mention too, are to some degree age dependent. So many of these kids with severe gain of function DEs present in the first few days of life. And in that neonatal period, the burst suppression or Ohtahara syndrome is one of those syndromes that tends to occur in that age range. Those kids can go on and evolve to other epilepsy syndromes that tend to happen more at different ages, like West syndrome, or now we call it early infantile epileptic spasm syndrome is a little bit broader term. That's the updated term. West syndrome is a triad of epileptic spasms, hypsarrhythmia, specific EEG pattern, and developmental regression. And then you can go on to something called Lennox-Gastaut syndrome, which is a syndrome with multiple seizure types and a particular EEG pattern of diffuse slow spike in waves with or without paroxysmal fast activity as well. So there's a sort of an age dependence on what the brain does, regardless of the underlying cause. And kids who present later might present with West syndrome or infantile epileptic spasm syndrome, for example. So the other common specific syndrome within this early infantile DE group is epilepsy of infancy with migrating focal seizures. The age of onset is fairly young. For the syndrome overall, it's less than 6 months. For SCN2A, the cases reported have been mostly under 8 weeks, and usually very early. It's an interesting syndrome with focal seizures that sort of ping pong between the hemispheres. One seizure is evolving and then it kind of pops to the other hemisphere and new seizures evolve and they kind of ping pong around. They can be prolonged and sometimes evolve to status epilepticus, and they're typically associated with pretty severe developmental outcomes. Again, like with Ohtahara syndrome, this is one of many genetic causes. So SCN2A is here amongst other genetic causes, KCNT1 being the most common, and Ohtahara KCNQ2 is sort of the cousin most common, but SCN2A is prominent in both of those. So an example here, you actually heard Colin's story, which is a nice example of this early onset DEE, but he certainly has challenges ongoing, but his seizures are mostly controlled now on a single medication, which is great. And he had multiple years of seizure freedom, which is not always the case. And we don't have great predictors of who is going to have ongoing difficult to control seizures versus not. And I have lots of kids who have ongoing tough to control seizures as well. So here's just another example of a term baby girl, no complications, had seizure onset at day of life 1 with focal tonic seizures, multiple per day, was on multiple medications with sort of partial response to sodium channel blocking medications. In early childhood, she's actually reasonably well controlled now on a combination of lacosamide and lamotrigine, particularly sensitive to missing doses of lacosamide. We think that's been the main one helping her, interestingly similar to Colin. I don't know, not a lot of literature to support that specifically, but it's interesting. She also initially had a burst suppression pattern on her EEG, has evolved to other patterns over time, severe global delays, swallowing difficulties, and poor weight gain. So the later onset DEEs with seizure onset greater than 3 months, there's several defined syndromes. I've talked about a couple of these. Infantile epileptic spasm syndrome I mentioned, Lennox-Gastaut syndrome I mentioned, epilepsy with myoclonic atonic seizures are sort of a lightning bolt jerk and then a drop. And epileptic encephalopathy with spike wave activation in sleep, or you may have heard of epileptic status epilepticus of sleep, or these patterns where you get continuous spiking in sleep and you can see setbacks in cognition and language and development in that setting as well. So we've seen that occasionally. Again, movement disorders are common in this subset, like the early onset DE group, choreoathetosis and dyskinesias. Autism spectrum disorder and intellectual disability overlap, as with the early DEEs. Muscle tone abnormalities similarly can be low tone or high tone. And with regards to treatment of epilepsy in this group, they're less likely to respond to sodium channel blockers. I'd advise them caution with the later onset epilepsy because they tend to have more of a mixed function, and sometimes kids can get worse and may do better on other mechanisms, but we don't know for sure. So just an example of a kiddo who falls in this group, normal birth and development, had onset of infantile epileptic spasm syndrome at 10 months of age, not controlled on the initial treatment, but was eventually controlled and then recurred with spasms again at 3 years of age. She had developmental regression with the onset of those initial spasms and never fully recovered those initial skills. And later has more focal to bilateral tonic-clonic seizures or focal seizures, and has chorea as a movement disorder that isn't requiring treatment, but is fairly common. So episodic ataxia, a non-epilepsy syndrome or a movement disorder, but again, it can overlap with individuals who have early onset seizures, and this can happen anytime from around a year of age into adulthood. It's highly variable with regards to duration and frequency. The episodes can last anywhere from minutes to weeks, and again, the frequency is highly variable as well. There can be some triggers such as head injury, sleep deprivation, alcohol, noise, menstrual cycles, variety of triggers similar to seizure triggers. And it's not just imbalance in coordination. You can also see some slurred speech, tremors, vomiting, pain. Cognition is often normal in this group, which is why it tends to be more that self-limited epilepsy spectrum, but not always. And there are some with cognitive impairment. And treatment response is not great for the ataxia itself. Then I mentioned this subset of kids who have more predominant autism and intellectual disability, with epilepsy being variable, and the severity of that epilepsy, if it happens, is highly variable as well. But many of the kids actually can be controlled on one medication or even come off of medications, whereas others have a tougher to control epilepsy. So there's ongoing research, and you're going to hear some great talks today or tomorrow. Dr. Burke and Dr. Ludwig have some really great data on the developmental outcomes of kids with SCN2A related disorders. So stay tuned. As far as neuroimaging, the brain structure is usually normal. We can see some atrophy or volume loss, especially in the kids with the more severe epilepsy, but broadly, there are some rare case reports of malformations that indicates the channel having some role in brain development in utero. Polymicrogyria in particular, in some case reports of absence of the corpus callosum, which I've actually never seen myself. So that's a structure that connects the left and right hemispheres of the brain. The other aspect that I didn't talk as much about, but is out there in the literature a little bit, is as our individuals get into adulthood, there are some reports of schizophrenia or psychosis, and that's something that we'll need to follow in more detail. I'm a pediatric neurologist. It's not my area of expertise, but I hope there'll be more information in that long term as far as what are the risks and how common that is. So this is a little bit broader view, but to sort of celebrate what the SCN2A community has been able to do, and that you'll hear more about in the next 2 days to Precision Medicine 2023. This was a review, and just to highlight, as far as gene discovery and diagnosis, we're making significant progress. There's more and more review here every year. I want to credit Lacey Smith, who published some guidelines for genetic testing in epilepsy, suggesting next generation sequencing on anybody with unexplained epilepsy that hopefully is helping us get more diagnoses. In the autism world, there's more exome sequencing happening as well. So I think that's helping. As far as natural history, you're going to hear about the Clinical Trial Readiness Project, the Instones Project, several projects that are really gathering great data, and hopefully we can continue to advance that over time so we really know what outcomes we're looking at when the clinical trials are ongoing and finished, which they're starting to. You're going to hear about preclinical models and drug discovery. We're working towards more gene-based and RNA-based therapies in addition to small molecules that are heading towards our community. And we're hopeful that those are going to be able to make a difference. And we need to know what we're treating when we do that. So building the community, establishing databases that can link to each other and really understand, and probably getting some more in-person data as well is going to be critical. And then work towards clinical trials, organized clinical trials. And one is mentioned there, which is something that you'll hear more about from Wendy Chung, our new chief of pediatrics at Boston Children's Hospital, at the conference as well, and an area of interest to me also, in addition to the clinical trials. And we'll have some great discussions about that. So I don't want to take too much time because we got a little bit delayed. Just quick note on clinical research and trial involvement. You guys are mostly involved. It sounds like you're doing a great job, but really helpful to have observational and natural history studies to, again, understand where we are so that we have a treatment we know we're making progress or not. If you're thinking about experimental therapies, there's two big categories: small molecules, a drug that you take by mouth or by gastrostomy tube, versus gene or RNA based that might be IV based. It might be an injection into the spinal fluid. It might actually be infused into the brain, depending on what approach it is. And each of those are going to be, they may be specific to the type of variant in SCN2A. It's not going to be sort of SCN2A treatment. So they're all going to have specific criteria that they apply to for good reason. They may be based on clinical presentation. There may also be experimental therapies that are available based on epilepsy syndromes and not necessarily specific to SCN2A that might be looking into. So if your treatment paradigm is not working, it's something you can consider talking to your team about, and important to look at risk benefit assessment and logistics for each particular study and or trial as it relates to the goals for your family and for the community. Happy to answer more questions. Thank you for having me.
Thank you ever so much. We're now going to move on to our next speaker, which is Stacey Cohen from Children's Hospital of Pennsylvania, on understanding your SCN2A variant. Welcome to the stage. Thank you.
Okay, good morning, everyone. Thank you so much to the Foundation for inviting me to speak. I'm Stacey. I'm a genetic counselor at the Children's Hospital of Philadelphia. And today I wanted to talk to you about information that you need to know in order to understand the genetic background information and how to read and understand your child's genetic testing report. So I want to start out just by talking about some fundamental concepts in genetics, how this is applied in the SCN2A gene specifically, and then putting this all together to what you need to know about your child's variant. So starting out with a genetics background, when we think about our genetics, I like to think of them like an instruction manual that our body has to read in order to tell our body how to grow and how to develop. So this is all in our genetic code. And our genetic code is packaged into what we call chromosomes. And these chromosomes, which you can see if we kind of neatly align them and put them together, are these lines on the slide. And these chromosomes, we have 46 in total, 23 pairs with 1 from each pair coming from each parent. And we know that the SCN2A gene specifically is on chromosome 2. And again, there's 2 copies of this gene in each individual, 1 coming from mom and 1 coming from dad. So all of the things that I just talked about with chromosomes and genes, these are the building blocks, the foundations of genetics that have been known for many, many years. But in the scheme of our knowledge of genetics, epilepsy genetics and the genetics of neurodevelopmental disorders is really a newer field within the field of genetics. So, if you have a child with epilepsy or autism and you walked into a genetics clinic maybe 20 years ago, what we would have told you is genetic testing is probably not going to find an answer for you because it's very complicated. It's research. It's not really something that we do in clinic. But now, with advances in technology and knowledge, we actually do know that we have a very good chance of finding the cause through genetics. Typically, these are changes that are new in a child or de novo. And it's becoming more and more the clinical standard. And I think that this is really important to emphasize, this history of the field, because I think it really highlights the advancements that all the scientists are going to talk to you about today. We've really come a long way, and there's a lot farther to go. But I think this is a kind of a good foundation to frame everything. So when we actually do genetic testing in this patient population, in patients with severe epilepsies or epileptic encephalopathies, and this is a study back in 2016, which did this, SCN2A is really one of the most common genes that we find. And again, I really want to highlight this because I'm sure, going through your diagnostic journeys, depending on where you had your genetic testing done and what expertise was there, many times families will encounter providers who've never heard of SCN2A before, and they just didn't have a lot of information about it. But as genetic testing is becoming more and more common, it's important to emphasize again that SCN2A is one of the most common things that we find when we do genetic testing in this population. So awareness is extremely important. So all of this talk about SCN2A, what actually is it? SCN2A is a gene which encodes a protein, a voltage-gated sodium channel. And SCN2A is one of the voltage-gated sodium channels in the brain, but there are others. And it's really important in early development as well as throughout development, but in early development is expressed in this segment of the nerve cells called the axon initial segment, which is a really critical piece of the nerve cell for its function. And there are other genes that are really important at the same spot, like SCN8A and KCNQ2 that are also implicated in neurodevelopmental disorders. So now getting into more specifics about the different types of changes that are found in the SCN2A gene called genetic variants. So I think we can all appreciate that SCN2A is not one condition, even though it's all caused by the same gene. You'll meet many different families at this conference, and just throughout being in the community, you'll see each child has a unique presentation. Each child has a different set of symptoms. And the reason, or part of the reason for this, has to do with a particular spot in the gene where their change is present. So what this slide is showing is if we took a picture of the SCN2A protein and we flattened it out, this is what it would look like. And there are arrows that kind of show different spots throughout the protein where changes have been reported before. And in the bottom half of the slide, you can see different what we call phenotypic categories or different groups of types of presentations that we can see associated with variants in the SCN2A gene. And there you can see there are changes throughout the entire protein. There are some changes that are more common, some changes that are reported only in a single individual. And it's important, again, to know which particular change a given individual has, because this plays a role in what we think about the symptoms that they may be at risk for and their treatment and management. So these SCN2A variants or changes, this language that I keep throwing around, a variant is like a change in a gene. So it's like you have a word and you've swapped out a letter, for example. And it's important to say most genetic variants in our bodies in general are not harmful. They have to do with our particular family's background, where we're from, but it's not necessarily, most changes are not actually related to our health in a measurable way. So when you do genetic testing, when you do that cheek swab or blood draw and send it off to the lab, their job is to parse through all of the genetic changes and identify changes which are actually harmful. Harmful in the sense that they disrupt or change that gene's protein product. Because we know that when SCN2A protein is missing or functions in an abnormal way, obviously this changes brain functioning. So you're going to hear the terms gain and loss of function a lot throughout the conference and through talking with families. I'm going to give a very basic introduction to these concepts, and some talks later are going to explain all of the nuances that kind of go into this. But what I've shown here on this slide is a very basic illustration of what a sodium channel is. So we have our sodium channel, and sodium is passing through the channel. And there are two copies here, again, to illustrate that there are two copies of the SCN2A gene. So when we say loss of function, what we mean is one of these copies is not able to provide this typical functioning. Either the protein is not made at all, or the protein that is made is not able to allow sodium to pass through. And when we say gain of function, there's really lots of different components that can underlie this. What I have here on the slide is just one example. Let's say there's too much sodium that's allowed to pass through. And this is what's actually underlying the change in brain function. So how do you know whether your child's variant is gain of function, is loss of function, is somewhere in the middle along the spectrum? One of the really important ways to answer this question is actually being able to dig into the particular variant that your child has. So what we have here on the slide at the top is our DNA, again, our genetic code. And this is a 4-letter code. So you'll see A's and T's and G's and C's. And this is the building blocks of our genetic code. And our genetic code is read in groups of 3 letters at a time. So when our body is reading this genetic code, it's reading through these letters 3 at a time. And then it's using this in order to build the SCN2A protein. So each 3-letter code corresponds to a building block of a given of a protein called an amino acid. And so when we talk about how to name a given genetic change, there are different ways that we can do this. And this is what's going to be on your child's genetic testing report. So firstly, on the left, you can see we have what we call the genomic position, which starts with a G dot. This is not super commonly noted on the genetic testing report, but it is one nomenclature. So I wanted to at least bring a little bit of awareness to it. But the most common ways that genetic changes are named are with what we call a C dot and a P dot, so the middle and right-hand side. And they're each referring to different aspects of the genetic change. So the C dot is referring to the change on the DNA itself. So the way that we read this, for example, the example on the slide, if we look at the 2,558 position, typically there's a G in the code there. And then that greater than sign means is changed to. So at this position, typically there's a G, and this is exchanged for an A. Then when the body goes to use this genetic code to build the SCN2A protein, this is when we get to the P dot. So the P dot is referencing what change in the protein is caused by the change in the DNA. So the way that you read this is that at the amino acid position 853, typically there's an ARG or an arginine, and instead, because of this change in the DNA, there's a glutamine instead, or GLN. So there are different classes or subtypes of genetic changes. And by far the most common type is something called a missense variant. And a missense variant means that one spot in the genetic code, one of those A, T, G, or C's is swapped for one of the other letters in the 4-letter code. And so when the body reads this, it exchanges the amino acid that's typically there for a different one. And again, this is how this is typically noted on a genetic testing report. Then we have what we call nonsense variants. Again, this means that there's a swap of a single spot in the DNA code, but rather than putting in a different amino acid or a different protein building block, it's actually putting in a stop. And so it's kind of like if you have a sentence and you put a period in that sentence too early, you're cutting off that second half of what you were trying to say, you're losing the meaning of what you're trying to say, and that sentence no longer has the meaning that it's supposed to have. So that's a nonsense variant. And the way that you can tell the difference between these different types of variants is usually within the P dot or the protein annotation. So typically, if your child has the nonsense variant, that's noted with an asterisk at the end or with an X. Those are kind of the most common notations for a nonsense variant. We also have what we call frame shift variants. So we talked earlier a little bit about how our body reads the genetic code in batches of 3 letters at a time. So if you add in a letter somewhere in that code, it may shift the set of 3 letters that it's trying to read. So what this ultimately causes is incorrect amino acids being inserted, and eventually it leads to a premature stop. And so the way that this is typically annotated on a genetic testing report is again in the P dot, and it will say at the end, FS, either an asterisk or an X, and then a number. And that number means that frame shift is by 11 amino acids, and then a premature stop is inserted. So you're still cutting a protein off too early, but in addition to that, you're adding incorrect amino acids prior to that premature stop. We also have what we call splice site variants. And this has to do with the way that our body actually processes the DNA. So there are different segments of our DNA called exons and introns. And one of the things that our body has to do is remove these introns when it goes to actually build the protein. So if there's a genetic change which interferes with the body's ability to recognize where an intron stops and starts, that can disrupt this process. So this is something that you would typically see rather than in the P dot will be reflected in the C dot. Typically, it will have a number and then a +1, a +2, or a -1 or -2, and that indicates that at the boundary between where the exon and the intron is, there's some spelling change which interferes with the body's ability to recognize that difference between the exon and intron. And again, this renders a non-functional protein. And then lastly, we have deletions or duplications of the SCN2A gene. So rather than a change in the spelling of the gene, It could be that the entire copy of the gene is entirely deleted or duplicated, meaning there's an extra copy. And this typically is larger than just a single gene. It may include other genes that have other functions in the body. And so the presentations for individuals who have this can be different and include other types of medical symptoms than beyond what we typically see with just SCN2A. So again, why is this important? It's important because these different types of genetic changes can lead to different effects on the SCN2A protein. And this affects the way that we think about symptoms to expect and potential treatments and therapies. So when we talk about loss of function variants, these include most nonsense, frame shift, splice site variants, all those variants which disrupt the process of the protein being made or cut off the protein too early. Those are all typically expected to result in a loss of function. But we also know that some missense variants can also cause a loss of function, which can be sometimes tricky to tell the difference between the missense variants that can cause loss and gain of function. And whole gene deletions as well are expected to cause a loss of function. Even though there are different types of genetic changes that can underlie loss of function, we typically expect the overall effect to be relatively similar. Whereas with gain of function, because there are lots of different ways that a channel can cause gain of function, there are lots of different things that can happen, and overall effects can vary widely between gain of function variants. So I wanted to talk a little bit about the information that goes into making a genetic diagnosis when an individual is undergoing genetic testing. So you can understand, how did this genetic testing report come to be? How do they actually know that this change is the cause of anything? And that has to do with a set of standardized guidelines that were put forth by the American College of Medical Genetics back in 2015 that allows for the classification of variants into 5 different categories: pathogenic, likely pathogenic, uncertain, likely benign, and benign. So a variant is found by a lab. It starts out in the middle of this spectrum, and the variant needs to prove itself pathogenic or benign. Or it may remain in this uncertain category if there's limited information. So what types of evidence go into actually making this distinction and actually being able to say whether a variant is pathogenic or not? We can look at things like population frequency. Is this change found commonly in the general population, which is really not the case for most SCN2A changes that are harmful? If we look at computer modeling of a variant and the predicted effects, does this prediction show that this variant may be deleterious? If we do functional studies, is there an effect? And if so, what is that effect? Does the phenotype of that individual or the symptoms that they have align well with what we know about this gene? If there are multiple affected people in the family, is this change found in everyone who has the same symptoms? And has the variant been seen before in other people in the medical literature? These are all things that are weighed when making these decisions. So when we say pathogenic variant, it means that the lab has looked at multiple lines of evidence, and there is a lot of strong evidence that says this variant is the cause. Whereas likely pathogenic, we still consider likely pathogenic to be a diagnosis, but this is one where there's slightly less information or slightly less evidence. And then lastly, variants of uncertain significance just means there's limited information overall as to the pathogenicity of this variant. And so if your child has a variant of uncertain significance, discussions with your healthcare provider are crucial to talk about the likelihood that this change may or may not be playing a role in your child's condition. So in summary, these genetic testing reports, they describe the genetic variant, they list the evidence for and against, and they provide an overall classification of pathogenic, likely pathogenic, or uncertain. But some of the pitfalls is that parental testing is usually the strongest factor. So if a change is new in a child, this is typically strongly weighted evidence towards pathogenicity. But if parents are not available for whatever reason, this can sometimes make it hard to make a variant go from uncertain to likely pathogenic. Some older reports have unusual formats. So especially prior to 2015 with those standardized guidelines, there can be non-standard terminology that can be used that can make it hard to utilize that genetic testing report. And then of course, there's static information. We're learning a lot about different SCN2A variants through a lot of the researchers in the room today, but none of this is going to be reflected on your genetic testing report. So this is why it's important to stay in contact with your geneticist or genetic counselor, neurologist, whoever ordered your testing, and periodically talk to them if there are any updates. So in summary, there are lots of different types of changes or genetic variants in SCN2A, and this is one of the reasons underlying why there are so many symptoms that can be seen. So it's important to know your C dot and P dot. If you have a variant of uncertain significance, this is always interpreted in the context with your healthcare provider team. Thank you.
Can I invite Dr. Olson back to the stage? We're going to take some questions now. Remember, in front of you, there are some bits of card and some pens. If you have questions, please write them down. Leah is circulating and we'll collect those and bring them up here. I have a couple of questions to kick off while we get there. We'll do that in a second. Welcome back. If you want to grab a seat there, that hopefully should be near a microphone. Excellent. Thank you very much. I'd like to start off with a question. How complicated are the genetics of SCN2A compared with other genes in the clinic? Heather, if you'd like to go first.
Sure. I mean, I think it's a good question. Each gene has its own complexities. I think the channelopathies are amongst the better established genetic causes of epilepsy. So from that standpoint, it's not too challenging, but it is challenging with regards to, as can be the case with others as well. It's not one disorder, but it's several disorders, and there's not a clinical test to understand the functional effects. So it's a combination of putting together the clinical picture with the genetic variant and what's known about it, and still more to learn. So it keeps us on our toes. I don't know if that fully answered the question.
Absolutely. And Stacey, do you have a sort of perspective on that as you see people coming in the clinic?
Yeah, so I think it's, I agree with everything Dr. Olson said. There's a lot of nuance to do with the specific genes that a child has. And sometimes we see that, many children with the same variant have very similar symptoms, and sometimes that's not really the case at all. So it is, one of the more common things that we see, and there's a good understanding from that perspective, but there's definitely a lot left to learn.
Wonderful, thank you. So if testing was done before 2015 or earlier than that, should the testing be redone, and can a genetic report change?
So a genetic report definitely can change, especially these reports from prior to 2015. So if a report is older and a change may be classified as an uncertain change, information about that change may become available after that. But of course, that's not necessarily reflected on the report. So that genetic change is still there. Our genetic information doesn't change over time, but the interpretation may change. So I wouldn't necessarily recommend repeating testing, but I would talk to your care team to talk about how suspicious they are of this SCN2A and whether there's any missing information, and at that time can consider sending more testing if we feel like there's still information that we're missing.
Yeah, I would just add that there's a couple of situations consider. One is the updated classification of the variant if it's of uncertain significance, as you mentioned, Stacey. The other would be if you don't have an explanation, then revisiting the data for reanalysis at 1 to 2 years. I assume most people here have a variant, but either if there isn't an explanation or it's sort of the thought process is that it's not fitting with SCN2A, that might not be the answer, then you might want to think about reanalyzing the data and or if it was a panel considering an exome, for example.
Thank you. So we have 2 questions about mixed function. And so the first one is a sort of practical question of a child who probably has a gain of function, but in thinking about clinical trials, the concern has been raised that it's a mixed variant, and wondering, firstly, how does mixed differ from gain versus loss of function? And how are these determinations made?
So that's a question for you and the scientists in the crowd who are doing the electrophysiology. The big picture clinician view is that usually it implicates there's a decrease in the peak current, but there's sort of some leakiness, a persistent current, a resurgent current, or a difference in how that channel is recovering for the next action potential. But you can also answer that one if you'd like.
So maybe we'll save that for a second. That the simple answer I'd give is going up is different from changing, and gain of function is changing. It's something extra rather than just going up. Related to that, though, there was a question about duplications. Do we think duplications are sufficient to cause SCN2A pathology? I must say, I don't know the answer to that. Do either of you feel you have an answer to that?
So it's complicated because typically SCN2A is not duplicated in isolation. Typically, these are larger duplications that involve other genes. And so it can be hard to say exactly what role SCN2A plays in that larger duplication with other genes that can cause disease.
There's sort of a cluster of sodium channels, but we definitely do have patients who have duplications that include SCN2A that I think are disease associated, which is different than you can have sort of a partial duplication or a copy number variant within the gene that may actually disrupt it and be a loss of function. So it depends on exactly what you're talking about.
Could I add to that? That was my
Sure.
So what I'm thinking about is gene therapies, where we're thinking about, for a loss of function individual providing more copies of a normal SCN2A. And I'm just wondering how much is smaller. Can we learn that from children who already have the
Yeah, that's a really great question. This is a gene that is clearly dose sensitive, and so there's caution in going too high or going too low in our dose correction. I was just having that conversation this morning. So it's a great question. Dennis, you actually have some copy number variant on the sodium data on the sodium channels that are out there, and there definitely are patients. I wouldn't say they're unaffected, but it may be something worth taking a look at.
To add something to that, I think it's important for us to separate a little bit between actual gene therapy, meaning you're correcting the actual genetic abnormality, and that's a little bit different. That's not necessarily going to be something that's dose dependent. You're basically just correcting the abnormality through the DNA, through all of the cells that you can access, and so that's not necessarily going to be dose dependent for either gain or loss of function. It is whatever gets done beyond the DNA. So as you go and try to correct the amount of mRNA that is produced for a particular allele or a particular type of that gene. And I think it's a great question, but I don't know how duplication can necessarily help. I mean, I think it can give you an idea, but I don't think it can give you a very precise idea about the dose dependency, because having a duplication does not necessarily translate, for example, into having a missense variant that causes you doubling of the activity.
Okay, thank you. But perhaps we'll save this. It's obviously a complicated question. Maybe we'll save this for later with therapies. Heather, I've got a couple of quick fire clinical questions for you. Can dystonia, chorioarthrosis, I can never pronounce it, chorioarthrosis, dyskinesias be controlled or treatable?
Great question. There are treatments and there are medications for for those movement disorders. Variable success in how well they work for any particular individual. So working with a movement disorder specialist is particularly important if it's a significant problem for your family member.
And then with EEG patterns, how common is burst suppression or Ohtahara syndrome in SCN2A?
It is quite common in that early onset presentation group. Some of those charts gave exact percentages, but it's not the majority, but it is a significant chunk. I don't remember the exact percentage, to be honest. It's somewhere less than 30%, but it's common.
And Stacey, a question for you. If everybody has different DNA, how can it be that there's a particular letter at a certain location in SCN2A that changes and can be reported? So the difference between the genome and a variant.
So this is a really, really great question. So when we do genetic testing, we compare to what we call the reference genome. So a standard genome for a person. But as this question rightly pointed out, we're all different people and we all have, different genetic background. But the sequence of SCN2A is so important and conserved going back, many species that even a small change in the gene compared to like the reference sequence is very conserved, like between people. So there is variation in the SCN2A gene in the general population, but these are not the types of changes that we are typically looking for on a genetic testing report or in a genetic testing lab.
Thank you. So 2 questions about ascertainment. And so the first one is, do we think that we're discovering loss of function more often? And then secondly, do you think that we're finding a higher fraction of individuals with seizures because they're more severe and being tested more often?
That's a great question. I think that we definitely were identifying the kids with more severe epilepsy and developmental disorders first, because those were the kids that was easier to get testing approved for and is more obvious to send genetic testing. So absolutely, for sure. I think as we're testing more kids with epilepsy, we're going to find more of the kids with milder forms of epilepsy and developmental disorders. And I think in the autism world, there's a lot more exome sequencing happening as well. So we're going to find more of the loss of function there.
Agree. And I think in general, especially in the kind of gain of function population, we're able to make that earlier diagnosis, and because of the seizures, and like give families that answer where it may take longer for individuals who don't have seizures, which I think is something that we as a community need to work on.
Thank you. Could you talk about the difference between an inherited variant, a mosaic, and a germline de novo?
Sure. So an inherited variant is one where one parent is found to, carry that same genetic change. And then there's a 50-50 chance for every child that they have that they pass on that same genetic change. And this is typically not the case for the more severe presentations in SCN2A, but can happen, especially in that self-limited neonatal infantile epilepsies. When we talk about mosaicism, what this basically means, it comes from, when you think of those mosaic tile works where there's kind of all sort of different patterns and colors across. So very early on in development, we start out as a zygote and we, rapidly divide. And if a genetic change happens, somewhere along that process, it's possible that only the cells that come from that cell that has that initial genetic change actually carry that change. So that means that there are some cells in our bodies that have that change and some cells that don't. And it can actually happen where someone may only have an SCN2A gene change in their eggs or sperm cells, which means clinically we would have no way to know that they have SCN2A gene change in their body, but when they go to have children, they may pass this on. So this is definitely something to talk about, with your care team, to talk about recurrence risks and what we call gonadal mosaicism. It is a phenomenon that's been seen before in SCN2A, although it is rare.
Or just add SCN2A is amongst the genes that they found the highest rate of mosaicism on the testing in the person that's affected by disease as well. And if you have a mosaic form, that could indicate a milder presentation, but there's still a whole lot of variability, and the rate of mosaicism in blood does not necessarily reflect the rate in brain, because it depends on where that cell started and divided.
Michelle, do we have any questions from the online? They've already been added. Fantastic. I thought the handwriting was familiar. And then one last question. And we're going to talk about the sort of cutting edge of distinguishing gain of function and loss of function and mixed in the next session. But from a practical point of view, sort of clinicians and geneticists, if an individual has one person telling them it's gain of function, another telling them loss of function, what would you recommend they do?
That's a great question. So I would suggest making sure that either you're going to a center or your primary physician that you're working with is able to talk to somebody who's worked with a lot of children with SCN2A so that they have a really good sense of the spectrum, and or connecting with genetic counselors, geneticists who understand the field. You can also engage in the research studies and hopefully eventually get some functional testing. It's not a clinical test that we can send, as we've talked about, so it's not an easy answer there, but having the actual functional testing eventually can be helpful as well. But I would say keep asking questions, diving into the research, and ask us for help. We're happy to help sort things out too.
I would agree. And, having that clinical expertise and background can help in, even in the absence of functional information, like knowing exactly what can go along with different categories can be helpful in kind of making that distinction. So definitely agree that, connecting with the larger community and keep asking questions, because there is more knowledge there to be able to pin things down a little bit more clearly.
The only other thing I'd add there too is that each child is their own little individual and they don't necessarily read the code book. So they may not respond to medications exactly as we expect them to based on what we know about that variant in that channel. And so being open to paying attention to the child.
Wonderful. That brings us time for a break. Before we go, I'd just like to say a big thank you to everyone who submitted a question. Especially thank you for writing clearly. Thank you for the audience being so attentive, but most of all, thank you to our wonderful speakers for their great presentations.
I just wanted to add for the other patient stories you're going to hear. So you heard Colin's with the early onset D. Lyanna is also an early onset D. Miles has a late onset developmental and epileptic encephalopathy. And Harry and Bennett are examples with autism and intellectual disability, predominant one with seizures and one without. Just to give some, you'll hear their stories.
Thank you. 20 minutes back here.
Yeah.
Hi there, is that Christina? If you could just enable me to, I think you disabled participant screen sharing. I can't hear you though. I think I can see Stephen. Hi, Stephen.
Hey,
Yes.
Andreas. Oh, okay.
I can hear you now. That's great.
Great.
Hi, Stephen. Hi. There's a bit of echo. And it tells me that the host disabled participants screen sharing. So if you could enable me to share the screen, because I can't at the moment.
Everyone could take their seats, please. We will carry on with the next session. That was my real accent, back to British now. So in our last session, we heard about the genetics, some of the clinical features we saw in SCN2A. And I think one of the major take homes from that was this concept of loss of function, gain of function, and then mixed in between those, a mixture of loss and gain of function together. In this session, we're going to dig into how those determinations are made, some of the biology behind it, and also some of the implications of that, especially as we start thinking of real world examples. Before we dig in and start hearing from our colleagues who are clinicians and scientists, we're going to start off again reminding ourselves with why we are here. And with that, I'd like to welcome up Miles' family to come and give us their perspective. And so a big round of applause as they come up, including three of our junior members.
Hi, my name is Lindsay, and this is my husband, Dan. Our daughter, Juliet, she's 9. Elijah's hiding right here. He's 5. And our youngest son, SCN2A warrior, Miles, who's 2.5 and pretty sleepy still. Some of Miles' nicknames are My Guy, My, and Smiley Miley. It took a long time to earn the Smiley Miley title, and we certainly enjoy every single second that he gives that to us. Right now, we are struggling to get those smiles, but have faith that one day they will return. The beginning of Miles' life is nothing short of unique. We adopted Miles as well as Elijah. They are full biological brothers, but do not share the SCN2A diagnosis. Miles was born on January 9th, 2021. We got to him on February 4th, and he was in the NICU for about 5 weeks. While in the NICU, it wasn't a pretty picture that was painted, but we weren't thinking the worst case scenario. We were told that he had a lot of physical markers that meant something, but in combination, we didn't quite know what. He had an ear pit, a high palate, low set ears, and a rocker bottom foot. They ended up doing some basic genetic testing while we were there, and everything came back normal. While in the hospital, Miles had major difficulties with eating. When we were discharged, we had been able to get him to feed enough from a bottle, but in hindsight, I wish we didn't leave the hospital without more answers. When we got home, feeding Miles from a bottle was torture for all involved. We pulled out all the tricks. No one could feed him but Dan or I. It involved walking and feeding, laying on the hard ground, sideline feeding, and any weird and unconventional way was the only way we could get a couple of ounces in him within an hour's time. This led us to our first of many specialists for Miles. The GI doctor quickly got an NG tube for Miles. We thought it was the best thing ever, except for trying to keep it in. And let's just say, as a mother or father, especially to a special needs child, there are things that you say you thought you'd never be able to do. And for me, placing NG tubes and Mickey buttons was that. This visit quickly sent us to our first neurologist visit. This was where we explored a lot of things that were going on with Miles that weren't making much sense. This included his feeding issues as well as his developmental delay. The neurologist ordered a whole exome sequencing test. The doctor said the results could be more impactful if a parent was tested as well, but this wasn't something we were able to do. I remember the visit of receiving the test results like it was yesterday. Life was so chaotic as it was, and in true cross-cuff fashion, we laid that on thick. We were having my youngest brother's wedding at our house 2 days after this appointment. The doctor walked in and asked if we suspected Miles of having seizures.
This was actually not one of the many issues we were up against at the time. He proceeded to tell us his gene mutation of SCN2A. The laundry list of symptoms on this report fit Miles perfectly, except for the seizures. Miles has a loss of function variant, but very much so presents as a gain of function in many ways. All of these factors left us confused and with so many questions and feelings of uncertainty. Miles went for a baseline EEG due to the diagnosis. The EEG results came back with no seizures, but a high probability of having one. Due to this, his doctor at the time said it would be a good idea for him to be on triliptol for a year and to see how it goes. In hindsight, me and Dan always say, you don't know what you don't know. And ultimately, this medication was not right for him, which he just recently got off of. Unfortunately, the one thing that we didn't think was on our radar showed up. During an occupational therapy appointment, our OT said she noticed something that she thought was an infantile spasm. I did not notice it. Dan didn't notice it. It was very subtle. Miles went for another EEG, and he, in fact, was having them. The first round of treatment was a high-dose steroid, and he was unable to finish this treatment because he was having a GI side effect from the steroids. He got almost to the end. This treatment did keep them away for about a month. I will not forget when they came back. I still feel traumatized from seeing it. He had intense stereotypical head drops and arm raises that would just go on and on. We did start stable then, and this seemed to be like the magical medication for him at the time. If we fast forward to today, his last EEG was just on July 10th, and he was not having any infantile spasms finally. But he is having myoclonic seizures. She said 4 to 5 per hour. Me and Dan looked at each other and thought that was a lot, but apparently it's not. Let's see. Oops. So currently Miles is in the middle of his storm. It came on suddenly and has been extraordinarily hard to determine what started it, why it continues, and what to do to help him find some relief. Miles continues to show us that he doesn't fit into a box, and he is very complex. After many conversations with his neurologist, we determined that he wasn't on the right medication and that maybe we weren't getting the quality of care that he needed. We did recently switch neurologists in April to Dr. Zierbro at U of M, and we now feel like we are in the absolute best hands that we can be. The start of this storm presented when we started to wean off triliptol, so we did play around with that a little bit, but ultimately he is now off of it. His current neurologist suspects that the triliptol had been intensifying his symptoms and probably brought the seizures on earlier than they would have been. Miles has been going through very intense agitation and irritability. It is more like a neurological rage. He tends to self-harm during these times, and you can see in these pictures that he goes for his face the majority of the time. Mittens or not, he makes his face bleed because he just repeatedly is hitting it. He recently started biting down his arm, which you can see in one of the bottom pictures, and just leaving it bruised. Thankfully, he has stopped that right now. He is constantly screaming or crying, which obviously he's showing you that he's not doing that when he's awake, or he was, without a list of sedative medications, which is what's happening now. He is inconsolable. He had a couple of hospital admissions to try to figure these things out, the last one just being last week. This has been going on since March, and it's been very difficult emotionally, obviously having us question at so many things and trying to understand what is going on with him. All of this just shows how complex in each and every variant really is. One of the biggest reasons Dan and I are able to advocate and get the best care for Miles is because of this foundation, including the Facebook group, which I ask lots of questions on and get a lot of answers. So as well as the town hall meetings, I know Sean has been a godsend for us because he's helped us get off triliptol, which was a big problem. And Leah in particular has been someone that I have been able to reach out at any time and get solid guidance on Miles' care, and that's priceless to our family. We are currently part of a program called Patch, which is where we have a nurse, physical therapist, social worker, and chaplain. And I honestly do not know where we would be or how we would be surviving the last 4 months without our nurse. We've become friends, and if we don't speak multiple times a day, it seems weird, but it also means Miles is doing good and it's a good day. And she is what we call our angel here on earth. Our family and friends are our army. They love and support Miles and our family more than we could ever ask for. Dan and I took our first stab at fundraising this year. It was a lot of work, but it was incredibly rewarding. We are just thankful that our family can do as much as we can to try to move the needle forward in finding something better for Miles and all of his warrior friends' quality of life. When we think of Miles, we can obviously say that he has disabilities. He is severely developmentally delayed, while at 2.5 years old, he presents closer to 2, 3, maybe 4 months old. He is nonverbal, immobile, and cannot eat on his own. He cannot sit on his own, crawl, or stand on his own feet. But this is not what we see when we think of our My Guy. We see a little boy that has the most contagious smile. I'm sorry. We see pure good and joy. We see a little boy that gives us the best cuddles. His hugs and snuggles can make you feel the most love. He has taught us what it means to love unconditionally. One of the biggest and most important things that he has taught our family is to not take anything for granted. Not even the smallest of things. When we speak words, eat ice cream, which we are all pretty good at, or just walk through our home, those are all things everyone does every day without a second thought. But if Miles does those things one day, it would be a true miracle. Something that Miles has done in his short life is bringing people together for good, to help better so many lives. Miles's purpose is big, and even with his disabilities, he will move mountains, as will all of our other SCN2A warriors here today. And I think Juliet would like to say something.
Sometimes it's hard with my brother, but I love him.
Do you want to say something? No. Thank you.
Thank you so much for that. And Juliet, what a wonderful summary. I would now like to welcome up to the stage Al George. I think it's fair to say that Al George has provided the functional data for more variants in sodium channels than anyone in the world. And so it is with great pleasure I invite him here to show us some of the work on interpreting loss function and gain of function.
Thank you, Stephan. Thank you all for being here. I have 10 minutes to give kind of an overview of determining, using experimental methods, the function of an SCN2A variant. I won't be showing individual variant results. It's not possible in 10 minutes, but I want to give a framework for how we do this and why we do it. I think already we've heard from other talks why we do it. We want to understand, first of all, is this variant capable of disrupting the function of SCN2A in a manner consistent with the condition of the patient? That's number one, establishing pathogenicity. It may also give us a clue, as you've heard, whether it's polarized functionally toward the gain of function spectrum or toward the loss of function spectrum. And that can help us also understand potentially whether an individual will respond to certain drugs or not. There are additional functional subsets other than pure gain and loss that we also can reveal when we do this kind of analysis. And I think in the long run, ultimately, as new therapies are developed, those therapies are going to be highly tailored to variants that are either gain or loss of function. And I think that's another very important reason to understand. Now, it's not possible to do an experiment on every discovered SCN2A variant. There are just too many of them. But the data we've generated can be used to help build computational models. And you're going to hear more about that in a later talk. Just for big picture, SCN2A is a sodium channel. It's a gated sodium channel. Its activity is modulated by the voltage in the cell and in the cell's membrane. And when a neuron in the brain is not firing, sodium channels are closed. They're not active at all. But then as soon as the neuron is stimulated to fire an electrical impulse called an action potential, sodium channels pop open and go into action. In fact, these are the major drivers of action potentials in neurons. They don't stay open very long. They shut down very quickly in what's called inactivation, and then they'll stay closed in that state until the membrane recycles until it resets itself. So this is the paradigm that we think of when we're trying to analyze the functional properties of a sodium channel. How does it activate? How does it inactivate? And are there properties even beyond those qualities that we can ascertain? So the classic way of assessing that is using this neuroscience method called patch clamp recording or patch clamp electrophysiology. And that can be done either the traditional way as shown on the left with instruments and expert individuals who are trained to do this, or one can use a now available automated method, which is what we've really embraced recently. And just to give a nutshell, when we're talking about sodium channel function, when sodium channels open, we get this big deflection of recording of current in the cell. And we can measure several parameters there, some of which you may have heard about. We can identify the peak of the current, what's the maximum amount of current conducted by that sodium channel. We can look at the size of the cell and then equate the number of sodium channels that must be firing into what we call current density. This is a standardized measure. And if you have more or less current density, you can start to interpret that as gain or loss. If there's no current density, clearly a loss of function. If there's a massive amount of current density, which is not that common, we could call that a gain of function. There are also some really nuanced properties. If the channels don't completely close after they open, you might have a small amount of residual current that we call persistent current that has also been identified in many SCN2A variants that we would label as gain of function. This shouldn't be there. This is an abnormal property. Now, that's just the very beginning. There's many more properties that get measured, and I don't expect anybody in the audience who hasn't been around electrophysiologists to understand any of this, but there's a lot of functionality that can be ascertained from a single experiment on sodium channels. And ultimately, we try to distill all of that information down into this very oversimplified, can't emphasize that enough, oversimplified spectrum from gain to loss of function. And the association with the diseases has been somewhat clear-cut, that early onset, neonatal period onset epilepsy is often associated with the gain of function mutations. Later onset neurodevelopmental disorders with or without seizures is more loss of function. And so that distinction is how we try to simplify everything. But there are many variants that have mixed properties that are difficult to classify into one of those two buckets. And that's where the field is right now. There are more advanced neurophysiological techniques to try to address this. They're not available for a high throughput strategy yet, but that's where we are. That's where we're moving. So try to getting away from this and trying to develop a more nuanced approach. Again, there are lots of SCN2A variants, most of which have not been studied functionally. This drawing here simply represents the nearly 900 variants that have been just reported in the scientific literature. In the ClinVar database, which is a repository for genetic discoveries in all genes, there's over 2,000 SCN2A variants. And in that group, there's probably over at least 1,000, maybe over 1,200 that could potentially have some functional consequence that could be determined experimentally. Unfortunately, the large majority of those variants are of uncertain significance. We don't know how to interpret them. Are they even the cause of the disease? And certainly it's difficult to look at them and interpret them as gain or loss of function in many cases. Now, one area that's near and dear to the family's SCN2A Foundation is their clinical trial readiness study. And in collaboration with Ann Burke and others involved in that study, we've made it a point that we will functionally test every variant in that study. And I think we've done that to date. This simply is a rough summary of how many of those variants are loss of function, LOF, versus gain of function, GOF, or have mixed features. You can see there's no pattern here. It's really impossible to predict that from just simply where the variants are located. But that's progressing very nicely. And this is just sort of an example of the volume of data that comes from this kind of work. The last thing I just want to finish with is these are experiments that are done not in neurons. They're done in another kind of cell that allows easy manipulation in the laboratory. And there are some definite advantages to using these cells in this approach. There are also limitations. So the key advantages are you can make very, very precise measurements in high throughput fashion using this approach. You can really understand subtle nuances of function, not just gain and loss, but get into more of the detailed channel behavior that's maybe present. And what we've noticed is that mutations don't all fall into the same bucket. They're all very different from one another. These systems experimentally can also be used to test drugs and test the effect of drugs on individual variants. And ultimately, one can use this to guide which variants might be most interesting to move forward to things that are much more expensive, like making a genetic mouse. The limitations are shown here on the right. It is slow. It doesn't happen overnight. It is not a clinical test. You can't order this at a hospital. And it's really limited to specialized groups who've developed the methodology like ours. Now, we're going to hear later in this session about predicting variants, and I won't belay that, but one could also make the same arguments of advantages and limitations. I think these are going to come up later. The major advantages, you can make a prediction right away. You don't need to wait for an experiment to be done. These are systems that have been trained based on experimental results from elsewhere, but it's ready to go. Whether that's accurate enough for determining whether someone should be in a clinical trial or a gene therapy is to be determined. So anyway, I think with that, I'll just share some acknowledgements of my group and our funding sources. This work has largely been funded by our soon to be ending Center Without Walls from the NIH and some former funding from the Safari Foundation. So thank you very much, and I look forward to the panel discussion.
Thanks, Al. That was fantastic. I'd like to welcome up our next speaker, who is Dennis Lahl. Dennis has achieved things with computers which many of us can only dream of. Today, we're going to witness a miracle where Dennis claims to be able to get through 53 slides in 10 minutes.
Okay, let's directly jump in. So it's limited time, right? So, you know, if everyone is there's anyone in this room who thinks this is interesting, we are hiring. So I'll come to this back later. So I have some disclosures. So I'm a researcher, but my goal is really to help people. And for that, I'm really, really keen to understand what companies need to run clinical trials. And therefore I have a lot of disclosures, and I'm happy to have more. And as my role of the director of the Center for Neurogenetics of the University of Texas, Houston, I'm really motivated to set up a clinical trial platform. So for all pharmaceutical companies interested in executing clinical trials, I'm happy to talk and get the trials going. Okay, so quick disclosure, this is not an educational talk, right? So I'm here to give you a lot of hope that the variant interpretation problem, there are people working on it, and this is not just me, it's like a big community of people here in this session, many funded NIH scientists all over the world, and we're working on this. And I just give you an example how that can look like, that what you receive from a genetic test result, where maybe experts are really uncertain what that actually means and how that can be, used in a clinical trial, for example, as an inclusion or exclusion criterion, or how that might even be a prognostic or diagnostic or be a prognostic marker. People working on this. And I just show you some frameworks around this. And if you're interested in variant interpretation, because you're a genetic counselor, physician, we're giving workshops, and the next one will take 3 days where I present probably more than 53 slides in Houston and after the American Epilepsy Society meeting. Okay, so why is variant interpretation important? Because, the most of the variants which you identify in clinical genetic testing, no one knows what to do with them. So, and this is including also for SCN2A. And it's important really to distinguish between the number of variants and the number of submissions. And this is what people typically don't do if they look at these databases. And if you look at the number of submissions, you will realize that even variants that have been seen before and have been multiple times submitted or looked at, people don't know what to do with them still. So, and this is where I have multiple members of my team just focusing on that challenge. So, variant interpretation is a slang. What we actually want to do is variant classification, and just from the variant side. And then, more lately, we are also interested in mechanism. So, and at the end, then it's up to the physician to make the decision how that actually relates to the person you see in front of you. And there you can bring a lot of clinical information about the disease, how that looks. And I will not talk about this today. So that's looking just at the variant, let's say after receiving the genetic test report. So really, you have the report and what can be done. Just a quick example. This is from an ongoing project where we helped Beacon Biosignals, and a project which is unrelated to variant interpretation, but they needed to interpret the variants, and that was presented yesterday. And here we applied a lot of say researchy ways to separate the variants. We look basically, it's really nerdy, the next 5 minutes, you can just believe me that a lot of things are happening. So you can look where the variant is located on the protein, and there's a lot of information from evolution which we can use and which has been shown in the past to be important. We can look where healthy people have the mutation. So even if that variant has never been seen, there are some regions where you don't see mutations in healthy people. We can use these algorithms, which we and others have developed as another layer of, getting a score if that is important. We can look where are actually all the patient mutations, and they are not random, they're not randomly distributed on the NAV 1.2 protein, so the SCN2A gene. You can incorporate this information. You can then do these things just not only in a linear, because you can do this actually on the molecule, which is the channel which does things. And you see, for example, that the pore region, so in this tube, in this channel, there are more mutations, and you can score this mathematically. And you can look at more databases, which, for example, companies don't have access to, because some of them are very researchy and they're gene specific, and we can access them. So we can even include information from other ion channels. So for example, other sodium channels, which basically mechanistically work exactly the same, but they do, their job in different cells. But we can use their mutation and their functional results, which has also been tested, and learn a little bit about what's going on. So also how these channels work and where these functional experiments, for example, from Dr. George, have been, tested, and where are they actually localized on the channel, can give also some information to understand about the biology. Long story short, there are some regions which are more likely to cause disease at a regional level than other regions. So we can incorporate this based on data from population, but also from functional experiments. And last but not least, and one of the most important findings, we can just look if the variant has been functionally tested. And there we can make access from the latest data, which has been just generated through the NIH-funded NNDS Center from L. George. And we can also look at the literature and their efforts to classify everything what has ever been done. And then you can develop a scoring theme, which is aligned towards guidelines from the genetics community. But you can score this a little bit more with all these additional information, and then you get a score for variant pathogenicity. So in this specific project, what was described yesterday, we could basically classify almost all variants into these categories, if they are pathogenic or not. And including those which were in the test report considered as uncertain significance. We could label them. Then we could even, change the classification in some of those in a negative way. So they were reported as pathogenic, but we don't think from our researcher perspective that they are pathogenic. And then we can apply a similar framework for variant interpretation in terms of what we think or could be theoretically for the function. And so here it's really important to also, to score the confidence we have, and is it truly a gain of function or is it truly a loss of function? And it's not binary, right? So first of all, this classification is already a little bit, let's say, crooked, but even within the classification, we have more confidence for certain mutations than for others. And we can generate like a similar scoring scheme. I don't explain now the details why this is important, but in long story short, you don't want to give someone who has a gain of function mutation something which is increasing the gain of function more, right? So we need to understand the disease mechanism. So long story short, we can incorporate also algorithms, what just mentioned, in as one marker out of many. What the variant is doing, we can look if it's a region. For example, here are functionally tested variants on a sodium channel, and you see that the blue bottom is more likely to be gain of function, whereas the red upper area, the functional tested variants are more likely to be loss of function. And you can factor in this information. We can also include more research findings because we can look where patient variants are located, and because certain expressions of the disease, certain types of disease which you have due to a mutation are associated with the underlying disease mechanism of the variant, and we can also cluster this on the structure, but I don't want to go too much into detail. So, and again, we can, as a strongest support, take the information if the variant has been functionally tested, and that's literally the strongest information, and use that also as a strong factor in the scoring scheme. Then we can score all, variants which we ever see, and then sort them here into different groups. Okay, so 1 minute. So, and then we can put this into guidelines. And just, I really want to show something researchy, which I've never shown. So, and then but more recently, we have one person who is spending 2 years, Nisha, a very talented postdoc in my team, to do molecular dynamic simulations. So what she's doing, basically, she is taking a mutation and is putting it on the channel. And then she's computing for literally 3 months on a supercomputer and see what that mutation is doing on atom level. And then you get these funny videos here on the top right. And we did this for many patient mutations and then see what's actually happening. And I don't have the time to go into detail, but you can see if you have loss of interactions, or you see if the whole channel is not working anymore. And we can for example, and can see that the agreement with functional tests data and so on. And we have actually quite interesting results for this. And then unfortunately cannot go too much in detail. Okay, so long story short, yeah, but I'm here all day. And but this is researchy, and please. So the point I want to make in this very heterogeneous audience, right, is we are working on this, and the path towards clinical trials is not clear-cut in terms of patient selection, but there is a large group of people with very different also opinions, which is good, how to do this, and we are aligning and we're trying to resolve all the issues. Okay, so with that, if any of this is interesting, please talk to me as just about the research, or if you think this is an interesting job area, we are hiring. So thank you very much.
Great. Our next speaker is coming to us live from Glasgow. So there's going to be an echo, a slight delay while we set this up. It was suggested that I should do a dance, but that's not happening. But fortunately, I think Andreas is here, and I'm going to stay away from the microphone.
Can you hear me? I can see and hear you. Can you hear me?
Yep.
Great. Thank you so much for giving me the opportunity to attend to that. I'm really sorry that I can't be there in person, but I really would like to, can you see my slides? Very good, excellent. This is running very smooth, that's excellent. And I try to do all of this in 10 minutes to have some time for discussion. So I'm a child neurologist in Glasgow, and I've been really researching sodium channels for quite a number of years now. And really what I would like to bring to this video is the clinic and how we can use information that we have from other sodium channels to actually help us to predict some of the variants that we find. And the learning objectives really are to describe how in silico prediction tools can aid clinicians to predict the disease phenotype and variant function, and also to understand the limitations of these prediction tools and the value of good clinical characterization of the patient. And if you're interested in this, please have a look at our podcast that's recently been published, where we really talk about this work in a bit more detail. So I really would like to start with just raising your awareness that, of course, there's quite a number of different sodium channels, and we can really learn a lot from other sodium channels. So sodium channels are really important for initiate action potentials, the nervous system, but also in skeletal and cardiac muscle. And you're very, of course, very, very versed with SCN2A, but you have, for example, SCN4A, which is expressed in skeletal muscle. You've got SCN5A, which is expressed in the heart, and then you've got other sodium channels that are expressed in the peripheral nervous system. Yeah, so there's many, many sodium channels, and what's important is that they all share really the same structure. And you will have come across similar cartoons today already, where you've got these 4 transmembrane domains, and you've got the pore loops, you've got a voltage sensor, and you also have got what's called an activation gate, and that all assembles in the cell membrane to an ion channel where the ions travel through. And let's take this to the clinic. So let's say you are let's meet Emily. So Emily is a previously 3-month-old child who presents with a cluster of seizures and involving bilateral clonic movements of the upper and lower limbs. And there have been 5 events over a 2-hour period, and each lasting about 40 seconds. And then the parents remarked 1 week earlier they noticed some abnormal facial movements and clonic jerking of the eyelids and lower lip lasting a few seconds. So she's made poor developmental progress since the start of her seizures. There's no family history. And then what you think, and most clinicians would think in a child very young with presenting the seizures, we would like to consider genetic testing. And what you find is that Emily has got a pathogenic SCN2A variant. But of course, what you don't know is at that stage what the future might hold for her. So what we know from the different phenotypes, and you will have had some explanation of this and reminder earlier already, that there's these 4 different groups. One is the benign neonatal infantile seizures that are mostly self-limited. Then the encephalopathies, these are really severe early infantile seizures, less than 3 months of age onset. Then the encephalopathies with later infantile onset after 3 months with infantile epileptic spasm syndrome. And then the 4th group where we have intellectual disability and autism without epilepsy. And thinking about the genetics of this and the gain, whether they gain or loss of function, it's just a reminder of the previous sessions that these are de novo variants. And in the early infantile developmental epileptic encephalopathies, these tend to be gain of function variants. And that means that the channel, for example, cannot close. There might be just too much firing through the channel, and this is then a gain of function. However, if you have the late onset epileptic encephalopathies with autism spectrum disorder, those are loss of function variants, and they present slightly later. And for example, the channel cannot open at all, and there's not enough firing through the neuron to the nerve cell, and then you have a loss of function. And when you summarize this and looking, for example, at SCN2A, so if you have those patients presenting with early onset, often before than 3 months, presenting with gain of function, and you would treat patients like that with sodium channel blockers. And if you present after 3 months, you have different seizure types, you have a loss of function, and often you wouldn't want to give sodium channel blockers. So if I now take you back to Emily, who presents at 3 months. So based on the clinical presentation, would you say Emily has a gain of function variant? Would you think she has a loss of function variant? Or would you say you don't know because she's presenting just at the threshold where you don't know what presentation she might have? And this then leads to the question, would you, for example, would you start a sodium channel blocker in Emily at this stage? Would you want to request functional testing prior to starting sodium channel blockers to be absolutely certain of what you're dealing with? And of course, you would like to do that, but of course, time is brain. So the time scale for functional studies is about 6 to 12 months time. There's a significant cost. We have very few laboratories can actually do this worldwide. And clearly there's a mismatch between the high demand and very limited supply. But what we know is that early precision treatment has really the potential to improve quality of life. So this is where the in silico prediction as an alternative to conventional biophysical testing in the laboratory comes into play. And this is a paper by Henrike Heine that we collaborated with, where Henrike looked at predicting the functional effects of missense variants in voltage-gated sodium calcium channels. And she uses basically the disease phenotypes of lots and lots of patients with different voltage-gated sodium calcium channel disorders. And from the disease phenotype, she infers what the function would be. And then uses some machine learning models and then validated this approach really by with actually functionally tested variants. And she comes up with this map where you can see basically across the cartoon that all those areas that are blue are loss of function, those in red tend to be gain of function. And if you put this, for example, to Emily's variant, you get a prediction of this might be a 62% gain of function. Now, what we've noticed is that, of course, all these sodium channels are really closely related. And you can see here, they're all the different sodium channel genes and the protein sequence. So they're really, really similar. They only differ by a few percentages. And when we looked at different variants and different genes, for example, SCN1, 2, and 8A, we could see that actually the variant location can serve as a surrogate for function. For example, if you have an SCN1A at one particular location, a gain of function has been proved to be gain of function. If you look at SCN8A at the same location, the same variant causes also a gain of function. Yeah, with a different phenotype, but the functional consequences are the same. For example, then if you find at a certain location SCN1A, a loss of function that gives you another epilepsy called Dravet syndrome. However, if you find at the same mutation SCN2A, you find again a loss of function, but an SCN2A loss of function will gives you an autism spectrum disorder. So we then looked into this and said, why don't we look at all ever published functional tests and experiments on any sodium channel? And we've done that and really were able to create a map of sodium channel variants across the entire protein that allow you to actually say at this particular point, we've got this variant and this variant has been described as having this function. You can see all the ones in blue are the gain of function and all the ones in red are loss of function, the mixed function. What's interesting is that we found 38 variant pairs, meaning across different sodium channels who are identical. And what we found is that if you have the identical variant, for example, in SCN, second row SCN4A, you've got a loss of function, which gives you a myotonia, and SCN5A, this same variant also gives you a loss of function and causes you an arrhythmia. Or if you have, for example, in row 5 in SCN2A, you've got a loss of function that presents with autism. In SCN5A, at the same position, you also find a loss of function that gives you Brugada syndrome. So if you have the effect of one location, you can actually infer the effect of that particular variant in a different gene. And here we've compiled with the help of Dennis Lyanna's group this into an SCN viewer, which basically illustrates all the 430 performed experiments. And then you can look up whether a new variant that you found, whether this has actually already been functionally described in a different sodium channel. And if you do this, for example, for Emily, so you have previously the functional prediction was that this would be 62% gain of function. If you now look at the SCN viewer, what you will find is that there's actually two identical variants at exactly the same position, SCN4A and SCN5A, And these have both been described as being gain of function in experiments. So with this newly acquired knowledge, that take us back to Emily. So based on the clinical and now the new in silico presentation, would you say Emily has a gain of function variant or loss of function variant, or you don't know? And if you think you've had some, some indication that this might be gain of function, would you now be more confident to start, for example, sodium channel blockers? And would you still want to request functional testing prior to starting sodium channel blockers, for example? However, if you take this a bit further, then the question was, of course, would you enroll Emily in a gene therapy program? And would you want to request functional testing prior to enrolling her in a gene therapy program? So starting a sodium channel blocker, you can, of course, then stop the sodium channel blocker. But starting a patient on a gene therapy program, that has got different implications because you cannot undo that. So in silico prediction is not perfect. So we have clearly it is accurate. However, particularly if you have mixed function, that's difficult to predict. Sometimes you can have trafficking differences. This is how the channels travel in and out of the cell membrane that can differ. So the predictions differ as well. And you find that in certain sections of the protein, that's much more difficult to predict than in others. Yeah, and we also know that some variants have been described as gain of function. However, they do not respond to sodium channel blockers, and we don't entirely understand why that's the case and whether this might be due to mixed function. So I think the current tools might be sufficient to inform anti-seizure medication choice, as these tools are accurate enough to, but are they actually accurate enough to inform gene therapy treatments? I don't think we're there yet. And I think that not all patients respond to sodium channel blockers, despite gain of function effects. And we really require better functional maps, really based on experimental data. And I think Al has done a lot of work in this field and contributed to this. And I think that these newly emerging tools, and there are other emerging tools that actually consider the protein structure and effects on function. And what we really need to consider is the clinical and functional data together. That's really, really important. I think that brings me to one of the last points, that we really need to start having really organized epilepsy genetic case discussion meetings where we know that we've got so many more variants and mutations that we find, and they will be classified according to the pathogenicity by our genetics colleagues. However, now we also need to discuss what is the evidence of functional consequences, what can we predict, what is the clinical presentation that is really important. So we really need to have case discussion meetings where we have experts that involves clinicians as well as geneticists and scientists and functional expertise to really come to a conclusion on how to characterize a variant, whether it might be gain of function, and then also make the consensus decision on which treatment might be the best treatment for that patient. And that's just an overview of these freely available and silico prediction tools that I really highly recommend clinicians to use. And Dennis already showed the SCN portal. And finally, I really would like to thank all our collaborators, particularly Dennis and his team, but also international collaborators in making this work possible. Thank you.
Wonderful. Thank you, Andreas. I'm going to step away from the microphone. Thank you, Andreas. Could I invite our speakers back up here to take some questions? For those in the audience, you now know the drill. Please write down on the cards. They'll come up to me and we will put them to our speakers here. Andreas is going to stay online, I think. Andreas, can you hear us? Get rid of that echo.
I've just been muted. I can hear you.
Oh, yeah, there we go. Fantastic. Well, as the questions I'm going to put the first question to Al. Can you explain the mixed category?
Can I explain the mixed category?
Can we kill that echo?
Yeah, I'm not sure. Just on him.
We measure about 10 different properties for each variant. They're not all harmonized. Sometimes there's a mixture of properties. Some of the things we measured are tipped more toward loss of function and others are gain of function. Those are the more complicated ones. And we're probably not smart enough yet to figure out which is the driver of each variant's clinical consequence. But that's the in essence. So essentially, we're not just measuring one thing, we're measuring a multitude of things. And the ultimate interpretation of, is it a net gain or a net loss, sometimes is very challenging. And I think that's the essence of the answer.
Thank you. There is a request for the tool links which Andreas showed. We will share those after the conference. I'll talk to people about maybe that coming as an email. Here's a question, I think, for all of you. How should we use these tools to weigh our decision about participating in clinical trials? Who'd like to go first? And Andreas, maybe if you take the first shot at that, I think it's probably most direct.
Absolutely, that's a really, really important question.
We can't
hear
you. Andreas, I'm going to ask one of the other panel members while our AV staff work on that. Dennis, should we put that to you? How should we use these tools to make decisions about participating in clinical trials?
Can you hear me? Okay. So I think in general, for clinical trials, there are protocols which are developed by either the executor of the clinical trial, and typically that includes then also experts, so that there is no individual decision. So each clinical trial will have a list of people of criteria and inclusion as well as exclusion of how someone or who can participate. And you might have, for example, on a molecular level, clear as cut gain of function variant, which has been tested, and you represent also clinically with that. But you might have certain allergies or like a brain tumor or something else, which would not make you eligible for that clinical trial. And this can only be assessed by a group of experts who know the disease very well, and that will then, in that situation, then make a judgment call. It's a very complex decision.
Thank you.
Yeah, I would agree with that. I think in a perfect world, we would know everything possible about the behavior of a variant before enrolling a patient in a trial that has potential dangerous adverse effects. That said, we have people in the audience who represent companies who are actively doing clinical trials for SCN2A. And I know that the online description of clinical trials from Praxis does not include any of these tools. It's based on what they have, which is the age of onset and the phenotype, which is the enrollment criteria. And I think that's all we really have right now, as a sort of, you could take a nihilistic view that all treatment is kind of empiric to begin with. And even with the best knowledge, it may still come down to trial and error. Now, that gets a little dicier if you're talking about giving a viral vector to somebody that's going to be in their genome for the rest of their lives, and you can't turn it off. That is a little bit of a different situation. But if it's a drug that can be washed out, it's a little safer. So I think it's mostly important for when we're talking about doing disease modifying therapies that modify the genome of a patient. There, I think the bar is much higher, and we should know as much as we can about variants that are carried by patients who are eligible for those trials.
Thank you. Andreas,
I would say, can you hear me?
I'm afraid you're still silent. Sorry. Al, a question to you. With automated patch clamping, is it possible to do high throughput drug screening?
Yes, actually, high throughput patch clamping or automated patch clamping instruments were originally designed with the pharmaceutical industry in mind, and that was their original market share. We just a few years ago decided to do something completely different and repurpose this instrumentation for studying large numbers of genetic variants. So we can always go back to look at drug effects on individual variants, and we do that from time to time, and that's been somewhat fruitful. Yesterday, for those of you who were at the research roundtable meeting, Madeline Odin from Tufts University, who's a parent of a child with an SCN8A, unusual dual SCN8A variant. We were able to demonstrate the functional effects of that, and are ready to start to do some testing in vitro of pharmacological agents.
Thank you. Our next question: if two researchers have different conclusions, one says gain of function, one says loss of function, what should a family do? Andreas, do you want to go first? Hopefully you now make noise.
Can you hear me?
Try again.
Okay.
Yeah, I think what's this also feeds into the last question. I think the clinical presentation of the child is really important. So I think this should be, and we know a lot about clinical presentation, and we have, from the clinical presentation, you have a hypothesis of what the underlying function for this child might be. And if you then have basically a prediction from your tools that actually is in keeping with what clinically you think, I think in that sense, the tools can be really useful to confirm your clinical judgment. And I think it would be, if there are two researchers who debate about the functional consequences, I think you shouldn't really lose sight of the presentation of the patient. I think the clinical presentation of the patient will be really key to identify and to see what is more likely in that scenario and what the presentation is like.
Dennis, anything to add?
Fully agree. I think so the caring physician is the person who to make a decision on treatment, and that person then needs to evaluate the level of evidence and opinions, what is there. However, I can really recommend everyone in this room to be at academic centers where people have a big interest in SCN2A in particular, because the more people spend time on caring for people with SCN2A, the more time they will spend at events like this, and then maybe on more researchy versions of the, meetings like this, and the more cutting edge knowledge they will have. So, but at the end, the caring physician is the person to make the call, and because they, that person can also understand the medical history, the drug history in particular, and all kinds of other factors which can have strong implications on treatment choice.
Al, anything to add?
No, I think that was well covered.
Fantastic. I would say keep asking. Like, this whole thing is in flux, pun intended. Sodium fluxes through the channel. And so the knowledge is moving rapidly. Keep asking if you're in that situation. Eventually, hopefully, clear answers will come. How do we know when a predictive algorithm is ready to be used in a trial? Dennis, do you want to start on that?
Yeah, so that's super tricky, right? So at the moment, so this is strategically, for many reasons, very tricky. So if you develop a drug and you put, for example, an algorithm in your enrollment criteria, there is a chance that this becomes a so-called companion diagnostic, so that you can only prescribe the medicine in combination with that algorithm. But however, the algorithm needs to be approved, and it's long procedure, which is not so easy in a disease area where a lot of things are evolving very fast. So it's a little bit unclear. At the moment, the trend, and this observed in, for example, in genetic test interpretation as a whole, is that the interpretation is becoming more standardized. And there's, for example, the American College for Genetics and Genomics guidelines. And actually, many people from us are involved in a specific interest group for variant interpretation for voltage-gated sodium channels. And where later this year, the latest guidelines, how you interpret variants, will be submitted. And from that on forward, hopefully all over the world, people follow these guidelines. However, they only consider at the moment pathogenicity and not function. So we as a community need to find intermediate expert agreements to approach that in the interim, but midterm, and midterm is like 5 years or so, there will be likely guidelines how to assess function published, and people hopefully will adhere to that.
Andreas.
I would say that, again, so we use, how do you decide whether a test is ready to be used in clinical practice? So first of all, this needs to be validated. And we use clinical tests in medicine all the time. And it's about a matter of how confident we are, how specific or sensitive a certain test is, and what is the purpose of the intervention that you base on that. So if, as Al highlighted earlier, if you're considering somebody for a gene therapy trial that is an intervention that is not reversible, then you need to be very, very confident. And you might find that the tools that we have at the moment do not reach this level of confidence, and you might actually revert to functional experiments. However, with time, we might develop tools that are quite highly confident. But this is really, you wouldn't just use one criterion alone. I think what has to be really come out of the session is that you never use one criterion alone. You really have to use the clinical presentation of the patient, the response to medications already, and then the prediction models, and all of that together hopefully will give an expert an overview, and who can then make a judgment of what the most likely consequence or the most likely underlying functional mechanism is.
Thank you. And our last question before lunch, Al, what mechanism do you see for doing the in vitro functional testing as the population grows? How is that going to be done in practice?
Well, again, I think that we've spent the better part of the last, 7 or 8 years honing this use of automated patch clamp to improve the throughput by a factor of 20 to overcome this burden of variants that are found. We can't keep up, so there may need to be another strategy. So one strategy which has been proposed for other genes is, rather than react to variants that have been discovered, one at a time as they come off the genetic testing pipeline, we should just come up with a strategy that allows us to make every possible change in the protein and then classify it by some bulk assay. This is a process called deep mutational scanning. It's been applied to certain proteins, and it's been thought to be the next wave of analysis. So in essence, you pre-predict what the function is of any variant, even though it's not been discovered yet. And then when a variant is discovered for the first time ever, a geneticist can go to a table and look it up. Now, that sounds wonderful. It turns out that, again, for a sodium channel, which has very nuanced functional properties, you're not going to get that kind of granularity of functional evidence. You're going to get a very, very washed out picture of, does this kill the channel function or not? And that may be useful. Maybe if we can figure out in advance all the possible loss of function mutations, that will take care of that side of the story. These nuanced forms of gain of function, I think, will be much more challenging to discern without doing something detailed like an electrophysiology experiment. So I think we're really just limited at this point by time and the usual things that relate to resources to fund the work. But yeah, deep mutational scanning is maybe on the horizon to try to overcome these barriers.
Wonderful. Thank you so much. That brings us to the end of this session. There was a request to learn more about the Molecular Dynamics project, which does sound fascinating, but so does lunch. So I'm gonna offer Dennis, as anyone would like to know more about that, which it does look amazing. Please do come and talk to Dennis here. For the rest of us, food is available in 2 locations. It's in the foyer just outside here, or if you fancy more of a kind of vacation vibe, on floor 5 by the pool in the courtyard, there's food there as well. And you could eat that in the pool, maybe. I mean, don't say I said that, but give it a go. We will start again here at 1 p.m. sharp. Okay. And we're going to start off with a family story. So of course we all want to be on there on time. Thank you and bon appetit. Thank you all.
Carson, how are you? Thanks for your help today. Oh, perfect.
All right, everyone. We're going to get started again for our next Why We Are Here story. Carson, floor is yours.
Hi, I'm Carson. I'm 20 and I'm from Oxford. This is my mom.
Hi, thank y'all for asking us to come speak. Like you said, he's Carson and he's 20 and he is from Arkansas. And so Carson's story started a little bit different than what we had planned. We spent 154 days in the hospital prior to him being born. He and we spent a lot of time hanging out. And then on February 4th, which seems to be a big day in a lot of people's lives that we've learned today, he had a very prolonged fetal heart deceleration to about 40 beats a minute that lasted for quite some time. We had an emergency C-section with a hemorrhaging umbilical cord. And he was immediately transferred to level 3 NICU. And by day 2, he was on, he received his first dose of anti-epileptic medication for seizure-like activity and extreme irritability. And that extreme irritability followed us for a little while, didn't it? Because we're a little overwhelmed at the moment. And we stayed in the NICU about a month, and this is when the day we came home, and that's about what most of our days look like. That kind of explains a lot right there. But the road to our diagnosis was long and windy. Our initial diagnosis was listed as global developmental delay and hypoxic ischemic encephalopathy. By 2, he weighed 14 pounds and was diagnosed with failure to thrive. Right after his 2nd birthday, he was diagnosed with an intestinal malrotation that we had repaired with the hopes of this is going to fix this crying that we did roughly 23 hours a day, except for the little bits of time that we would kind of crash and fall asleep. We cried and fussed. After that, we didn't see the improvement that we really thought we were going to see when we fixed his malrotation. And he was then diagnosed with eosinophilic esophagitis. And then we thought, okay, we're going to fix his belly again. And this is going to help the irritability get better. It's going to help some of these things that we were seeing improve. And then it just didn't. Later that year, a little before he turned 3, he was diagnosed with autism and was nonverbal. And right before he turned 3, the seizure activity really became more apparent. The things that we were seeing early on became very obvious that he was having more seizure activity every day. And they varied from facial jerking in that bottom little corner picture. That's kind of one side would get tense up, the other side didn't. You could see that happening. And then he would seize a lot of times when he was trying to eat, which eating was always hard because of all of our GI issues. But then he would choke because we would be eating and then choke. And so that was what most of our days looked like. If we didn't smell like vomit, it wasn't a full day. And that was one of our big things that was going on. And we had multiple seizure medications, and all of them failed. We never really gained any true seizure control. And we started genetic testing in about 2005. Which never really showed us anything. And they kept saying, please come back. We had this really great geneticist that we worked with, and they would say, come back, just keep coming back. And we said, okay. And we did till about 2013. And then I said, we're taking a break for a little while, and we missed it. We kind of fell into that gap and didn't get a diagnosis until much older. And so what we knew and what we didn't know, we knew that Carson continued to have seizures, more seizures than we could count most days. We were just talking at lunch, and we really just counted days that we maybe didn't have a seizure because they were so few and far between. It was easier to count than 1, 2, 3, 4, because that would be what our days look like. And the most medications we tried either failed or the side effects were so horrendous that we had to stop the medication. And when he had seizures, he would lose most recent memory and all of his educational milestones. The school would come out and go, this is what we did yesterday. And it's all brand new day today. Every day was a new day. That's what I would tell people. Every day is a new day. Anytime that he got hot, he had more seizures. And so he's going, anytime that he got startled, he would have a seizure. So if you just said, Carson, like yelling at your kid across the house, we would start a string of seizures at that point. If we dropped something in the kitchen or if something would have fallen on this floor, we would start seizing. And language was very hard. That was one of our biggest things, because he was frustrated because he didn't understand why we couldn't understand him. And we use lots of communication devices. We use different kinds and we use different methods, and he would really try hard. It was just really frustrating. And what we didn't know is what the future would look like. We didn't know if we would ever maintain any kind of seizure control. And we didn't know if he would ever be able to communicate effectively, like I'm not doing at the moment, with us and with his friends and with people in our community. He really had great ideas of things he wanted to do, but I was like, we've got to find an effective communication tool in order to get you there. And so these are just some pictures of our days growing up. The medications weren't working, so we tried a lot of things. We started EI at 4 months old. We did all those services at our house and at the house of his great grandparents, because that's who watched him, because we worked all the time. Nothing came very easily, but we made it work. At 2, we transitioned to an integrated preschool, and he got OTPT and speech through our education co-op. He entered kindergarten at our local public school, and I stayed in public school. And that's a question we've had several people ask today. Are you still in school? We are still in school. At that point, he started kindergarten in a general ed kindergarten class with some significant supports. He started kindergarten nonverbal and still wearing diapers. But we got over that. We made it, didn't we? And he stayed in gen ed school classes until with a heavy supports until we moved to a much smaller school district. And that smaller district had smaller classrooms, which made life a little bit easier. And we were able to back down some of those IEP supports. He's currently, we call him a super senior in Arkansas. And so we're currently a super senior, and he's still receiving services under IDEA, and he will for another couple of years. He's also on the state's home and community-based waiver program. And here's my soapbox of that. If you're not on your state's home and community-based waiver wait list, please call somebody. In Arkansas, the wait list is 10 years. And so we were on the wait list for 10 years and 4 months and 28 days. And so he does receive services there, and he and Miss Anna, they go running around. They go to Spencer's Gifts, because that's our favorite place to go, and Books A Million and the library. And so those are his things to do during the day. But these are just Carson. And one of the things, Carson always likes to travel. He's a good traveler, and that's going to be really important here in a minute. And these are a couple of the teachers that really made a big difference, and folks that he's just really likes hanging out with in his life. And that group of friends up at the top, they are buddies, and they've become friends with alternate ways to communicate with their friends. And so they texted a lot, and they wrote, we still pass notes at school. He would get in trouble for passing notes at school, not for talking in class, because that was hard, but we could pass a note. And so those were our best buddies. And then we finally found the why at 18 and a half. Right before we transitioned out of pediatric neurology into adult neurology, they said, let's do this one more time. And I said, okay. And so we did. And I happened to be in the hospital the day we got the phone call that said, here's what's going on. And the first thing she said is, don't go online. And so my phone hadn't hit end, and we were online. So we got on Google and we looked things up, and we figured out that all these things we had seen for 18 years that we kept thinking, there's no way this is made up. I can't make this make sense. None of this all lines up for us, all made perfect sense. We had an autism diagnosis. We had autonomic dysregulation that was through the roof many days. We had diffuse epileptic encephalopathy, GI dysfunction from the day we were born, an intellectual disability, motor delays, sleep disorders. We never slept through the night until recently, and speech and language deficits. And we met with several geneticists and neurologists, and they all kind of feel it's a gain of function based on some of our presentation and med history. And so now what? So we got a diagnosis and then what do? You look at this and go, now I've got a grown son with a new diagnosis that I didn't expect to happen. Our thought was, we'll do this genetic testing. It's going to stay the same. No, when they said that earlier, please, no. If it's been a long time, please go back. So we came to the conference last summer with one goal in mind, and that was to find a study. We're going to find a study and we're going to figure out what we're going to do. And so we happened to sit by a group of people, and we all sat and we all visited and talked, and we started talking about some of the upcoming trials that were available. And so I read a lot and I Googled a lot and I researched a lot in a very short number of days. And so we left that conference on Saturday, and on Monday I started calling people. And so Monday we called someone and they said, somebody will call you back. And they did. And in the world that we all live in, having somebody call you back that fast is sort of amazing. So we got a phone call later that day, and we were at a research center within about 7 days. Within the week, we had our first visit. And so, when I said Carson was a good traveler, and that's really important, this is why. Our first trip to the research center was on August 11th of last year. So shortly after we had been here and gone back and forth and sent records and got everything taken care of. We've made 17 trips from Central Arkansas to Gulf Breeze, Florida. And that's about 1,084 miles a trip. If you leave my house at 3 a.m., you will make it to a 1 o'clock appointment. We have it down to a science. There's a Chick-fil-A in the parking lot, and we will pull into that Chick-fil-A at noon, and we eat us some chicken and some waffle fries and jump back in the car and drive across the parking lot. That's been 18,428 miles that we've driven. We've gotten a new car because the old one just wasn't going to make it. And 1,372 data journal entries. We have what we call the seizure phone, and every day on the seizure phone, you put in all your doses of medication, kind of seizures you've had, if you've had any seizures. And we did 4 months in the first phase of the trial that we were in, and 7 months so far in the second, and we're still trucking, aren't we? Carson, what's the visits look like? A lot of people have asked today, what does it look like when you go? Carson has a supported decision-making plan instead of guardianship. So he has to sign all of them forms, and the folks there have been wonderful about going through, day one was 54 pieces of paper. And that was not a fun day for anybody. He remembers that. They'll bring out a few and he's like, oh. But he does, and they've been really good about explaining everything, working with him as his own person. And so he's been a key player in determining his role in the study. If he wasn't going to do it, we weren't going to be able to. Yeah. But once the paperwork's completed, they always do more assessments, lots of lab. We're pretty good about letting people stick us too, which makes life a little easier. And then they always give us new meds for the next time. And so we've got all that figured out. They send us home with coolers full of medicine sometimes, and then we start anew the next day. And so what does it look like today? This is Carson hanging out with his sister because I'm no longer cool. We've got seizure control. What we're seeing now, we started out with more seizures than we could count. They couldn't get through the assessments because they would have to stop and let him finish having a seizure every time we would try to do something new. Please don't try to look in his eyes with a flashlight to look at his pupils, because that's going to start it. You can't stop it some days. We're currently seeing 1 to 2 seizures a month. The last time we had to take emergency seizure meds is in between those 2 pieces of the trial. They had to wean one to restart the second. And that was the last day we had to take meds, was on the day that we were at the bottom. Called them and said, oh my gosh, we got to do something. They said, oh no, got an override to be able to move on. Let's go. We need our medicine. And he's sitting here telling me, I need 4 meals. And I'm like, baby, you can only take 2 today. He knew right then. He sleeps through the night. And when you've not slept through the night for roughly 20 years and your child sleeps through the night the first time, that's the scariest morning of your life. And you jump up and run through the house, and he's just like, leave me alone. He sleeps in. That's pretty exciting. He can manage to be at home by himself for a little bit. That's something new that we didn't really think was in the cards for us, with some of this independence. You've probably all seen him. He just kind of, I need to go to the bathroom. And so I said, okay, here's the thing. Luckily, we sit by the table with the really blue tablecloth outside. And so that's been handy. Go to the blue tablecloth. We're right inside here. So doing some of those things on his own. He wants to go places. He told me the other day he wanted to go to an arcade in Little Rock. And I said, I just got home from Little Rock. I'm not turning around and going back. And he goes, oh, I'll call an Uber. And I said, you will what? It was a joke. And so that's come along too, you know. So we finally decided calling his sister and going to Target, and the boba tea place was okay. Maybe not an arcade, but it was cool. But the things that he's doing now, he calls me on the phone and we'll start the conversation with, I really hate to bother you at work. And I'm going, number one, you just called me. And number two, you hate to bother me at work. Holy cow. He talks to his friends on the phone. We'll be in the living room and going, what is he doing? Because we used to hear a lot of jargon and stuff going on, but now we're like, he's talking to somebody. And is this a person, or are we talking to somebody online? Because that's a new scary thing we didn't know we were doing. We understand jokes. We tell jokes. We're snarky. and he's got a pretty good sense of humor. Yeah, he'll tell us funny things, and it's just very different. And that piece of communication that we didn't know we were going to get was our game changer, honestly. And so really what I wanted to tell everybody is, you know, we've had a really different road than a lot of families that we've met, but don't be afraid to ask questions. Ask questions of people you didn't think you would ever like just call on the phone. Call people, ask them, try to find the answers that you need. Don't be afraid to look outside your home state or your home region for help. That's kind of a scary thing. A lot of us are used to the world of Medicaid, and we know Medicaid typically is pretty much state line bound, but these are different. Call people outside your area, call people outside your state, figure out, you know, where you need to go. They gave us, we were right in the middle of two research centers, the exact same mileage each way. And one was St. Louis and one was Gulf Breeze, Florida. And they said, which would you rather go? And I went, Florida. There's sand involved most days, you know? And so that's kind of where we made that decision from. And you're your child's biggest expert, and you know what's going on, and don't let people make you feel like you don't. And you're their voice until they find their own. And someday they might, you know, we didn't know we would. And now we do. And he tells me, he talks back. Yeah. And if you need help making decisions, look for people to help you. There's folks out there, and sometimes it's hard to ask. Sometimes it's uncomfortable to ask and go, I just don't know what to do. But it's okay. So we appreciate y'all having us, and we appreciate this. This is huge. Do you have anything else to say? No, are you done? You'll get me out of here. Grab your notepad. Thank you. Can you remember here?
Incredible. Thank you, Renee. Thank you, Carson. I thought about trying to do a British accent for this session too, but I'll hold off. I don't want to embarrass myself. So this next session, we're going to learn a little bit about drug developers. We're now entering the world as a community where we have these opportunities to be enter and enroll in clinical trials. And we thought it was important to have you meet and understand a little bit about how a biotech company works. And what their day-to-day looks like. So we have a number of biotech companies that are going to join me on stage for a brief fireside chat, and we'll ask them some questions. We're going to start it up. All right, so I'm very pleased to introduce 4 different companies that we have up here. Starting from this end, we have Randall from Longboard, we have Brian from Praxis, we have Perry from Regal, and we have Carolyn from Neurocrine. Wave. So maybe we'll do a quick, brief introduction, maybe starting from. So I think one important thing to realize is that not all biotechs are the same. They kind of grow like people. They start off small and they kind of grow into bigger creatures as they evolve and get to be a bigger company. So we're going to start by maybe talking about what a small biotech company looks like. And I think that's kind of what we as a community think of as probably a whole bunch of scientists working in the lab trying to find a cure. And then as a company grows, we'll learn a little bit about what those companies look like. So we're going to start with Perry. talking about Regal Therapeutic. Maybe could you give us a quick, tell us a little bit about Regal, about yourself, and what you guys are working on.
Yeah, I would be happy to. So good afternoon, everyone. It's a privilege to be on this panel with these other three wonderful companies. I'm a program director at Regal Therapeutics, where I'm leading our preclinical central nervous system programs. And I'm just going to go on a little bit of a story for my journey to Regal, because it intertwines nicely with what this conference is all about, which is SCN2A related disorders and advancing research for SCN2A. So before joining Regal, I was a graduate student in Kevin Bender's lab, who is, some of you may know him. He's led a lot of the work characterizing what changes within a neuron and within the brain when you have a loss of function SCN2A variant. And I was privileged to be a part of that work. We made a lot of what I think are quite interesting discoveries, understanding how that changes the excitability of neurons, how that results in changes and impairments in synaptic plasticity and learning in the brain. But what I think is most important for our discussion here today is we found that if we could restore the expression of SCN2A in a mouse model of SCN2A haploinsufficiency, which mimics the loss of function variants present in patients with autism spectrum disorder and intellectual disability, that we could restore a lot of the cellular deficits that we saw. And this gave us hope that we could develop therapies to potentially treat this population of patients. And that work was the result of a collaboration with another group at UCSF who was exploring using a strategy called CRISPR activation, which is a genetic approach to increase decrease the expression of specific genes within the genome. And this can be applied to a whole host of rare development or genetic disorders. And they were interested in applying it to SCN2A. And so based off of the success of that work and the work that that group was doing with other genes, the leader of that work, Navneet Matharu, founded a company, and that paired with another co-founder named Jordan Dimitshtein, who is here in the audience, and who developed other innovative methods that complement nicely with Navneet's technology, where we can restrict the cells that are and tissues that are involved, or we can restrict where the intervention is within specific cells and specific tissues, so that we can hopefully add additional safety factor to our therapies. And so, as Sean said, I'm here to provide the perspective of an early stage company that is trying to develop novel technologies for gene therapy. We are a preclinical company, which is different than the other companies represented here on this panel. So what that means is we're not yet testing our products in patients. What we are doing is demonstrating the feasibility of our technology to be effective. And then we're also generating safety data so that when we begin first in human trials, that we can be sure that the expected benefits outweigh the risks. So with that, I'll turn it over to the rest of the panel.
All right, and we'll just kind of work our way up the food chain. Brian from Praxis, maybe could you give a quick understanding of what Praxis looks like from 10,000 feet?
Yeah, definitely. So I'm Brian Pfister. I'm the Vice President of Medical at Praxis. I can kind of tell you what we are based upon where I had been. So I'd been in big pharma, started out big pharma, moved smaller. And the primary reason to move smaller to a biotech is time. So big pharma takes forever to get anything done. No offense to any big pharma folk, but biotechs can move much more quickly. They're smaller, so we're about 60 people, 75 people. We're dedicated to these programs. We live this every day. We're able to move quickly from concept to candidate selection, so finding the molecules that may work, to getting them into the clinic. And so that's I think the best thing about small biotechs. It's a group of people with similar ideas, with knowledge bases that they can pull from to move so much quicker than what it would have been at Lilly or Novartis or even Lundbeck in the past. So
thank you, Brian. Randall, which is kind of considered a mid-stage biotech company. Could you tell us what a company like that looks like?
Hi, my name is Randall Kay. I'm the Chief Medical Officer at Longboard Pharmaceuticals. Named our CEO is a surfer, so that's where we got our name. I'm obviously not a surfer. So I'm also a pediatrician by training. So I'm going to tell a story a little bit like Perry just did. So I trained in the 90s. I remember doing my pediatric rotations, including neurology. and seeing my first young child with an apparent seizure disorder. I remember what that was like, going through that part of training and spending all that time on diagnosis and supporting the family and going through that early part of the journey with someone. And at the end, when we finally had a diagnosis, I said, great, now what are we going to do? And you're nodding. So you know what was said back in the 90s, like, well, we have a couple of options, but they're not very good. And it felt back then that there wasn't a lot of hope. So I've been involved in drug development for 30 years, and I've worked in a variety of different areas. I really like the approach that I think we're taking at Longboard that I'll describe very briefly. But I think there's something that's really changed over the last decade or two. And it's just that there's more hope, there's more technology, there's more science, there's more data that we have to deal with. And I'm really excited to be kind of part of this journey with all of you. At Longboard, we have a drug. It's called LP352 because we're uncreative and can't come up with a name yet. It's a 5-HT2C receptor superagonist. So you can see we still can't come up with a decent name, but that's where we are. The approach that we take is we look at precedent medicines or molecules that seem to demonstrate efficacy. And what we do is we hone on the receptor that it's interacting with that we believe is contributing most to efficacy. And then we remove interactions through medicinal chemistry with any of the other receptors that either are known to cause adverse events, or we don't really know what it does anyway. So we tend to focus on single selective targets. And we have an ongoing study. We're expecting to have a data readout around the end of this year.
Thank you, Randall. So for drug developing companies, they're kind of the end goal is to get a drug approved. When they're in development, you can only access the drug in the context of a clinical trial. So what all biotech companies want to be when they grow up is to be a commercial company. And Carolyn can maybe talk about what it's like to be a grown-up biotech.
Hi, everyone. I'm Carolyn McMicken, and I'm a director in clinical development with Neurocrine Biosciences. Neurocrine's a neuroscience-focused biopharmaceutical company, and we've been around for 30 plus years now. I haven't been there for 30 years. I've been there for about 7.5. And most of that time was spent toiling away as a biotech, trying to bring the first compound through discovery and development. And we did that with a compound in movement disorders back in 2017. And so we are a commercialized company, but we have a broad pipeline that's not just neurology. We have psychiatry as well as endocrinology. And I'm in the neurology space and in rare disease and working on sodium channel inhibitor that some of you might be familiar with our program for SCN2A DEE. We have an ongoing trial and active early discovery research as well with some of my colleagues in the audience with interest also in SCN2A. I would say, just a quick story, because I know we want to get to the panel discussion. Like I mentioned, at Neurocrine, when I came there, I was in medical affairs, which that's the part of the organization that typically interfaces with healthcare professionals after a drug is approved. And in my prior life at another company, I worked closely with the infantile spasms community as well as Lennox-Gastaut syndrome. And it was through that I was just so inspired by the families and the caregivers that it really motivated me as soon as I found out that Neurocrine in-licensed some compounds that were going to be targeting rare catastrophic pediatric epilepsies. I kind of raised my hand right away and said, I want to work on this. And that's where I've been for the past 3 years. And I'm just super excited to be here on this panel today.
Thank you so much, each of you. I think a lot of the caregivers kind of want to understand like what a clinical trial is like and try to understand that experience a little bit better. I think the vast majority of people in here haven't been in a clinical trial. Like what is that? And this, well, kind of open this up for the panel at large, but when do patients have access to drugs? Like when do they have an opportunity to raise their hand to be in a clinical trial? Can that be at any time? Like any one of the participants maybe want to give a quick excerpt on what a clinical trial looks like and when our community has access to these medications?
Yeah, I'll take part of that. So at Praxis, we've got 2 clinical trials going on right now. So as mentioned before, we have an ASO, which is meant to be disease modifying for the SCN2A. And we have then Prax 562, which is a sodium channel inhibitor that's meant to also, be different than what we've seen in the past. So when we get to that point to be able to enroll into a clinical trial, we design the protocols, we write the inclusion exclusion criteria, we pick sites. And then once those sites are open, then we'll typically notify the patients that these sites are available. If they're interested, here's the inclusion criteria, here's the exclusion criteria, and then they can reach out and find out more information and really proceed down that road. One of the things that we've looked at is, how do we do this in a way that there's such a high demand and high need for medications for SCN2A in particular? There's not really anything specifically designed to treat it yet. And so then we've looked at ways to expedite that recruitment period. How do we get people in contact with the information that they need ahead of time so they can get into the trials, get treated? Like, for example, the Prax 222, which is the ASO, has, we recruited the first cohort of patients, and we were able to do that very quickly, which helps us to get to the next phase, which ultimately creates availability for the product much more quickly for the rest of the population. But again, once the sites are open, once we get those set up, then there's typically an outreach that goes to clinicians, and we'll go also reach out directly to patients, and with the patient advocacy groups to connect with them, so everybody has the information so that they can get involved as quickly as possible, so we can get drugs to families faster than in the past. Thank you, Brandon. Do you have a comment too, Randall?
Yeah, if we can add to that a little bit, to some degree, since we have an audience of family members that have family members living with SCN2A, it actually starts more with you and your interest in being involved in research than with us, because we try a lot of different techniques of reaching out, whether it's through advocacy groups like yours or through potential investigators that are involved in the study. But I'm just going to share with you sort of a line or an adage that I've gone by in the 30 years I've been involved in drug development, which is that research is part of the treatment paradigm. Research is part of the treatment paradigm, which is a very different concept when you start to think about when you're in the very early stages of sorting through, oh my gosh, I can't believe we have this diagnosis. What does this mean? It seems overwhelming from every aspect, beyond just emotionally, but it's just so incredibly overwhelming. But it'd be good to start to think about that as early in the process as possible. And being involved in research, just one last concept, doesn't mean you need to be involved in a drug study. It could mean being part of a naturalistic study or contributing your loved one's data into a registry or a database, so that people like us can share knowledge and get smarter over this journey while we're trying to come up with great treatments and cures.
Thank you, Randall. That's almost a perfect transition. Caregivers and families have an absolute essential seat at the table for developing drugs for our children. To empower the drug developers to make the right drug for our children, and also know what the indication looks like in order to that there may be multiple drugs needed for our kids. I mean, that's kind of the inevitability. Maybe I'll kind of open up the panel for each group, since they are kind of different types of companies. How can caregivers contribute to your process in order to make it better? Maybe just a few words from each of you, and being from early stage preclinical to clinical trial enrolling to a commercial company, maybe not for SCN2A, but just in general. But how do patients and their caregivers contribute to your process?
Yeah, I'll just echo what Randall said, which is participating in natural history studies and patient registries, especially for, in our case, looking at the loss of function patient population, where I don't believe that there are ongoing clinical trials for those children. That is the most important thing you can do to help create data for us to evaluate whether or not our therapies are appropriate, and whether or not we think our therapies would be effective, and whether or not the benefit we can provide would be, given the potential risk profile for a therapeutic, would be appropriate for this disorder. So having as much information there is important. Also participating in academic research that is trying to advance biomarker discovery. So at this conference, there are ongoing efforts There's the eye tracking study that's being run by Dr. Kevin Bender. I'm sure many of you have heard about this. Just participating in that is very helpful. There's the Biogene EEG studies that Caitlin Hudak is leading. That's helpful. These sorts of biomarkers, which they might not be the symptoms that your children or that are the most important to you in terms of getting them corrected, but they're an integral part of the accelerated approval process that gene therapies will need to take in order to reach the clinic. So being involved in that is very important. And then I guess lastly, participating in the patient-focused drug development process, which I believe is going to be talked about more in later sessions today. Finding out ways that you can work with the SCN2A or the family's SCN2A Foundation to be a part of that process, to really advocate to the FDA that your child's disorders are important and need medications.
Yeah, I'll just piggyback onto that. First, I want to thank the families here and the families SCN2A, because what you're doing, we're working in some other areas where there's little known about rare diseases, and you just remove a lot of barriers for the clinical process if you participate in things like natural history studies, because it helps us to better design a trial. And I think, particularly, like you said, for loss of function, or when we're trying to target more than just seizures. I mean, the seizures is a somewhat well-worn path to a drug development perspective, but participating to better understand the non-seizure outcomes and things like the Inchstone Project, they're just really, really super helpful.
Yep. Okay. So I agree 100% with what the other two colleagues have said here too. I think the biggest thing that's been helpful for us is like being part of natural histories, being able to share the information, helping us to understand you in a way that helps us to highlight what drugs can do and find pathways that are novel, that are really groundbreaking is huge. I have a son with epilepsy as well, and so as sitting on the research side and living it in some ways, it's like, I get it. Like, I get the things that are important, and sometimes they aren't always captured in the way that we traditionally have captured them in clinical trials. So being able to include that or having that component in there and being able to see that and being able to study where you guys have been, what you've been through, and how you guys exist in the real world, because again, clinical trials sometimes are not 100% real world looking. And so the more that we can get, to understand the patient population, understand what you guys are going through, the better trials we can do, and the quicker we can get the drugs developed. So keep doing what you're doing. These type of meetings are wonderfully helpful to hear the stories, to understand the impact, to really feel what you're going through is amazing for me. It gives me goosebumps, because then it helps us get up and work hard at what we're doing. So I mean, again, just be active and be vocal and tell people, anybody who will listen. That's what we did with my son. Anybody who would listen to the story, I'm happy to tell it. But it was, you got to find that advocate that also then is on the development side too. So just keep doing what you're doing in that regard.
Just a request, give us some feedback. So when you are talking with your clinician about maybe being involved in the study, if you choose that it's not right for you, let them know why, because that feedback gets right back to me. We sometimes just get, lack of interest. Give us a specific reason. It took us a while to realize that having patients come in every 5 days for a 3-week period was a little bit inconvenient. You would think that'd be obvious, but it wasn't, because it was something we were trying to accomplish in the study. But getting that kind of feedback, whether it's about visit frequency or how exhausting a clinic study day can be, and could you please try to split these up and maybe make a hotel night available between the two so that we can actually get all those assessments done. But please just give a little bit of extra feedback so that the next studies that we're putting together are going to work better for you, and for us as a company.
Great. Thank you. I mean, we have an essential seat here, and your voice is heard loud and clear whenever we have the opportunity to speak up and talk about our children and the reasons why we want something better for our children. But one question that comes up a lot in our community is for people that do have interest, that they want to know whether my child can participate. And clinical trials are designed to be, a test. They're evaluating whether a drug is safe and effective. So part of a test, there are, rules for the test to make sure that we can assess it well. Brian yesterday was able to talk in detail on eligibility criteria and did a great job during the research roundtable. Maybe could you kind of frame for the community why those are important and maybe things that they should think about as they're looking at different studies?
Yeah, that's this is like kind of tale of two cities, right? Inclusion, exclusion criteria, the best of things and the worst of things at the same time. So when we're developing drugs, we need to, our first and foremost request or things that we need to do for the communities is make sure we create safe drugs, right? So we want to look at SCN2A, for example. We want to look and study drugs in that particular patient population. So the inclusion criteria typically is about 4, and the exclusion there's about 20, right? And so the reason that we do this is we want to turn down the background noise on all the things that would lead us to the incorrect conclusion. So you're going into a clinical trial saying, I have this drug, I've looked at the science, I've looked at the data, I understand how this drug works, it could potentially be beneficial. But then there's a whole host of things that can get in the way of us really understanding if it was beneficial or not. So this is where on the surface you meet criteria to be included. And then when you start parsing out some of the things that would exclude you from the clinical trials, that then becomes where the frustration sets in, because you're like, oh, I thought I could be in this trial and now I can't be in the trial. So we do that again, just to turn down that background noise so we can really detect if this drug has a benefit, and also then maintaining safety, because there's a lot of things that can get in the way of safety, through the course of a clinical trial. And we don't want to cause any harm to anybody. And one of the things that we've done at Praxis that was different than other companies I've been at is we're able to go back through and look, like I mentioned, where patients are. How do they present clinically? What do they look like? And Dennis had mentioned that, looking at the clinical, presentation of the patient on top of variants and those type of things. We also could look at the burden of the condition, like how difficult is it going to be? So if I set up 4 clinical research centers and they're not anywhere close to your house, unless you're Carson's mom, it becomes, difficult sometimes to travel. And so I want to make sure that when we design this, we could do something that would meet you where you are and create a decentralized clinical trial design, because we saw that was a major hurdle to inclusion. Is getting to the site is half the battle in a lot of ways. And so that became so difficult and became such a hurdle. So we were able to implement that. But based upon the information that we saw in the databases, in the natural histories, in what we heard from you, we're able to come up with an innovative new design. So, again, maintaining your voice and understanding where you are and bringing the research to you instead of bringing you to the research. So that's been our focus.
Thank you, Brian. We had a few questions come up, and there's one theme that it would be good to kind of talk through a little bit. Each of you are US-based biotech companies that are, developing drugs. Can you talk about the process and barriers as you are developing the drug and starting your clinical trials to go from the US to ex-US? When did that typically happen within drug development, and what are the barriers that limit that sometimes?
So, yeah. Longboard is a publicly traded company. Because of that, oftentimes we might be doing a whole bunch of activity, but we don't even talk about a lot of the process of those kinds of steps that we're taking. That also includes when we're in the planning stage of a clinical trial, we might not make a lot of the information all that public. So just a quick side note, clinicaltrials.gov is actually not the best place for information. Because we won't post our studies on clinicaltrials.gov until 2 weeks after we activate the first study site, because we have investors that are staring at us and are trying to do these crazy calculations. It's true, right?
It's true.
Yeah. Doing these calculations of when we're going to have results so they can hedge it. Is that the right word? Mm-hmm. Yeah. Most companies, ours included, does them in as close to parallel process as we possibly can. Things have got a little bit more complicated with Europe post-Brexit because we're not really sure exactly who we're supposed to talk to. So as a publicly traded company, we probably won't talk a lot about where we are with the discussions with them, but I can assure you they're ongoing. Our attempt is to do everything at the same time. But I'm curious with my colleagues if your experience is a little different.
Yeah, I would just add, generally speaking, of course, we're dealing with totally different regulatory bodies between the US and different countries and continents. So these things are, you have a whole team of people that are working on it. And often we have partnerships with clinical research organizations that also have regulatory teams working with our own to make sure all of the documentation submitted to whatever countries that we're going into. So it can take a very long time. I think things were getting better after kind of COVID slowed things down tremendously. And then now there's, new regulations all the time that also add to some slowdowns or changes in how we have to do things. So it's, like I had said earlier, I moved from medical affairs, which is all post-marketing, to clinical development. And it's quite an intricate process. We have lots of smart people working on it, and we strive, particularly in conditions that like SCN2A that are so rare, to get a broad representation across the world, if possible, of sites.
Thank you. Anything else?
Yeah, I'll make one quick comment. Like we've looked at this and looked at strategies, as mentioned, with the regulatory bodies. We have a central theme within Praxis, and it's solving for time. How do we do this quicker? So we look at this, I think, eyes wide open and say, where are the opportunities and how do we get this, through quicker to get these decisions to be able to continue to move products in development and really to help the families. So, we move pretty quick. And so sometimes the information is coming out, a little bit slower than we're moving, just because as we're organizing things. But again, we look at it from a standpoint of, are there opportunities in other countries to be able to get trials started up, get aspects of it, run different study designs than we're accustomed to in pharma. And so it's been, again, just like, what's the opportunity and how do we do this safely and effectively and do it as quickly as possible?
Great, thank you. One theme that kind of emerged in a few of your answers were, sometimes we can't say things because of certain reasons, whether those are regulatory or other components. And for any company that is publicly traded on Wall Street, there's a regulation where they can't speak anything unless it's been published by the company initially. So I think one question that comes out in our town halls and conversations with family is, I want to be in the loop more. How come I can't get kind of like live information all the time? I think maybe comment a little bit, or if you have any thoughts on just because you're not hearing things doesn't mean there's not a lot going on in the background. You're still not, racing for a cure and working as fast as you can. Maybe any comments or thoughts on that or any other compliance issues that are important for our community to know?
So I told you a problem, or I said, don't go to clinicaltrials.gov. So I probably should give you a sense of where maybe you should consider going. Our two best sources that we think for you to consider, at least from Longboard standpoint, would be your clinician, who is most likely to be most knowledgeable of what studies are coming. So let me say, I know we have Boston Children's and CHOP here. You guys know it takes about 6 to 8 months to do all the discussions with starting off a study. So these folks will know, and that's typical for every institution. They'll know in advance what studies are coming and probably give you a much better sense of when that's probably going to be, because on the pharma side, we're constantly talking about study start is going to be, June 2023. Are you ready? This is when we're going to start. But we had that conversation 7 or 8 months in advance so that we actually start on time. The other source is the group here, is the advocacy groups. We like to communicate as early as possible and even give a heads up of, we're seeing this study maybe coming. We're thinking towards the middle of next year, so that you can start to communicate with your folks that is as a possibility.
we're talking about, yeah, there's, yes, lots of rules and regulations that our companies operate under, and perhaps, you know, in a commercialized company, even more so, we need to worry about being accused of promoting, which seems funny because we're trying to encourage people to participate in clinical research, but it can be also viewed in some cases as like pre-approval promotion. But at the same time, there's also a shifting paradigm in that we want to and need to be much more collaborative with patients and caregivers. So, you know, we've been at Neurocrine kind of having this tension and more recently over the past few years decided when we talk to like internally about what we can share, it's more about here's what we want to do and let's find a way to do it. You know, we've learned from the past of like asking something and always getting a no. So we're trying to look for solutions rather than, you know, we know all of the reasons and the things we can't say, but let's talk about, you know, where we can push that and what we can share and get feedback from the community.
Yeah, and we did. What's interesting is I think that, you know, we always want to communicate. I tend to like to over communicate, and I know Steve's in the audience over on the side, so hopefully I don't get in trouble for this. But I like to share. I want people to be informed and know what's going on. And one of the things that we had looked at with our clinical trials is to set up like a couple landing sites where you could talk to a nurse navigator. So like for the small molecule, you could go to emboldstudy.com. For ASO, you could go to embravestudy.com. You get information, get connected, which helps you to stay in a loop. So when it's ready to go, when things are there, then we can, you know, move things more quickly. But one of the things that I guess one thing that I hate in life is to be wrong. And so we do wait sometimes to tell you the information until I'm 100% sure, because I don't want to be up here and say, yeah, we're going to do that now. And, oh, guess what? We're not going to do it now. We're going to do this other. So I just want to make sure we're right. And I want to make sure that it's accurate. And then you can make your decisions based upon the information that we provide. So that's a commitment, again, I have to you, is to make sure that you know the information, and working with Sean and working with the other advocacy groups to make sure that they're looped in on what decisions we're doing. And you know, we're again trying to move as quick as possible, but I do not want to be wrong. So I want to make sure it's right for you guys.
Yeah, thank you all. But one thing I did want to bring attention to is the Carolyn's comment that things have been changing where we have a bigger voice. You know, if you look back 10 years ago, this wasn't how drugs were developed. They used to be, you know, the biotech companies just did what they wanted and hoped that there was a patient population at the end that worked. And nowadays, you know, they're here in front of, you know, 300 people, many of which have very sick children, wanted to hear your voice, wanted to hear your perspective to make sure that they're developing the right drug in the right way. So it's great to have a seat at the table as a parent. But one question that came through maybe for Perry, as being the one company that's still preclinical, what are the steps that go into kind of going from preclinical to clinical? And I know that's a complex question, but maybe help just our families understand what levels of like validation and what's important for you guys to see.
Yeah, definitely. Yeah. So, I mean, this is a journey that I think we've been on, a lot of us coming from academia into the industry side of things, where in academia, really what you're interested in is developing new technology and new science and showing that things are feasible, and evaluating the potential of a technology. That is still important once you're on the industry side of things, but suddenly safety is a much bigger consideration, right? As it's, you can try a lot of stuff in a mouse that is absolutely unethical to try in humans. And so in order to advance to the first in human dosing, especially of a product such as a gene therapy, it's a one-time treatment, which has the potential to provide transformative benefit if it's effective at a single intervention, but it also can be permanent. And so it can be highly invasive depending on the delivery route that is used. So we need to follow a highly regulated process to demonstrate the potential to provide meaningful benefit. So this is like when we talk about the patient-focused drug development aspects that these natural history studies are help contribute to. We can evaluate whether or not our therapies have the potential to provide that meaningful benefit, and whether or not it will offset the potential risks that arise from the therapy. And the way you establish those risks is you do rigorous toxicology and safety testing in animal models. And then you very, very carefully move from those studies after you get FDA IND approval, that's the process that you go through, investigational new drug, to explain the 3-letter acronym. And only then can you can begin doing clinical trials. So it's the FDA provides a lot of regulation, but it's to keep you safe. It's to keep your children safe.
Thank you, Barry. We got about 5 minutes left in the session. So I just want to open up the door for each one of our industry groups. If you have any closing words for our community, anything you want to say to, at a patient advocacy group conference.
I'll start. I know there was one thing we didn't touch on, and I want to emphasize it takes a village to bring new treatments for your children. It's not just your help, and of course participation is important. Our teams within our respective companies, and then even in addition to that, I alluded earlier, is we have all of these collaborators. It's your study physicians, it is contract research organizations. It's a lot of people that we're working together collaboratively to make a difference. And we appreciate your participation, also your patience, even though I know time is of the essence. And we definitely appreciate the feedback and input that we get to make everything as seamless as possible.
Well, to the participants, thank you for letting us be part of this journey with you and teaching us and letting us learn from you. And to the organizers, thank you for the lunch, but particularly not the adult lunch, but the children's lunch table where there are chicken fingers. It's the only time I can get away with sneaking a chicken finger. So thank you for that.
That's awesome. I was going to say, just in general, it was brought up before. I think Carson's mom had said, you know your kids better than anybody else. Be the advocate for them, and I think that holds true even into drug development. So when you have questions, ask the questions. There's no stupid questions. I can give you a stupid answer, but there literally are no stupid questions. So please ask away. Be involved. Fight for what you know, and believe in what you're doing. We're here to help you as well, and we want to hear those pieces of feedback. Again, even within our Praxis company, we have 2 of the founding members have kids with SCN2A mutations. So this is something that for us, genetic epilepsies is really a passion of ours. So please ask any and all questions you have, and we'll get you an answer.
And I guess to wrap things up, I'll finish the way I started, which saying it's an absolute privilege to be here. This is my second Families SCN2A conference, first time again as an academic, and then now from a different perspective as someone who's trying to develop a drug. Being involved or meeting patients and being involved in these sorts of family outreach, it's incredibly grounding and incredibly motivating. And so I just thank you for everyone who's come to talk to us, to ask us about what we're up to, about our research. It really helps motivate us, and drug development it's a long and challenging process. It does take a village, as was said earlier, and you guys really provide the motivation to us to keep going and to invest in disorders like SCN2A. So thank you.
All right. Well, thank you, everybody. Thanks, guys. Very nice.
Yeah.
Christina, should I bring up my slide? Which is next? Space. This?
You know, I sent the wheels in motion. They're going to give an announcement in 45 seconds.
Okay.
You're ready to go. Brilliant. Because you're very self-sufficient. That was less effective than it might have been. All right, should we try the banging? The banging glasses seem to work pretty well there.
I smashed it.
Our program is about music. Good afternoon. All right, welcome back. We are now entering our next session, which is talking about alternative models for healthcare. It is my great pleasure to welcome John Millichap here, a man who's going to talk about virtual healthcare and has such extreme expertise in this. He was even able to sort out his slides on the computer himself. I'll pass you over. You will hear a 2-minute warning from there.
All right, thank you very much for the introduction and for the invitation to speak at this conference. I've been at every conference, I think, since the first one in Chicago, and I've really enjoyed being part of this community. I'm a pediatric epileptologist, for those who don't know me, I was at Lurie Children's for over 10 years and now am in private practice with a 100% virtual clinic. And I can see patients in about 26 states. I keep adding states, so I can't keep the numbers straight. Also adjunct associate professor of neurology at Northwestern for research and teaching. So this is a new topic for me. I was asked to speak about. So any feedback on the slides and the content would be much appreciated. The audience seems to have thinned out a little bit, maybe for some desserts, but people at home I know are watching virtual. Oh, yes, and there's a parallel session. Could I get a raise of hands of everybody who's had a telehealth visit with their child? Okay, and then think back 5 years ago, so pre-pandemic, a raise of hands. Who had a telehealth visit 5 years ago? Wow, so that's 0 to 60 in 5 years. That's amazing. And who thinks that they will have a telehealth visit with their child 5 years from now? All right, so another raise, same number. So I think it's a new thing and it's here to stay, according to this group. So one definition of telehealth is a collection of means or methods for enhancing healthcare, public health, and health education delivery and support using telecommunication technologies. So telehealth is not just you meeting with your child's doctor in a video. This is the whole delivery of healthcare. This can be administration. This can be insurance. This can be communication between doctors. This can be this meeting we're having right now, delivering information about healthcare. So when we talk about telehealth and the delivery of it, there's three main patient-facing forms. So the one you're most familiar with, we often refer to as telemedicine. And these definitions get thrown around and these terms get thrown around a lot, but this, I think, is the most succinct way to think about it. So this can be either meeting with patients face-to-face, either in the hospital, so a doctor in their clinic, remoting into a hospital, perhaps that doesn't have a neurologist, and taking care of that patient in the ICU or on the floor, or more familiar to you is to your home or direct to consumer clinic, either the providers in their home or in their clinic and direct into your home. Something you may not think about is store and forward, which is asynchronous or not at the same time. So in our community, this would probably refer mostly to EEG. So an EEG is done at your home or in the hospital. It is recorded. It is electronic data. It's transmitted to a doctor. The doctor interprets it, makes a report, and then that gets back to you. This is also a form of telehealth. And then something that's not utilized much in our population is remote patient monitoring, or RPM. This is used a lot, I think, in adult internal medicine, monitoring heart rate, monitoring blood pressure at home. And I hope that this form of monitoring will become more commonplace as technology evolves and really insurance catches up with paying for these things as we can find clinical benefit from it. So as I mentioned, the pandemic really made a shift. We couldn't have face-to-face visits. There was limits of inpatient stays as well, but staying in touch with your doctor was really important. So we had to make changes. So telemedicine really blew up very quickly, and pediatric neurology was no different. This reduced exposure to COVID-19, of course. And in my opinion, epilepsy and autism or behavioral issues are exquisitely appropriate for telemedicine delivery. Other types of pediatric neurology problems like muscle diseases, movement disorders, or issues with the muscles may not be as appropriate because the neurological exam is much more important or needs hands-on neurological examination rather than observational neurological exam. During the COVID-19, state license requirements were lifted, as was insurance issues, but those are all back in effect now. So to bring this home for some people, just think about a 12-year-old boy who has daily seizures due to a genetic cause. It could be SCN2A or some other genetic cause. He had seizures started at birth. The parents and the child have been through 20 different treatments. He has continued seizures on 2 seizure medications. He's nonverbal and in a wheelchair. They typically go into the city to see their doctor twice a year and go to the hospital for a EEG overnight every year. They live an hour and a half away and they have siblings in the home. So 5 years ago, this was just life. 3 times a year, you pack up and go to the hospital and go through all of the issues. Now with telemedicine, they can have visits every 3 months, perhaps, maybe shorter, maybe on time. Maybe they don't have to, pack up the child into the car, get to the hospital downtown, go up in the parking structure, get into the elevator in the parking structure, get to the lobby of the hospital, wait in line in the lobby of the hospital, wait in the elevator line to get upstairs to the clinic, wait in the line to get to the secretary to check in for the clinic, then wait because the doctor's 2 hours late. Yes, I was always running late in clinic. With telemedicine, I don't. For some reason, it just stays on schedule. But just sort of that day in the life and those travel hardships and that stress and the reduced cost and struggle for the family to get the same or similar care is really important. They're not getting as frequent neurological exams in person, but I think if they do need EEGs and EEGs in the hospital, that can be a point where that care can be provided. And there is something to be said for the interaction with the nurses and other staff during those hospital visits, even though they spend limited time with the doctor itself. So health equity is an opportunity for everyone to receive health care they need and deserve, regardless of social or economic status. These underserved communities are ones we're familiar with: low income, rural, people of color, immigrants, people with disabilities, people with language barriers, people with limited digital literacy. And barriers, you can imagine, not having a device for having the telehealth visit, no internet, not having a private housing, not having virtual providers locally, or not speaking the language. One way that I've seen help for folks who don't have this digital access is the Child Neurology Foundation. They provide devices and internet access for eligible families where they can access telehealth visits, the community. They could attend a meeting such as this one, and there's the website at the bottom for more information for yourself or for others you may know of. The hospitals also have barriers to telehealth. Doctors have to be licensed in the state that they're practicing and also the one where the patient is. They have insurance issues. And the hospitals also have invested a lot in their towers and their offices and their parking lots. And so they've had to make a shift these 5 years to reutilize that space or find uses for it. And staff who used to check patients in may not be as utilized. So telehealth is really family-centered care. You and your child may feel more relaxed. Doctors' offices are stressful, and children with special needs especially may not feel comfortable in unfamiliar surroundings. You might be able to see an expert that isn't in your local town. You may have more time with your child's doctor, and the virtual visits may fit better into your schedule with less complications of driving and exposure to illnesses. So preparation for a virtual visit, you can practice with your child, get them used to the idea of speaking to the camera, and coach them to communicate with their provider. It can be done anywhere in the home, so even their bedroom, wherever they want. And remove any distractions, siblings or pets. Tests can be done remotely too, not MRI, that has to be done in a center, but EEG and genetic testing are things that can be discussed and performed over virtual means. EEGs at home, we already discussed, it can be very convenient. And you may not be aware that there are doctors who are able to connect to your local hospital and take care of patients who are in the ICUs or on the floors. Especially neonatal intensive care units utilize this expertise from within the state or even out of state in order to provide better care to patients in the hospital. I'll just put a plug for a nonprofit based in England that provides EEG remotely to undeveloped countries such as less developed countries such as those on the African continent. Tele-EEG, so they provide an EEG machine and record the data, upload it to a server, and then we'll send it to doctors like myself to interpret, which can be a great resource for those areas. Genetic counseling is another area that can be done over virtual means with expertise, access, and really want to emphasize that not just genetic counseling, but other forms of counseling can also be performed through virtual visits. And lastly, clinical trials. Not all clinical trials would be good for at home. So with procedures such as lumbar punctures or with potentially high risk treatments may not be appropriate, but those that are finally selected could be done at home. This has really increased in or has become a possibility since the pandemic as companies cropped up to make this happen, and could potentially make clinical trials faster and cheaper. So as I'm a little bit over time, I'll just say my take-home points that it's telehealth is available, so ask for it if you want it. And telehealth is appropriate for many situations with developmental and epileptic encephalopathy or other rare diseases. And this can really increase health equity and inclusion by giving specialty care where it's needed and clinical trial availability enrollment to all. Thank you very much.
Wonderful. As I invite our next speaker up, a quick reminder that there will be a big group photo at 4:15 for everyone. That'll be straight after the next session. And also at 5 o'clock, there will be buses going to the aquarium. You do not want to go there any other way. Don't go by bus or helicopter or car. Bus is the right way. And Leah told me that, so it's true. Many of you asked, what would a rock star look like in genetics? And with that in mind, I'm delighted to have our next speaker, Wendy Chung.
Thanks so much, Stephan. I don't know about rockstar, but I want to share an experience that I've had with one of my patients that is not an SCN2A patient. So let me be clear about that, but is another neurogenetic condition with one of these N of 1 studies with an ASO. And as I know, many of you have been thinking about this or even potentially participating, give you some insight into what we're doing. I also want to say that for some of you, you've seen our team for the Simon Searchlight group that's out there, just to say that we're here working with the team and have been with the families SCN2A for many years and making the data available to many of the researchers that you've been hearing about. And for any of you, when you get queries to continue to do things, it's because we want to make sure these data are helpful. It also helps with a research match program that we have to let participants know about clinical trials. And so for any of you that are doing clinical trials or planning clinical trials or anything else, it's a distribution network. And obviously you get them through families SCN2A, but we can also do this for families, individuals who may not be part of that. Okay, and I think the researchers know about this, but genetics are complicated for this condition. And we have many cell lines and other things available for you. Okay, so let me get to the part of the discussion, which many of you know about already, but the ASOs themselves are very small nucleic acids, oftentimes about 20 base pairs, and we need to be able to get them to the brain. We synthesize them synthetically, and as we go through that, that's a reagent. It's like a drug, but it's a small DNA molecule as we're doing it. In doing it, you've already heard a lot about how the ASOs can work, so I'm not going to spend too terribly much time about this, except that they're not fundamentally changing the DNA itself. So it's not a permanent change. It's not a one and done. It's something that needs to be re-administered as we do this, and it acts in various different ways. And again, I know you guys have heard about this, so I won't spend too terribly much time, but one mechanism is by destroying a bad copy of a gene, and in some cases, leaving the good copy of the gene so that that good copy of the gene can still do its work. And in some cases, it's taking out both copies of the gene. But by doing it, it's by a method that, again, temporarily changes this. There are other cases and other technology where you do almost the opposite. It's actually trying to bring up the amount of the gene so that individuals, for instance, who may be, we call it haploinsufficient, but have half the amount of the gene product that's made, it's a way of kind of turning up the volume, being able to increase the amount of the gene product that's made. So with this, there's yet one more strategy. And again, you heard a little bit about this yesterday with SCN2A, which is also trying to change the way genes get cut and pasted together or spliced. And so there are strategies to do that. The point is that that slide that I passed by really quickly with all of those different mutations, you have to think about what's the hammer and what's the nail and put those together, and what's the screwdriver and what's the screw and put those together, because you have to have a match between the technology and between what we call the mechanism or the way those different genetic variants are working. So I'm not going to go through a lot of this except to say that smart people think very deeply about how to make the right ASO, how to pick the right nucleic acid sequence, because it's not one size fits all. And it is the case that the more of this we do, the smarter we get. It's an iterative process. And so we get better in terms of both knowing which sequences are going to be more effective. We also get better at knowing which sequences are going to do just the opposite and potentially have some toxicity associated with it. So we are getting better over time, but you've already heard it is not that there's a guarantee in terms of either things working or in terms of them being perfectly safe. In doing this, the people, and I just want to give a shout out to all the researchers that do this. This is not easy to do. It takes a huge amount of work in the laboratory. I won't go into all the details, but it's again, testing many different things in cells so that we don't have to try them on your children first. We can in some cases see when we're turning up or down the volume, how much we're turning it up or down. So we get some readout from cells to be able to see this. And in some cases then see when we're doing nothing or doing something that it's just the opposite of what we're trying to do. The other thing that, again, I'm going to talk about an N of 1, but I think many of us have been thinking about, as you were hearing yesterday, how do you go from an N of 1 to an N of a few to an N of more? I don't know how many more as we're doing it. And so there's some strategies that I won't get into a lot, but where you don't have to target every single different mutation, because that would be just an overwhelming amount of work. I call it a handle, but you find a way of being able to grab onto a handle and make one handle that fits for many different people. And sometimes there are ways of doing this when you're using a knockdown strategy by taking not the rare genetic variant that's causing the mischief, but actually taking a handle of a common genetic variant that might be more common to more people. And so you might be able to use one of those handles that might work for something like 10 or 20% of the community. And so there's strategies that many of us are thinking about to be more generalizable. So as we're thinking about this, ultimately, we need to be able to get the ASO here, and we need to be able to think about how to do that safely, and we need to do it over and over again. So for any of the women in the world who've had an epidural, myself being one of them, in the same way that the anesthesiologist or someone was putting that needle in your back to be able to give you the anesthetic, we put the needle in the same place. We do this under sedation, so it's in the hospital in something like an operating room or an endoscopy suite. Again, we use a light anesthetic so that the person getting this is not wiggling and that we don't do any damage as we're doing it. And as we're doing it, we take a little bit of the cerebrospinal fluid out. It's actually an equal volume we take out to what we put back in so that things balance and we have the same amount of fluid. And the ASO is in a liquid that's similar to the cerebrospinal fluid that we're putting back in. As we're doing this, and I should have said, for most individuals, we need to have a clear way of getting in. So if there's anyone that has any hardware in their spine, so there's some people that have rods or other people that have had scoliosis surgery with hardware that's in their spine, that can cause a problem in terms of being able to do that and deliver it safely. So you've heard about this a little bit already, but as I've done this for an N of 1 study, as I said, for a different condition, we have to always make sure from a safety point of view that we're not going to have bleeding problems, because we are putting a needle in there and you could get bleeding into that area, which is a problem for us. So we make sure that we don't have any bleeding problems ahead of time. We do safety labs 24 hours before to make sure everything's okay. And then, at least in my study, we monitor the individual in the hospital afterwards for 24 hours. just to make sure that, again, we don't have any problems inadvertently in terms of how we delivered the medication. For any of you that may remember getting anything like that, like the epidural or something, you can sometimes get a headache afterwards. And with that, that's one of the things we monitor for. Sometimes with our children, it's more difficult because they may not be able to tell us that they're having a headache. And so what we tend to see is just someone who's not happy for whatever reason, but we may not know why. That ends up being a little bit harder because there can be other complications besides something just like a simple headache. You can have problems in terms of, as we're putting the needle in the back, problems with what we call cerebrospinal fluid leakage. And so there can be problems in terms of pain in the back as well, an accumulation of fluid there. You can have longer term other problems that you've heard of, like hydrocephalus, which are more serious problems. And you can have problems with irritation of the nerve roots where we have the needle put in the back. And so those are all things that we watch very carefully for. So you've heard a lot about this already, so I'm not going to again go over it, but it takes oftentimes definitely months to years in terms of being able to prepare one of these. And within this, and this is one of the things you should be listening for, I'm going to make a very big distinction between the N of 1 and the clinical trials. And I know you've been thinking about this as a community. Technically, the FDA for the N of 1 studies thinks of this as a compassionate use of the particular ASO. And so within that, the bar that they have us go over in terms of safety studies. So although we do safety studies, for instance, in rats for toxicology, we don't do the level or the number of safety studies that we do if this is an official FDA registered clinical trial, as an example, where the FDA is much more rigid. They're much more careful in terms of making sure from a safety point of view that there are more preclinical safety studies. The FDA considers these compassionate use N of 1 studies as something that really is sort of an emergency. It's like all hands on deck. You need to really, really do this and pull out all the stops and make it as easy to get access, because the consideration is that this could be a lethal condition. And so we're trying to do something as quickly as we can to be able to save that person. So that's the balance in terms of why the FDA is willing to let us take some of these shortcuts. It's not a complete shortcut, but I do want to be clear, it's a shorter cut than we would usually do for a regular FDA registration study. As we're doing this, I have to say, and this was the first time I'd ever done one of these N of 1 studies, it feels a little bit like flying blind. It feels a little bit like that for me as the doctor doing this. It also feels like that for the families. We can anticipate as much as we can, but I can tell you we don't always know what's going to happen. We don't know either on the good side or the bad side exactly what's going to happen. So we tend to be look very, very carefully. And so from my point of view, what that means is that I won't say we torture families, but we get a very close relationship with our families in a good way, because that way they can tell us if there's anything going wrong. And that way we know the patient, we know the person very, very well, so that we can also notice if anything seems to be a little bit different. I will say that as we're doing it, we try and get as much as we can what I call baseline data, so that we can know as we start administering this whether or not we're seeing any change, and being very granular. The more data point for me, the more data points I have, the more sensitive I am to being able to see any of that change. I will say, and I say this for those of you as clinical trialists out there, I also realized that in going into it, I plan these studies and with the outcome measures with what I think I'm going to see, what I anticipate seeing based on what I know for the mechanism. I also learn as I go along and iterate. And so one of the things is that as I've done my particular study, I've realized that other things were changing and changing faster actually than I expected them to. And so I've also allowed myself the ability to be able to iterate and change as we've gone over with time. In these N of 1 studies, the FDA is more lenient in that because it's one person. And so they'll allow us some latitude because, again, it's considered sort of at the edge of clinical care and research. It's not a rigid clinical trial design where you're registering every single outcome measure and deciding exactly whether or not you hit that outcome measure. So I draw this distinction because I know those are two different things that are people are thinking about, and they are, in my mind, actually significant, or there are significant differences to them. In doing this, another part of this that for any of you that have heard about NLORM, I know you heard a little bit about it yesterday. One of the things about NLORM, I think, is wonderful in terms of they are for free, saying that they'll give the ASO for life, and that is true, but they are not able to cover the cost then of the clinical administration. And so that's something that, we need to think about. With all of this, this is not for the faint of heart, because with this and with this uncertainty, it really is flying blind. And so I just say this in terms of some of you that may be more risk averse, don't get on this bus. Wait for the next one that's coming by and wait till there's more experience. With this, I will say, and I wasn't going to show you the granular data from my patient because it's a very different disorder and I didn't want to make you confused. But I will say to be able to give you some hope for the condition that I was treating with, something called KIF1A associated neurological disorder. That is a degenerative condition and a fatal condition. And that was the reason why we tried this sort of Hail Mary. And I will say, I think we've actually seen improvement. And so within this, I won't say that we didn't have any bumps along the road in terms of things that we had with complications or adverse events that we had to take very seriously. Times when we had just regular gastrointestinal bugs that we had to figure out. There were all those things that came. But to give you that seed of hope is I do think we're making progress. I think for that condition we did, and I hope that experience is going to help many other communities. So I'll be glad to stop there.
Thanks, John. If we could collect the questions, we'll bring them up here, have a short question answer session. While we're waiting for those to go, I'm going to start off with a question of my own. Wendy, in the last session, we were talking about how sometimes there's uncertainty whether a variant is gain of function and loss of function. Thinking, having sort of been through this for real, how, when it comes to actually giving an ASO, how sure do you think we would be?
So I'll say personally, I think you need to be really, really sure, because to me, the mechanism is very, very different in terms of whether you're trying to turn the volume up or turn the volume down. And to me, this is a Goldilocks situation where you're trying to get it just right. So I'd like to know which direction I'm swimming in.
Excellent. I think it is fair to say that there's a lot of excitement on the N of 1 trial, surprisingly, amongst, I think, clinicians and scientists here. Let me just organize these. While I do that, John, I'm just going to put a question to you. When we think about clinical trials, we heard earlier from Renee about driving 18,000 miles for a clinical trial. How much do you think telehealth could reduce that for a clinical trial?
Well, obviously, as I mentioned, you need to have the right trial with the right eligibility and the right procedures being done during the trial in order to get the information needed to approve the drug. But you could enroll patients from their homes from start to finish. This would be done with home health nursing and with secure delivery of the agent. There's already commercial delivery of pharmaceutical drugs available. So I think that a lot of the necessary data could be collected remotely and reduce travel times, I don't know, about 18,000 miles. So yes, I think we could get it down quite a bit.
Fantastic. Thank you.
Yeah, sure.
Well, let's start with this. Could the results of an N of 1 trial contribute to drug approvals? Let's imagine there was an ASO, which was an N of 1 for compassionate usage, but actually happened to work for another 50 people. Could that be used as evidence towards an IND?
So I'm going to let some of the pharmaceutical companies that are doing this for real be able to answer what the FDA will take for registration. I don't know that in terms of a registration, you guys will tell me in terms of the regulatory package. I do think the experience for sure is something we're all going to use. So whether or not it's formally part of the submission package or not, I don't know. I'll let others say that. But I do say, because I've thought about this for this other condition, KIF1A, we definitely are going to take the N of 1 experience and build on that in terms of going to, like I said, what ultimately I think from a regulatory point of view will have to be a clinical trial. I don't think we can just keep doing N of 1s over and over again. I do think we're going to be, and it's incumbent on us to do the necessary safety studies and everything else. So at least the knowledge gained for sure, whether or not it's officially part of what the FDA uses to make a decision. I don't know. Someone above my Krieger would help to answer that question.
Thank you. If an ASO in an N of 1 trial works for a variant, will it also work in another individual with that same variant?
So I'll let those for this community who are designing the ASOs answer the question. It depends on what the ASO is targeted to. So if it's targeted to the exact mutation, then yes, it should work for anyone with that same exact mutation. If it's done in allele non-specific way, then it should be non-specific and it should work for anyone. And if it's going for the handle approach, it should work for anyone that has that same handle. So it all depends on what DNA sequence that is targeted towards.
Excellent. There's a question here saying that that your explanation was fast. It would like to be a little bit simpler regarding the N of 1 trials. Do you feel you could have a go at just quickly reiterating the key points for N of 1?
Yep.
Yep.
So the key for the N of 1, let me say it this way. It's still designed in the same way that an ASO would be designed for a larger study. It is the FDA, when they think about whether or not to allow it to go forward, though, from a regulatory point of view, is completely different. And so if you were to do this for registration, because you want to be able to get approval and you want to sell this, then in that way, they're very, very careful in terms of patient safety. Number one, they want to make sure that it's going to be safe, and they require a series of toxicology studies first for safety. And then in terms of efficacy, does it work? Then they'll formally do a clinical trial and they'll decide how to judge before anyone gets dosed with this, what the outcome is, whether or not this is a positive outcome or not. For the N of 1 studies, it's more of what they consider compassionate use. So in other words, I think of it as a Hail Mary. So if you have someone who's very sick, you can imagine someone who has a cancer diagnosis and has 6 months to live, and you need to like pull out all the stops, then the FDA in certain cases is willing to use the compassionate use case and allow for something to be used under this compassionate use case. And so they have a lower bar in terms of safety to be able to do that. And so that's paradigmatically the way they're thinking about it. But they think of this is one use case. This is one person who needs that Hail Mary. This is not to say what we should be doing for a community that has 1,000 people.
How did you demonstrate target engagement?
So in this particular case, the way we often do it in the laboratory is with cell lines. And if you're doing something where you're trying to, again, adjust the volume, you can get a readout simply in terms of what the volume is. So it's not a physiological readout necessarily in terms of, although some people do try and do patch clamping within a cell in a cell culture or in an in vitro situation and be able to show it that way. But oftentimes the first thing we're doing is just looking at the amount of protein that's made or looking at the amount of expression of the gene that's made. In some cases, people will look at morphology of cells. They'll look at electrical potential of cells. They'll look at organoids. Some cases they'll look at animal models before that. But all of those in terms of, is it doing what people want it to do?
Fantastic. And did you have to define a reliable outcome to the FDA?
So in this case, and the answer is yes, we did have within that a set of study measures, both to monitor for safety and for efficacy. We did predefine those. They were based on one particular child. And in her case, we knew what she was doing beforehand. So we had a baseline for 6 months that we were collecting data before we actually dosed her so that I could see whether that made any difference, either up or down. And we had agreed with them ahead of time. On the other hand, it's a little bit different because from a statistical point of view, we didn't power it, or we didn't say in terms of the effect size we were going to see, we should be able to do it in such and so a way. They really considered it more like, in a way, clinical care. And as a doctor, would I be able to, taking care of my patient, be able to see if there was a difference?
Well, thank you. John, with telehealth, do you expect this this model to expand in the future? And how would people align themselves to different genes or disorders?
Well, the question seems to be in two parts. So yes, I think telehealth will continue to be a part of healthcare and only expand. There are private clinics that are already cropping up and promoting this for different diseases. And I think that the hospital systems and university health systems are only going to follow and repurpose those office spaces probably for inpatient care and surgeries primarily. And for specific gene therapies, I think that this model could be used either regionally, where you might have centers of excellence with the doctors in that clinic with licenses in all of the surrounding states, and really cover the entire United States with 4 regional centers of excellence for each specific gene. So you could really get with an expert within your region of the United States, Eastern, Midwest, Mountain, and West Coast. So I think that's really the way it's probably going to go. And those centers of excellence will deliver sort of a supportive center or a center of excellence, similar to what an epilepsy center does now at a university hospital with support staff in addition to the providers themselves.
Thank you. For Wendy, if a child's been deemed ineligible for one existing ASO, is there still a chance that a future ASO might be beneficial to them?
Sure. So with this, the ASOs can be designed, as I was saying, either in a mutation specific way or non-specific way. So just don't give up hope, I guess is the point, that there are others that are going to be coming along, and others, I think if someone's on the right track, I expect others are going to continue down that same path. So.
And do you see this approach towards N of 1 being used in ASOs also extending into CRISPR or CRISPR-based editing and maybe gene replacement therapy?
It's an interesting question that I've been thinking about. So in these early days, I think the answer is going to be, anyway, very much cautious. So there's a big difference between the ASOs and any of the gene therapy or gene editing, in the sense that the ASO you can stop. And so even for other conditions, and I'll put out Angelman syndrome as another condition where there were side effects and there were problems, there was the ability to stop, and with that to regain function. The one case or the 2 cases of hydrocephalus where there have been, and again, this is not for this community, but where there have been some problems, obviously those are more serious and less reversible problems. But when it comes to gene editing or gene therapy, in general, the concern is that that's oftentimes a one-time thing. And once you do it, you do it. And so if it's good, that's the good thing. It's one time, you're done, you're fixed, and you move on. The bad thing is if it doesn't do something good and it actually does harm, you're stuck with it. And so this issue of what we call off-target effects or things where we may have problems gets to be a bigger deal. So my prediction is, and this is whether it's within this community or others, is that there may be certain, again, think about the Hail Mary sort of situation. If there's an individual where they really have very little time to live, and the way they're thinking of it is they have less to lose, I think those are the folks that are going to be the earliest adopters of those Hail Marys. And some of the things that we're going to figure out in terms of safety, delivery that are going to be generalizable will eventually be ported over to this community. But I don't know that that's what this community is going to try and do for the one, unless, like I said, it really is someone with a Hail Mary situation. So that's what I see across, sort of the gene therapy, gene editing landscape.
Thank you. Credit to the person for this question, because it's applicable to both of you. It's impressive. How would I go about negotiating an N of 1 therapy with my neurologist? Who would like to start?
Well, I'll say that, and I have no particular interest in NLORM, but I actually just realized that not all of you were here yesterday to hear what was said about NLORM, but NLORM is one of, happens to be with individuals who came out of Ionis, the company Ionis, but this is a foundation, a nonprofit foundation, NLORM, you can Google them. And they have set this up that they will take nominations and anyone can get nominated. So you could be in the United States, but anyone could get nominated for this. Your doctor needs to work with you on this and get nominated. And they won't take everyone into the program. And not everyone's mutation is amenable to treatment. That's what they always think about, is the science of whether or not that's possible. But as they sometimes say with the lottery, you can't win if you don't play. And so if there are people that wanted to get nominated into that program, they certainly could. That was what my patient did, or what some of my patients have done. There are also other individuals who scientifically are doing similar things. There are other companies doing similar things. So there are multiple folks out there, but it's hard sometimes. This is the one mechanism I know that for families, if you wanted to know what you could control and what you could do, it's sort of democratic in that way that your doctor can nominate you.
Well, and just to add on to that, and this specific question was, how do you negotiate with your neurologist? So I think if you talk to your child's doctor and they're not willing to go through the process that was just described, you should ask that physician for a referral to a doctor who might help you, or at least give you reasons why not to pursue it, and to make sure that you fully understand the process and why you might or might not proceed with this nomination. I'll get a second opinion.
Some questions about Simons. So as we know, Wendy has recently appointed head of pediatrics at Boston Children's, which is very exciting, very good news for everyone. What's your ongoing role with Simons and Columbia? And then also in Simons Searchlight, how easy is it for researchers to get blood samples?
Sure. So a couple of questions in there. So I am still the principal investigator of both Spark and Simons Searchlight. Administratively, we're changing things a little bit different. I'm no longer within the Simons Foundation, and the people that are working on the project will eventually come out of the Simons Foundation and be with me at Boston Children's Hospital, continuing to run the programs with me. They will still be supported by the Simons Foundation, or in terms of distribution. So for any of the researchers, you'll still have the same access. As I like to say, for participants, the front end will look at the same. For the researchers, the back end will continue to look the same. Just the sandwich in the middle, we're going to be sort of administratively changing things a little bit, but we'll still get the same job done, and hopefully, I think, even improve. What I mean by the improve, and this is for the families, and I do want to hear back from you, is that I think, so part of the reason I came to Boston Children's is I just think we can provide exceptional care, especially to patients with complex conditions. We have teams that are just second to none. And we especially want to look towards the eye of what we can do in terms of future treatments. So be it clinical trial preparedness and clinical trials. And so what I hope we can hear from you as a community is, what do you need in your clinical care? What are the types of physicians you need? What are the services that you need? And can we help in terms of providing comprehensive, best-in-class care for that? And as we do that, I think it's going to benefit not just the SCN2A community, but really it's very similar for all of the Searchlight conditions. And so by doing that and having a real direct clinical presence, I think it's much more than just this virtual sort of registry. And I hope it'll help even give more granular data by validated in-person assessments that we can use in terms of that clinical trial readiness. So anyway, we'd like to hear from you. We'd like to hear suggestions about what would be most helpful to you so that we can meet your needs.
I can just offer my personal experience on Simons Searchlight. It is one of the easiest but secure repositories to get access to. I'm almost a sort of professional of data access. I spend a lot of time doing it. Searchlight is one of the best. It's a very honest broker, but and fantastic.
And I should have said specifically for the blood sample case, if there are researchers that need blood samples, number one, the Simons Foundation has iPSCs, induced pluripotential stem cells. If there are blood samples you need for something else, certainly either let me know, let one of the Simons Searchlight folks know, and we'll try and be able to match you so that we can get what you need for your work.
Good. We're going to take a break now before the last session for 5 minutes. If your question didn't get answered, please do come and talk to people up afterwards. And clearly a lot of interest in the subject. We'll see you all in 5 minutes. Thank you. And thank you to our panelists.
Hello, hello. There we go. If everybody can find their seats, we're going to start the next session. For anybody who wasn't here first thing this morning, I'm Heather Olson, just be moderating here. We're going to start with another family story. We have Pam and I don't know your husband's name, Mac, with Lyanna, where they're going to tell their story. And then we're going to dive into a session on goals of care, kind of your priorities and thinking about discussions around trials. And so here we go.
How much lower do I have to bring the microphone?
Okay, good. No. There we go. All right. Hi, my name is Pam Weinstein. This is my husband, Mac, and my daughter, Lyanna. So Mac and I are college sweethearts. We met down the road at Northwestern. So we've lived in Boston for a very long time. He's a civil engineer. I'm a scientist, biologist by trade, and now I work in industry as a program manager. We're not really people who like phrase, I don't know. And we like to understand how things work, why they work, and what makes them tick. So Lyanna is our first kid, my only pregnancy. My water broke spontaneously because Lyanna does everything on her own schedule. We live in Massachusetts. She was born at our local community hospital. I was doing great. Everything was fine. And then all of a sudden, it wasn't. So at about 2.5 weeks old, Lyanna was transferred to Mass General because she was having issues breathing. Wasn't an issue with her breathing. We were introduced to so many specialists. They didn't know what was going on. And about an hour in, we met with neurology. They put an EEG on her head. And one of the residents came running in saying, "Oh, your kid is having seizures." So her seizures were subclinical. We never saw them. Still haven't seen them. So I get asked a lot of questions by some of the parents here saying, "Oh, is your kid's seizures under control?" And the best answer I got is, I think so. None of the medications worked. She wound up being on 8 different ones. So that's a lovely picture of her her IV tree, and it was right around Christmas. There was a lot going on. Eventually, she wound up being put in a pentobarbital coma and was in a coma for about 2.5 weeks. Everything had been fine for us. We were a happy family. And then we were very, very sad. And it got worse. So again, the doctors didn't know what was going on. We met with specialists. We met with different neurologists. They asked me to walk. They asked me to shake their hands. They wanted to know exactly what I did with my work, what might have been happening. There were no answers. They did an MRI when she was originally admitted to the hospital, and then another one at about 6 weeks old. And for those of you who aren't clinicians like myself, you can see that the corpus callosum down the middle of her brain sort of widened and her brain started to shrink. So right around Christmas of, Lyanna was 1.5 months old, we were told that she wouldn't reach her first birthday. We were devastated. And I think really the only reason that I can talk about this right now is because we talked with palliative care like daily for a very long time. We were in the NICU for 52 days and then we were sent home. It was an hour before we were sent home from the hospital that we found out she had an SCN2A mutation. Obviously, she's gain of function. We didn't care anymore. We didn't care that we knew the answer to the question because our question was different. Our question was, how do we have our child? How do we have a 2-month-old? Spoiler alert, we're not on hospice anymore. But that's what it was. We didn't care. So Lyanna's mutation, just one little amino acid, one little double bond that got changed to a single bond. People talk about their variant all the time, but you forget that it's just one little thing that's different. we didn't care about SCN2A at that point. I'm sorry for all the people in this room that we just didn't. We cared about different things. We made a bucket list of things that we wanted to do with our 2-month-old. We wanted to spend time with our family. We took her to the beach and she hated it. It was one of those rare 60 degrees in January days, and she was so mad because sand is coarse and it gets everywhere. We read lots of books and we took so many pictures, and eventually we got better at them. And then we came off of hospice in the middle of COVID when everyone was freaking out. But we were ecstatic. Our kid was going to reach her first birthday. But we said, now what? What happens now? And we realized it's the same, other than the fact that we wanted to find a community. We wanted to find people who understood, who knew what we were going through, who might be able to learn from what we did, or at least help. So this is my daughter now. She's 3.5. She has an SCN2A related disorder. She has epileptic encephalopathy. She had seizures. We still do yearly EEGs, but so far they've been good. She has CVI. She's nonverbal. She has global developmental delay, and she has cerebral palsy. Most of our problems currently are cerebral palsy related, but she's happy. And that's our biggest thing. She loves music. She loves to play. She loves being held by mom and dad. Today is a dad day. She really didn't want me this morning. She just wanted to play with daddy. For us, quality of life is the biggest thing, but we also care about you guys. We participate in clinical trials. We did the CTRS study earlier this year, and we did the EEG in Caitlin's group yesterday. Lyanna had the best time. She's on Vimpat and gabapentin for seizure control, but otherwise, people ask, everything's fine. We still read books. She loves anything that has music, so that's how we get her in our stander. And honestly, we're trying to get her to go to the beach because that was a big thing for me, but she still doesn't like it. So for us, we just try to live every day and make sure that she's happy and we're happy, and that's our story.
Thank you so much for sharing that beautiful story. So our next presenter is Dr. Brittany Kelly from Massachusetts General Hospital, who's a specialist in palliative care. Come on up, and we're going to talk about what are your goals for your loved one's care. I have to figure out how to get your slides. There we go. Thank you.
Can everybody hear me? Okay, so she just gave me aspirations. I am a nurse practitioner, but maybe one day a doctor. So thank you all for inviting me today to talk with you a little bit about pediatric palliative care and how I think it may be able to help support you all and your children. So to begin, introduction and disclosure. So as I said, I am a pediatric nurse practitioner with training in palliative and hospice care. And I work at Massachusetts General Hospital for Children. And I have also worked in the community with the Community Pediatric Palliative Care Network of Massachusetts, which we'll talk a little bit about. And other disclosures, no financial disclosures, but I am also a parent. So I think I bring a little bit of that with me today as a parent, and having that mindset as well about what do parents think about when they are facing uncertainty with their children. So my objectives, spoiler alert, this will not be a neurogenetics talk. My objectives are pretty simple. It's that you leave here with maybe a little enhanced understanding regarding what pediatric palliative care is and what it isn't, so that you can understand how to reach out to local teams in your community so that they can support you if you're interested in that. And then possibly how to apply some tenets or philosophies of palliative care when you're considering different medical interventions and specifically clinical trials. So what It is. It is an interdisciplinary approach to care. So when I say that, I mean, it will look different. Every facility or team is resourced differently, but ideally it is bringing different lenses and perspectives, different areas of expertise to the table to support a child and a family. So typically physician staff, nurses or nurse practitioners, social workers, child life specialists, music therapists, and I work in an inpatient consultative team. So we also work with the other allied health professionals in the hospital. So speech language, pathology, OT, PT, et cetera. This is, as I mentioned, I work in the hospital, but here in Massachusetts, we're very fortunate to also have a pretty robust community-based pediatric palliative care network. State by state, this varies, but often these are the two modalities that you're going to access pediatric palliative care teams in hospital or in the community. We take a holistic, whole person approach. So you have lots of subspecialists. You have people who are thinking about the kidneys, thinking about the liver, thinking about the brain. We kind of step back with you and think about your child as a full individual. What is the big picture and how do all of these subspecialists and networks interplay and interconnect? And how does that result in the best level of care for you as a family and your child? Similarly, we take a patient and family-centered approach. So we partner with you, we collaborate with you. We try to basically help you make the most of your child's care. And we have additional training on communication and symptom management, particularly symptoms that affect our patient population the most. So pain, dyspnea, trouble breathing, nausea, et cetera. And really one of the pieces I really want to drive home is that we support families, children and families at any stage in their disease diagnosis, regardless of what treatments, interventions, parents and families elect for or elect to forego. We are here to support you regardless of that. So at any point in a child's diagnosis or disease process, it's never really too early and it's never really too late. And we really focus on what Pam told us about, the quality of life of a child and their family, and how do they live each day to the best of their ability. And really, we try to amplify the parent voice. So in the hospital, when you have a 52-day stay in the NICU and you're seeing lots of subspecialist providers, it's exhausting, and you can be incredible advocates as Pam and Mac were and continue to be. And it helps to have another provider, another team that can just amplify your voice, that can say, this is what I'm hearing is most important to the family right now, or most worrisome to the family right now. Can we keep this at the center, or can we circle back to address these things, amplifying the family voice? So what it's not, we often hear they're not there yet, or, we're not there yet. They still want to pursue X, Y, or Z. This is not giving up. This is not saying no to any treatment or intervention. This is not doing nothing. This is actually doing everything. This is actually focusing on how do we reinvigorate this child and this family's life, and what do we have to offer that actually matches and supports that. So it's discernment. It's not doing nothing. There is no obligation to forego anything in order to have pediatric palliative care supporting your child and your family. Hastening death, I think this is a huge concern that we hear from families, that their child's lifespan may be limited. Much of the data that we have in pediatrics is actually based on adult data, but there is a very robust amount of literature about how early adoption of palliative care can not only, in looking at the literature, not only helps improve the quality of life of patients as they report it, not only reduces depressive symptoms, but also actually with enhanced end-of-life care, there's still a longer median survival of life. So this is certainly not hastening death in any way. Oftentimes families think, well, my child doesn't have cancer, so we can't access that. That is also not true. We support a number of children with wide variety of diseases and conditions, and actually chromosomal and genetic conditions are one of the largest pool of patients that we serve and support. So what it may look like. We primarily are involved to support the patient and the family, but we also get involved to help support providers. We often will be asked, can you find out what the parents' goals of care are? And this coded language that means basically nothing to families really is getting down to what is most important to this family? What are they hoping for? What are they most worried about? And we go in and we assess that, because until we understand what a family's goals are, we really can't provide medical recommendations that are informed. We can tell them what options there are or what treatment therapies there are, but in order to really provide an informed recommendation, we should understand what is it that's most important to them? What is it that worries them the most? So that's a lot of what we do. You'll see that we also do a lot of other things. So we will provide symptom management support. We will provide continuity of care, frequent hospitalizations. We try to check in when patients and families have repeat hospitalizations, be the familiar face, be the people who know how to kind of smooth the rough edges of those admissions. Focusing on quality of life, helping support the family when there are gaps in what they're hearing from their providers. Do we need to review things? Do we need to try to reach out to different experts or specialists to get more or different information? And then we also focus on all the other aspects of life. Are there siblings involved? How do we support them? Is your faith really important? And we're just not actually integrating that into your care, thinking about how we can bring all of these pieces together. So what it may sound like, these are just examples of some of the questions. We are a team that comes in and asks lots and lots of questions, and it's so that we can get to know you. So tell me what about your child and what they enjoy. What have you heard from your teams, your child's teams or others about their disease, treatment options? We help support medical decision-making. I'm not going to read all of them, but this is just a little bit. What has been most challenging for you and your family during this experience? Do you think your child is comfortable? And if not, what are you noticing? So that, again, we as providers can take on a similar lens and perspective. If you know that your child always does X, Y, and Z when they're uncomfortable, we want to know that so that when we notice those things, we act and intervene in the way that you would hope or that you would do yourself, right? So now that you've heard a bit from me on what I think it is and what I think it isn't, hopefully this will work and you will hear a parent perspective. There's no sound. Oop. Anybody know how to make the sound work?
So before doing this, I had no idea what the care was. So and she said, you know, it's not necessarily more child that it's going to be constantly today. You know, utilize the resources definitely for families and a huge disease that is her whole life. And it just kind of helps keep a good quality of life going. We're not necessarily doing end of life care now, it's just making sure her quality of life is where we want it to be. I think that's really what care has done for us, care has done for us, making sure that every day our mission is to reach out, whether that's 5 years, 12 years, 20 years, but every day is we're making sure that she works to her best level, her best potential.
So that's a little bit of the parent perspective and the parent voice. And now I just want to share a little bit about the why. So why is it important to ask these questions? I imagine the parents in the audience may not need much convincing, but this is based off of a work that Chris Feutner and others published in JAMA in 2015. And essentially this is in asking parents what they need in order to feel like they were a good parent to their child. What are the things that are most important? And just some of these pieces that they cite: making sure my child feels loved, focusing on my child's health, making informed medical decisions, focusing on my child's comfort, my child's quality of life, staying at my child's side. The why is, if we don't ask, we don't know. And if we don't listen, we can't help. So this is the crux of palliative care in my mind, is we ask these questions so that we can help better inform the care that we provide for our children and our families. Now, how do you access palliative care, since I've pitched it so hard? I will breeze through these, but essentially, this is a graph from the Center to Advance Palliative Care, essentially a report card in 2019. And what this depicts, on the left, you'll see Massachusetts, in the middle, New England, and on the right, it's national data. And dark blue depicts urban, light blue is suburban, and the orange is rural. And basically what this says is, if you're in Massachusetts, you're going to have access to palliative care. If you're in different parts of the country, it may be more challenging to access palliative care. So I want to try to help you identify what your local options are. So again, hospital-based and community-based, these are going to be the ways to access palliative care, pediatric palliative care, the easiest. You can use getpalliativecare.org, the one on the bottom left, to essentially use a provider directory to look it up. What's closest to me, and then of those, which are the pediatric options. You can also use PPCC-PA, this is the Pediatric Palliative Care Coalition, to identify if there's a pediatric palliative care coalition in your state. Now, in order to set us up for what Dr. Ludwig is going to talk about a bit further, how do you use this framework when you're considering different medical interventions and specifically clinical trials? So this is how we support our families when they're weighing out medical decision making. We talk with them about what are the potential risks, and talking with the provider, the researcher that you're working with, saying, what are the potential risks of this study? What are the potential benefits? Are there trade-offs that we have in our mind as parents or caregivers? For example, will all of this travel back and forth out of state, maybe more time in the hospital this year? Will it be worth it if it means better days or more time with my child? Are these the trade-offs that we're thinking about? If you were to be part of a placebo or control arm, would that be acceptable, going through all of this and not necessarily receiving that intervention? Does that change how you think of it? A framework we use a lot is best case, worst case, most likely. And this is something you can ask the researcher or your specialists who are providing care to your child. In my child's actual situation, my child, my N of 1, what do you think is going to be the best case if I pursue this trial, the worst case? And if you can say, what do you think would be the most likely outcome? And similarly, if we don't pursue it, best case, worst case, most likely. And this can kind of get you in the headspace of thinking about each of these scenarios. Next is the logistics. There's a lot of logistics that come into play. What state is the study in? How many blood draws, how much hospital time, how many images is my child going to have to go through, and how does my child tolerate all of this? How does my family endure this? What will that mean for childcare, for the cost of all of this? All of these pieces are, for better or for worse, variables that our families have to consider when they're thinking about these things. So we try to support them as they're basically just fanning through all of these pieces and saying, what's the best option for us as a family? And then ask and advocate initially, and then over and over and over again, and utilize your pediatric palliative care team to support you in doing so. I just want to plug 2 important resources before I hand it off. So Courageous Parents Network, if this is a website that you're not familiar with, I would encourage you to check it out. It was actually started by a bereaved parent of a child who had Tay-Sachs, and it has huge video library of parents and caregivers and clinicians kind of sharing, but mainly I watch it for the parent experience, talking about their journey with their child, receiving a diagnosis, weighing through options and interventions, how they think about this, how they navigate this care. It also has guides and blogs and lots of other wonderful resources. So I would check that out. And then if you are in Massachusetts and not supported by a community palliative care team, the Mass PPCN, Pediatric Palliative Care Network, could be an option for you. And actually parents can self-refer. Thank you.
All right. Thank you so much, Brittany. That was excellent. And I love my palliative care colleagues. They've really come and helped our families a lot. So talk to people who have had good experiences, and I encourage it. So now we're going to hear from Natasha Ludwig, who's done some excellent research on what does better look like in SCN2A, collaborating with Jenny Downs from the Telethon Kids Network, and she's from Kennedy Krieger. So welcome.
All right. Hi, everyone. So my name is Natasha Ludwig, and I'm a pediatric neuropsychologist at Kennedy Krieger. And I work with a lot of patients with SCN2A, and I'm involved in research in this space as well. And I'm so excited to be here today to talk to you a little bit about a little research study that we did from data we collected last year at the conference from 10 kiddos with SCN2A. So very grateful for your participation. We're excited to share some of the preliminary findings. So I'm going to talk about how family goals may inform clinical trial participation. And this is really the brainchild of Dr. Jenny Downs from Telethon Kids in Australia. But we all work together through the Inchstone Project, which is a collaboration of patient advocates, researchers, clinicians, and industry partners. We're all working together to develop clinical outcome measures to capture changes in development and functional abilities for children who are most severely affected with developmental and epileptic encephalopathies. And so that includes SCN2A. So this is a wonderful collaboration. And as I mentioned last year at this conference, we worked together with families SCN2A who supported us in collecting some data on these children. We did some really deep phenotyping. We did qualitative interviews. So it was just a great project. So let's talk a little bit about change in health status and functioning. We all can experience changes, right, in our health and functioning. For kids with SCN2A, this can occur in many aspects of health and function. So for example, in their epilepsy status, in their sleep quality, pain, in their development, right? Like communication, gross motor skills, and changes can be positive or negative, right? It's really important to detect changes because this can inform clinical care and clinical decision-making, right? So when to intervene when there's been a decline, when are the therapies that we're trying out effective, right? Are they changed? Is the child changing in some way? Are they getting better or are they getting worse, right? Also in a research context, it's important to detect change. So when we think about natural history studies, so that means, collecting information about various aspects of health, development over the life course of children with SCN2A, so you can start to learn about them and what they look like, right? It's important to look at that data and be able to know, like, when is change happening, over the course, the life course. And then also effectiveness of interventions in the context of clinical trials, right? That's really important to be able to detect change in response to a novel drug. But how do we know whether a change is truly meaningful, right? Statistics can tell us if there's a statistically significant difference, right, in a score on some measure of health. But is that statistical difference truly meaningful? So I'm going to talk about this concept of minimum meaningful change, or really the smallest difference viewed as meaningful by the patient or the caregiver and family, right? This term, there's actually a couple of other terms used to describe this same concept. You may have heard of MCID, or minimal clinically important difference. So there's a lot of different terms that get at this concept. There's really been no consensus quite yet on which term to use. So I'm going to call it minimal meaningful change for this presentation. All right. There we go. So clinical outcome assessments. So as I mentioned, the Instrom project, we're developing clinical outcome assessments, and these really measure something important to families. So things like seizures, pain, and in the context of Instrom project, we're really interested in development and functional abilities. And these tools yield a score, right? And so in the context of these clinical outcome assessments, we need to start to understand, like, what does meaningful change look like on these tests, right? Or on these measures that we're giving and that we're developing. So some questions that we have are, does meaningful change vary by child functioning level? So those most severe versus maybe a little bit less severe versus more higher functioning. Does meaningful change, or that magnitude of change over time, differ by child status? Does meaningful change vary by the risks associated with the treatment, right? And then also, why are these changes considered meaningful, right? Like, what kind of impact do they have on the patient and family? These are all really important things to start to consider as we're kind of refining these tools, and also as we're starting to look at the impact of interventions. And so we can use some qualitative methods to start to answer these questions. And so, as I mentioned, we collected some data last conference. We ran a pilot study. And so part of that pilot study was to conduct some qualitative research to start to answer these questions. So we explored how parents of children with SCN2A related disorders describe minimally important differences in developmental and functional skills for different clinical trial scenarios. So we asked about, a small molecule trial, and then also a gene therapy trial where the risks may be greater. All right, so we collected data on 10 children. So we had 8 males, 2 females. And as it kind of shook out, we had 4 kids in our group who were considered relatively more severe. These kids could not walk independently. They had minimal hand use. They didn't use spoken language. And then we had a relatively less severe group. So these children walked independently. They had some hand function, but they were nonverbal. They did not use words. And we conducted family interviews. Usually it was moms who participated, but we also had fathers participate as well. So what we did was we conducted these qualitative interviews, and we asked a series of questions, but really at the core of what we were asking were 2 main questions. The first one was, what difference in function would be just enough for you to enter a small molecule trial? The second question was, what difference in function would be just enough for you to enter a gene therapy trial where the risks could be greater? And we asked this question across 4 different domains. So gross motor functioning, fine motor functioning, communication, and activities of daily living. Okay, so this is a really complex but quite beautiful slide. This is Jenny's slide that she developed that really shows the results of our interviews. Okay, so I can tell you kind of some of the main points from this graphic here. What we found is that children who were relatively the higher functioning group had a bit more skill. Their parents wanted to see a greater magnitude of change really across the different areas that we asked about across the board. Whereas the kids in the more severely affected group, parents were looking for maybe smaller magnitude of change within more basic or early functioning skills. The other big takeaway from this is, remember we asked about differences for the small molecule trial and then also the gene therapy trial where the risks might be greater. And the general trend we saw is that parents across the board, when the risks were higher for that gene therapy trial, they were wanting to see a greater magnitude of change compared to what they were wanting to see, in that small molecule trial. Then we started to think about, what were the reasons that parents were telling us about, why they wanted to see, these skills change. And we felt like this was really, really important. So 2 kind of main themes emerged. One was child related and one was more parent related to taking care of their child. So the first being child related. Parents really wanted to see their child build these skills to build their child's quality of life. So for example, one parent said, I would really like for my child to be able to have better head control so they could be able to hold their head up and be at eye level with their peers so they could get more social interaction, right? Another example that was an example from the relatively more severe group. An example from the relatively higher group is, I would love for my child to be able to walk more smoothly. And the reason for that being so they would feel more confident across different kind of environments, right? So on a carpet versus a road, that might be a little bit uneven. So I think that was pretty interesting. And also, again, that second category or that second theme that emerged was more related to how parents were able to care and support for their child. So one parent said, I would want to see my child be able to bear weight through their legs so that they could assist a bit more with transfers. Okay. And then some families also, part of their why in terms of their gross motor function was, and this was in the kind of relatively higher functioning group, they wanted to see some of the gross and fine motor changes so their child could participate with some chores, around the house and be a part of that family community, right? So I think, the main takeaways from this pilot project were, in terms of meaningful change, child severity matters, right? So if a child has less severe impairments, maybe parents are going to want to see a bigger change in function to participate in a clinical trial versus, if a child is more severe, they may be okay with smaller but meaningful changes for them, right? And their child and their family. And I think this idea of considering, why are these changes meaningful for that family gives us some really important information about what's important to families and what we need to be measuring to begin with as well, right? And I think the other kind of interesting and really novel concept is this idea of that risk level really matters to parents when they're thinking about meaningful changes that they would accept, right? So, right now that level of risk isn't really incorporated into FDA guidances about what meaningful change really is. So FDA regulates, the approval of novel drugs, right? And they don't really talk about that level of risk being that should be incorporated into this concept of meaningful change. So I think that this is something we really need to start thinking about. It's clearly very important. And I think we need to think about ways to incorporate that into this concept of meaningful change. And so our future directions for this work, we want to get a larger sample. We want to look at this by different ages, meaningful change in relation to different variants and different comorbidities, right? There's likely going to be differences across these different groups. We want to be able to map what does meaningful change look like on some of our general standardized developmental assessments that we use commonly. And also as part of the Inchstone project, we really want to start to think about and also the family's SCN2A clinical trial readiness study, we want to make sure that the measures that we're developing and that we're using have items that are really relevant, that are important to families. We're learning a lot about what's important to families through this work and through some other work that we're doing through the Inchstone project. So this is like one of my most important slides, I think. So if you take a photo of any of my slides, this one should be it, because this is about a new study that we've just recently launched, and we would love for you guys to participate in. So this study is a caregiver study where we're basically trying to find out, what really matters to families, what is important to you and your child. And so if you look, there's a flyer there. If you go to that QR code, it'll take you to information about how to complete the survey. But we're really, really wanting to learn from you about what's important to measure and what meaningful change looks like. So we just launched the study, and our goal is to get to 200 families. Right now we have about 31, so we have some preliminary data I can share with you. Two of the questions we ask is, how do you know your child's having a good day? What does that look like, right? And a lot of by the way, sorry, I should have said this earlier, but this is across neurogenetic conditions. So it's a sample of pretty severely affected kids, but it's across multiple neurogenetic conditions. And so far we have 3 kids with SCN2A included in this. So that's why I'm kind of like rallying and trying to promote this, because if we get to 20 kids with SCN2A, we'll be able to share and kind of aggregate that data and share it all back with you guys, so you can see how your community, what as a group, kind of what you guys care about. And so one of the questions we ask is, how do you know your child's having a good day? And a lot of families said things like, well, when my child's laughing and when my child's smiling, and also when they're engaged and when they're interactive. And then we also asked, how do you know when your child's having a bad day? And a lot of families said things like, oh, my child's crying, or mood is irritable, or they're screaming, or they're sleeping a lot, they're lethargic, they're not engaged, right? And so we're starting to learn a lot from these families. That's in this information is just so crucial to our research. So we're really excited that we've kind of pushed this out, and we really hope to get more participants. So, and hopefully next year we'll be able to share some data at the conference about this. So. Thank you so much for listening. Just wanted to say thank you to my colleagues at the Inchstone Project, especially Jenny Downs. This is really, her brainchild, as I mentioned. And so thank you all for listening. And for those who have participated with the Inchstone Project or who are involved in some way, we just thank you so much. So thank you.
So who's ready to go back home to your local neurologist and advocate for these awesome conversations and have a conversation with them about whether or not to participate in a clinical trial? Feel empowered? Good. We're going to hammer it home just a little bit more, and we're going to do a skit. This is our last thing today, and we really hope you enjoy it. We have an actress, Zafir, and we have Sean, who didn't have a choice.
I drew the small straw.
It was like pulling teeth to get anyone to do this. I asked Kevin, and Kevin gave me 4 other people's names, and they all said no. So we really appreciate you guys. They're going to talk about, Sean's going to play the doctor, Zafir's going to play the caregiver, and they're going to have conversation about whether to participate in a clinical trial.
I was hoping I was just going to get a white jacket.
Testing. Okay. Thank you for meeting with us, Dr. Hauser. We'd like to discuss the potential of clinical trials for Joseph. Can you help us think through whether this is an appropriate option for us?
Absolutely. Happy to help. Maybe before we discuss any particular clinical trials, it might be a good idea to discuss what your goals are for Joseph. Can you help us this can help us not only with our discussion around clinical trials, but also help guide his care in general going forward. Maybe let's start by talking about Joseph's current situation and where you envision his future.
Well, Joseph's been doing pretty well of late. He seems to have, at least for the time being, gotten through that really rough patch where we lived at the hospital and he was in so much discomfort with the dystonia and seizures. This new treatment regimen has helped calm things down a lot. The dystonia has been much more mild and seizures are down to 1 every few days. And he seems to be laughing. Sorry, that was me, go ahead. He seems to be laughing quite a bit more, which is great. And his teachers at school have indicated that they've seen some real progress in a few areas over the past 2 months. It's hard at this point because he's doing a bit better and we'd like to really try to keep pushing forward and see if we can find some additional gains. We want to really make sure he's getting the best possible quality of life. And if there are areas where he can gain some level of independence, we want to try for that. Also, we really love these smiles and don't want to lose them. It means so much to us to see him more engaged in things that are bringing him happiness.
It's wonderful that he's been doing so much better and is taking some meaningful steps forward. So maybe just to recap, Joseph's finally in a stable spot after a serious period of acuity. And his family wants to ensure that he has the best quality of life and best quality development as possible. Seeing him engaged emotionally is a very important milestone for your family. When considering how aggressive to be therapeutically, has your family considered what a meaningful improvement would look like?
I guess it would be continued stability and development for him.
That's a really good goal and a good benchmark. Have you considered what you're willing to risk when you're trying these new approaches?
Risk? What do you mean risk? I think we're willing to try new things. We want the best for him.
Of course. Things to consider are the stability that he currently has in those smiles and the development you're making. That is stability both for Joseph and for your family. And it's also fairly newfound. It's important to consider that he's making these positive progress right now. And while a new therapy has the potential to accelerate these benefits further, they're not guaranteed. And there are some risks of side effects.
What types of side effects?
Very often there are no side effects or they're minimal. And in clinical trials, Joseph would be monitored closely for anything serious. But clinical trials are times when medications are still being tested and there's still some small risk of a serious side effect or even death. The risk reward should be carefully considered by each family and also appreciate that these may change over time. Earlier in the year when you guys were constantly in and out of the hospital and things were very unstable, the risk reward is likely to be a lot different than it is right now.
I see. You've given us a lot to think about. Joseph is finally in a good spot, and I don't know if we're quite ready to risk that.
One thing to also consider that risk reward can change independently of Joseph. As trials progress and more data is gathered, the potential benefits may prove to be very high and the risk could end up being very low. And that may change the equation as time goes on. Starting these conversations now and knowing that your family is interested in clinical trials means that we can continue to have the discussion. So maybe we'll pause there. And this was a scenario where, maybe clinical trials weren't right for that family and their personal prerogative and their personal values. We're going to go through another scenario that's, very similar setup, but has a different outcome. And that outcome is dependent on the family's different values. So we'll restart again. They'll sound a little familiar at first.
Thank you for meeting with us, Dr. Hauser. We'd like to discuss the potential of clinical trials for Joseph. Can you help us think through whether this is an appropriate option for us?
Absolutely. Happy to help. Maybe before we discuss any particular clinical trials, it'd be good to discuss what your goals of care are for Joseph. This can help us not only with our discussion about clinical trials, but also help guide his general care going forward. Let's start by talking about Joseph's current situation and what you envision for his future.
Well, Joseph's been doing pretty well of late. He seems to have, at least for the time being, gotten through that really rough patch where we lived at the hospital and he was in so much discomfort with the dystonia and seizures. This new treatment regimen has helped him calm things down a lot. And dystonia has been much more mild and the seizures are down to 1 every few days. And he seems to be laughing quite a bit more, which is great. And his teachers at school have indicated that they have seen real progress in a few areas over the past 2 months. It's hard at this point because he's doing a bit better and we'd like to really keep pushing forward to see if we can find some additional gains. We want to really make sure he's getting the best possible quality of life. And if there are areas where he can gain some level of independence, we want to try for that. Also, we really love these smiles and don't want to lose them. It means so much to us to see him more engaged in things that bring him happiness.
That's wonderful. That he's been doing so much better and taking some meaningful steps forward. So maybe to recap, Joseph is finally in a stable spot after a period of serious acuity. His family wants to ensure that he has the best quality of life and development as possible. Seeing him engaged emotionally is an important milestone for your family. When considering how aggressive to be therapeutically, does your family consider what a meaningful improvement would look like?
I guess it would be continued stability and development for him.
That's a good goal and benchmark. Have you considered what you're willing to risk while trying new approaches?
Risk? What do you mean risk? I think we're willing to try new things. We do want what's best for him.
Of course, things to consider are the stability that you guys have recently encountered, those smiles and the development you're making, the stability both for Joseph and your family. And it's also fairly newfound. It's important to consider that he's making these positive progress right now. And while a new therapy has the potential to accelerate these, they're not guaranteed, and there are some risks of side effects.
What types of side effects?
Very often there are no side effects or they're very minimal. And in clinical trials, Joseph would be monitored closely for anything serious. But clinical trials are times where medications are still being tested, and there are some small risks of serious side effects or death. The risk reward should be carefully considered by each family, and also appreciate that these may change over time. Earlier in the year, when you guys were constantly in and out of the hospital and things were unstable, the risk reward is likely a lot different than it is right now.
Thank you for that information. While Joseph has improved a lot from where we were a few months ago, he's still profoundly impacted by his condition. His baseline risks, even when stable, is still incredibly high, and it's likely only a matter of time before we're back in acute state. We see time as critical, and we are willing to risk the relatively stability for now, for an opportunity for something better. From what we have read regarding some of the new medications in development, they're designed specifically for SCN2A and have the potential to be much more effective, maybe even transformative. Furthermore, these trials are important, and we learn a lot about SCN2A, and them and our participation is critical to continue to advance the field. No child should have to suffer the way Joseph has, and if we can help with the cause, it's important to us.
Thank you for sharing your family's perspective and your nuanced view on Joseph's goals of care. Maybe let me rephrase your goals. Joseph's finally in a stable spot after a period of serious acuity. His family wants to ensure that he has the best quality of life and best development as possible. Seeing him engaged emotionally is a really important milestone for your family. However, your family still believes Joseph's relative risk is still pretty high, and you also believe that the risk reward supports clinical trial enrollment. Pursuing opportunities for a better therapy and contributing to research are priorities for your family. Does that seem to capture your family's current goals?
Yes, I think that frames it well.
All right, we'll pause there. So I mean, this was just a good example that, you know, us as caregivers have the power and freedom to have real conversations with our clinicians. I think often when we're new to this environment with a really sick child, you talk to your clinician and they give you guidance, and, you know, they're respected professionals, and you kind of take that and follow it. But we as caregivers have, you know, a lot of power in making those decisions for what's right for your family values. And those can be different for everybody in the audience, depending on your personal values and your family values.
I could have the speakers back up. We'll just have a few questions and answers. Thank you for the session. That was really insightful. Is Christelle here? There you are. Come on. Christelle Ashkar is another member of our epilepsy genetics team at Boston Children's. We just wanted to be available for as clinicians who do clinical trials. And if there's anybody else out there who wants to join us, come on up. To start with, I will ask, as we're gathering questions here, how do you guys think about for clinical trials? Certainly there's risks and benefits in weighing that ratio, but the known versus the unknown risks of a clinical trial with something investigational, there are unknowns.
I have to ask you to repeat. We were moving the chairs.
Oh, sure. So in a clinical trial, how would you think about and discussing with families for a clinical trial, both the known risks as well as the unknown risks? Because with anything investigational, there may be unknown risks.
This is a very good question. I think the first rule is that you need to be as transparent and as possible. Not every single clinician or neurologist knows exactly what the trial is about and whether your patient is an adequate candidate for that trial or not. And so that's the first rule. If you feel like you need to refer your patient to a specialist, you start with that. The next rule is to review the trial protocol or any information that you have very, very carefully with your patient. If you still have questions about it, refer back to the pharmaceutical company or to the scientific group that is conducting this trial in order to have all of the information at hand. The third thing I want to say is that nothing is risk-free. even though we do our best to measure blood levels and do brain imaging when needed, with many drug trials, there will be unexpected, potentially unexplained side effects that sometimes can be dangerous. And that's unfortunately a risk we have to be very frank about. But I think this, what you actually mentioned in terms of the level of improvement that you would agree to, that you would, potentially agree to go on a drug trial for, that I think is a fantastic model and a fantastic way to discuss this with your patient. So I'm gonna pass my microphone to you if you have anything to add to that. Or have your
testing. Oh, it works. I mean, I would agree. I mean, I'm a psychologist, so I don't have these conversations with families, but, I am involved in this work, and, we have talked about this. We've talked about these data at a few other conferences, and it has come up before where people have said, I don't think you're supposed to think about the level of risk when you're thinking about minimal clinically important difference. That's just not how we've been taught. That's not how it says, you should be thinking about it in the FDA guidances. But I remember one time you were on a panel, right? And you're like, absolutely, we should be considering, level of risk when we're thinking about minimally important change. And I totally agree with that. And so I think these data are teaching us, and parents are teaching us that we really need to be like switching our mindset around that. So I'm all for that.
I think as far as gauging how much unknown risk there is, you want to look at, were there similar drugs in trials in similar populations? What is the mechanism? That kind of thing, but just something to think about. Okay. So for Natasha, was there a difference in the ages in the non-ambulatory and ambulatory groups?
That's a great question. I don't know off the top of my head, but I can get the answer. Who's ever interested in that, you can just email me.
Sounds good. And for Brittany, what are the differences between pediatric palliative care and complex care coordination? And we can help with this too, but.
Can everybody hear me? That's a great question. If it were a Venn diagram, there's a lot of overlap. So essentially, we often work with, again, hospital-based perspective, but we often work with outpatient and inpatient complex care teams or coordinated care teams, because the vast majority of our children are inherently medically complex. So part of what we do is act as continuity of care and act as care coordinators at times when we're trying to bring all of the various subspecialists and allied health professionals, therapists together in order to enhance the care of our children. So I would say we are typically different teams, but we collaborate and often have a significant overlap in the population and the specific children that we work with and care for. Hopefully that answered your question.
And I don't know if this is the same everywhere, but at least at our hospital, the complex care service is a high-level pediatric service that has an in-person clinic appointments that sort of partners with your primary pediatrician, whereas palliative care tends to more join the conversations or do consults as inpatient. So it's a slightly different model approach, but.
Yes, and for smaller hospitals, such as MGH or even community hospitals that might have more limited pediatric palliative care, we, as she shared, we are a consultative service, but if that team is kind of lacking on the inpatient environment, we sometimes will, we often will liaise with the outpatient complex care or coordinated care service in order to kind of act as continuity between the inpatient and outpatient environments.
Great. And I think palliative care has a little bit more range depending on the setup too, as far as in situations where you can't get in for visits as much, having community-based services and supporting in that environment. Okay, in a non-communicative, non-verbal, poor, absent, or other communication abilities child, how do you assess and treat pain? It's a hard, great question.
Can you say that again? I'm sorry, I didn't hear.
So for a non-communicating patient, how do we assess and treat pain? I'm happy to address it too. I don't know if you want to.
I was gonna say, I
Say
think
anything,
we
Brittany?
probably all have some thoughts, but I think usually we think of, there are individual rating scales that we have where actually the parent caregiver will outline to us what pain behaviors are or versus various levels of discomfort, for instance. So just like we have for some children, a kind of facial pain rating scale for our atypically communicating patients who may manifest different behaviors as signs and indications of irritability versus discomfort versus severe pain. We utilize kind of an individual pain rating scale as dictated and determined and guided by the caregivers. And then we try to distribute that in a child's medical record or in the outpatient care service. We try to have that as continuity so that we can essentially use your lens and your perspective to guide the way that we respond and manage, because that is going to look different in children that have different comorbidities and conditions.
Yeah, and the person who asked the question, sorry, I'll let you address too, but said poor or absent communication. And I think as with all of you, we use what communication they have, which can be simple but meaningful. And we take a head to toe approach and just really be systematic and looking for potential sources of pain. Whether or not we find one right away, we keep at it and we work with you step by step to try to get that individual in a better place.
I agree with both. I think part of, we try to use as many objective measurements as we can, looking at difference in vital signs, body language, any tone changes. And that's the one area, I don't know if Dr. Millichap is still here, but that's the one area where I ask to see my patients in person so that I can do a full exam to look for any sources of pain that we might be missing because our child cannot tell us what's hurting.
I have a question. Do you guys use physiological measures, heart rate, those sorts of things?
We use them more or less of, in terms of any differences. I do know, however, that there is some research that's ongoing to use like different autonomic measures, more specifically in ICUs. I think these are still in the research phase, but I think you can potentially use like, transduction or things like that from the skin to kind of assess, additional level of discomfort. We're not there yet. I have to say the palliative care team are my best friends. And I think Heather said the same to help understand, I think where I really feel as a neurologist, I have not really cracked the question is this question of neuroirritability and what do we do about it, because it can look like pain, but there is really no clear source of pain. And so we do need, I think that's a great question. We do need more objective measures to figure out what's going on.
So you're now empowered to ask for support from palliative or complex care, and don't be upset if your physician actually suggests, I may suggest and actually ask my colleagues to join me for a visit so that we can really talk about goals of care. And I would also encourage you to bring those principles into your visits with your other physicians as well. So I like to always make sure I align with families and understanding and reassessing from time to time, where are those goals? And I mentioned to Sean the other day too, but we have some practical limitations in our clinic. So if you feel like you need an in-depth and more prolonged discussion, ask for extra time because we don't always have it built in otherwise, and we want to respect you and your time. So I will offer it over to Leah.
Thank you.
Thank you guys so much. So we're running a little bit late. So I'm going to ask you just to leave everything here. Everyone's waiting for us to take the picture. So just come back and get your stuff after. Head straight out the doors to the left, past these stairs and down that long hallway, and you will see the group. And one last thing, do not miss the 5 o'clock bus. Let's go.
Thank you for joining us, and we'll see you tomorrow.